yesterday during the day, and of course at night we had big night as always, and people were awake singing, dancing till 12. So without any further delay, I would request my Master of Ceremony to start the session.
Good morning, respected faculty members and all delegates. The first session we start with, I call upon the chairpersons, Dr. G.D. Tiwari sir, Senior Physician in Bhopal, Dr. Ramesh Bhargav sir, Senior Physician in Bhopal, Dr. Ashok Tiwari sir, Senior Physician in Bhopal. The topic for the first session is acute watery diarrhea, algorithmic approach, for which I call the speaker Dr. Deven Singh sir, Senior Consultant Gastroenterologist from Apollo Hospital, Bilaspur.
With permission of chair, may I start, sir? Yeah. Yes. Yes. Good morning, everyone. At the beginning, I must compliment Dr. Sanjay Kumar and his team for the wonderful show that they have put up. Everything has been wonderful. The academic sessions of yesterday, the big night, and today morning's Pilates session was equally good. So I've been interested to speak on acute diarrhea algorithmic approach. And in this 8 minutes, I'll try to be as crisp as possible. Not moving. चलो मैं यहीं से कर लेता हूँ. It's not working. Well, acute diarrhea has troubled the mankind since very, very early days. And the definitions being more than 3 stools, liquid or loose per day is diarrhea. It's acute if it is less than 2 weeks duration, persistent if it is between 2 to 4 weeks, and chronic if it goes beyond 4. More than 90% is caused by infectious agents. Remaining 10% could be either medications, toxic injections, and rarely because of ischemia. Well, as per WHO, of the majority infectious agents, rotavirus is the most common agent which is implicated, but more so in children. Among adults, it is either Shigella, typhoid, E. coli, and cholera in that order. It has been a global health issue, and of all the total 10 to 12, rather 100 to 110 billion people so far who have walked on this earth, Mother Earth, 10 to 12 billion may have died because of diarrhea as per one of the estimates. Even the Indian numbers have also been very bad. Under 5 population has about 15% incidence, and sadly about 5,000 deaths due to diarrhea are happening every day, 200 per hour, and every minute 3 people are dying because of diarrhea. And the deaths were mostly due to dehydration till a gentleman changed the scenario. I'll come to him later on. But the good part is more than 90% are actually preventable. Clinical evaluation involves history, which is very key. Onset, frequency, stool volume, all should be asked. Recent history of travel, contaminated food, antibiotic uses. We must look for whether the host is immunocompromised, if there are associated vomiting or fever. But we must keep looking for the red flag signs in form of severe dehydration, hypotension, persistent vomiting, altered mental status, or if the patient is elderly. But we must look for some clues from history, like symptoms that begin within 6 hours of ingesting something are usually because of preformed toxin of either Staphylococcus aureus or Bacillus cereus. Symptoms that begin 8 to 16 hours later suggest infection with Clostridium perfringens. Symptoms that begin at more than 16 hours can result from viral or bacterial infection. Could be because of contamination of food with enterotoxigenic or enterohemorrhagic E. coli. But we must also take clue of whether patient has been on antibiotics. Well, most cases are self-limiting, but some will require investigations, particularly the one who has severe disease. Diarrhea is prolonged beyond 3 to 5 days, host is immunocompromised, or you are suspecting an outbreak, patient is hospitalized. Usually we go for conventional tests, that is stool microscopy in form of OVAs, looking for OVAs and cysts. Stool culture is routinely sent in severe cases. We must also look for electrolytes and renal function, but there are certain limitations in the conventional tests. The limitation being they are time intensive, have low sensitivity, and they might delay the targeted therapy. To mitigate these problems, we have PCR-based diagnostic tool called BioFire. This was actually introduced in the year 2014, but has not got very much popular in this part of the world. What it does, like in traditional testing, you have to actually have multiple sampling, testing takes time, and then multiple reports come. In the PCR-based BioFire, there is only one sample, and that is actually put to test, and within very quick time, that is 1 to 2 hours, turnaround time being very fast, you get multiple results in the single report. What does BioFire have? Well, it discovers about 22 targets or organisms in the GI panel. This includes 5 viruses, 4 parasites, 13 bacteria, which are commonly associated with gastroenteritis. The performance level is about 98.5% sensitivity and more than 99% specificity. Sample type has to be stool in Carib-layer medium. These are the viruses, bacteria, and parasites which are actually included in the BioFire panel. Well, it was put to clinical trials and clinical use also, and what it does, it is associated with reductions in antibiotic use. That has been the primary benefit. Time to optimize the antibiotics is also another benefit, and length of stay obviously gets reduced because you are not treating patients with antibiotics where it is actually not indicated. There is an Indian experience also which has come from DMC Ludhiana, where Dr. Ajit Sood's group, they had tested about 32 samples, and they had very good results of these 32 samples, which actually those patients were of 10 to 82 years of age. There was 72% positivity for at least one or more pathogen. Total 41 organisms were detected, of which 65% were bacteria, 5% viruses, and 32% were parasites. Giardia lamblia was the most common organism. Stool culture was also done in about 16 patients, but positivity was seen in only 2 patients. Just compare. In BioFire, positivity was very high in 72, but whereas in stool culture, the conventional test, the positivity was very less. So there are certain obvious advantages, which is rapidity of diagnosis, and turnaround time is about 1 hour. Between 1 to 2 hours, you can get the report. Just compare it with 36 to 48 hours, which you have to wait for the stool culture reports to come. It has got high sensitivity, specificity, detects low pathogen load also. For conventional positivity, you have to have a high pathogen load. It identifies multiple pathogens simultaneously because multiple culture media are not required. This single thing will take care of it. It improves antimicrobial stewardship so that you are not using unnecessary antibiotics. And even the viral diarrhea, which is very common, people tend to use antibiotics, that is also avoided. It enables targeted therapy. This is the gentleman who has actually pioneered the management of acute diarrhea. He is Dilip Mahanalabes. He is the one who actually pioneered rehydration therapy, and potentially this gentleman alone has saved more than 70 million lives, and he is someone we must thank for saving lives of diarrhea patients. The initial assessment and triaging has to start right away when the patient comes. You have to quickly assess severity and look for the red flags. Vitals and all have to be done. If the patient is unstable, immediately IV resuscitation has to be started, and patient has to be quickly categorized. Whether if the patient has watery diarrhea, most likely it is viral. If it is inflammatory, that is the patient having fever or blood content, Shigellosis or salmonellosis is likely. If the diarrhea is persisting beyond 7 days, protozoal infections are more likely. The basic management has to be there in all the patients. It has to be started in all, like rehydration, it is the cornerstone of the therapy. Nutrition, people tend to keep the patient fasting. Well, that's not correct. Early feeding must be started. Avoid high sugary drinks. Symptomatic therapy, antiemetics if needed, but zinc, especially in children, must be started. Where does biofire fits in here? Well, there are certain strong indications, like if patient has severe diarrhea requiring hospitalization, if there is diagnostic uncertainty, host is immunocompromised, there is suspected mixed infection, failure of empiric therapy is there, or patient is in ICU, well then biofire has to be done. Advantages are it detects bacteria, viruses, parasites simultaneously, TAT being just 1 to 2 hours, highly sensitive, but there are certain limitations in form of it also detects colonizations, cost is high, and it is not widely available as well. Empiric antibiotic situations are there where you don't have to wait for anything. If mild watery diarrhea is there, you have to avoid antibiotics. Start empiric antibiotics only if there is blood mixed stool, high fever, or the patient has traveler's diarrhea. Options like azithromycin is preferred in India. Cipro resistance concerns are there. In special cases like Clostridium difficile, you have to treat with vancomycin right away. Post results, if these are the targeted therapy, you have to start. I did not go, this is an August audience. But what to avoid is important. In dysentery, you have to avoid loperamide. Probiotics are optional, they have modest benefit only. Unnecessary antibiotics have to be avoided to prevent resistance. Like, we have to quickly dispose the patient if it is mild, manage in OPD, admit only if patient has severe dehydration, sepsis, patient is elderly, or patient is unable to accept oral diet. So, to summarize, the initial approach has to be patient presents with acute diarrhea, assess severity and red flags. Unstable, admit, give IV fluids. Stable, continue evaluation. Mild, no red flags, ORS and early feeding should be started. Next, if moderate or severe or red flags, indications for testing, stool must be put to biofire GI panel. Empiric antibiotics if dysentery or severe, adjust to targeted therapy once results are there, and then disposition is to be decided depending on the result, either you can discharge or admit the patient. Key take home, most acute watery diarrhea is viral and self-limiting, hydration is life-saving, avoid indiscriminate antibiotics, biofire is a game changer if available, rapid, accurate and syndromic diagnosis is possible. And in precision medicine, antibacterial stewardship is something which we must promote. Thank you. Thanks very much.
Thanks, Dr. Devin Singh, for excellent talk on acute diarrheas. Now,
मेरे जैसा इडियट एक चीज जोड़ना चाहता है कि इम्यूनो कॉम्प्रोमाइज पेशेंट में खासकर क्लॉस्ट्रिडियम डिफिसिल वगैरह जब इन्फेक्शन हो तो वेंकोमाइसिन ओरल दी जाती है।
Yes, sir.
इंजेक्टेबल का कोई इफेक्ट नहीं होता, वैसे ही मेट्रोनाइडाजोल भी ओरल देनी चाहिए तभी इफेक्टिव होती है। थैंक यू।
Point well taken, sir.
Any comments from audience?
Devender, we have a little experience with biofire, so
Yeah.
I would like to share that it has been particularly useful in patients of IBD who come with a flare, because there it's very important to detect an organism and treat. So like one of our patients who was a post liver transplant patient for ulcerative colitis and PSC, and she came with a recurrence and we found cryptosporidium on biofire, so which perhaps could not have been detected, and once we treated and she became out.
We also face challenges in detecting cryptosporidium even on conventional testing. You have to specifically ask for it, because suspecting it you have to ask the pathologist to look for it, then only we are likely to get positive result. Otherwise they frequently miss it, and this is an excellent tool which can actually detect all these organisms within no time.
So for acute watery diarrhea, it may not be cost effective in a general patient, but for immunocompromised, certainly.
There are special categories in whom it should be asked for.
Thanks.
Yes, sir.
Yeah, excellent talk, Devendra. I was also just about to make that point that biofire is not a very cost-effective thing to talk when we are talking about the routine garden variety of acute watery diarrhea. I think the audience should take that take-home message very clearly, that this is a niche investigation in that select audience of immunocompromised patients, IBD with flares, post-transplant patients, and so on and so forth. We shouldn't be using this as a routine.
Yes, sir. There are very specific situations where it has to be used. Majority is self-limiting. Rehydration itself will take care of majority of the diarrheas. But otherwise, in special situations where delay is going to be harmful, only in those few situations, biofire is an excellent tool. Although, mortality, as we are all aware from diarrhea, has gone down drastically. But there are certain areas where there are still some gaps, and this is an attempt to fill those gaps only.
I think excellent talk, and I don't want to repeat biofire, we already talked about. But for physicians and everything, I find 90% prescriptions for a diarrhea with a combination of a quinolone and a metronidazole in this country. And it is still persisting, which is very, very sad. And as you rightly said, you hardly find anyone prescribing an azithromycin in diarrhea.
Yes.
So we have to really change our practices.
It has
Just
to,
wanted
sir.
to agree that.
I think it's
practice.
absolutely right because
Absolutely. We don't have to use these combinations which are available only in this country. We don't have these combinations available anywhere.
I think he's absolutely right because we hardly see prescription of azithromycin for acute diarrhea so far. Regarding this biofire also, see, as you have already mentioned, there is a lot of problems with contaminants also. Many times, like a surprise organism we suddenly see, it may not be necessarily related to that particular problem. So that is one of the interesting things that is there in this.
Yes, sir. There is a limitation because it also detects the colonizing bacteria as well. So there, it has to be taken along with your clinical decisions whether that is also responsible for the diarrhea or not.
As discussed by many, that biofire is not a cost-effective strategy to do in many of the outpatients. Only a select group of patients would require. But there is a tendency to prescribe rifaximin or combination of metronidazole or rifaximin nowadays in any patient who comes with diarrhea, because only the reassurances would not work with the patient well. If the patient goes with the diarrhea at home, they may take metronidazole or fluoxetine combination by themselves. O2 is prescribed like anything by the pharmaceutical pharmacy people. So is that right approach, giving rifaximin? Number two, if not doing any culture or biofire, how could we prescribe a patient who is suffering from diarrhea azithromycin kind of a drug? Is there any clinical clue to the diagnosis that patient is suffering from salmonellosis?
Sir, actually, majority of the diarrhea is self-limiting and do not need to prescribe antibiotics at all. More so, if you are thinking of a combination of antibiotics, only about 2% of acute diarrheas will have 2 organisms causing the diarrhea. So if at all you have to prescribe any antibiotic, go for 1 antibiotic, not for 2. The combinations are actually pharma-driven, industry-driven, because it is more profitable to them, clearly. The other thing is that if at all you want to give any one antibiotic, the resistance profile of quinolones is bad. There are many reports of quinolone resistance nowadays. Azithromycin is one drug which has still high sensitivity in acute scenarios. So if you have to use an antibiotic in some situations where, for whatever reasons, the patient is more sick or the patient is getting restless that some kind of antibiotic has to be given, then give azithromycin. You send for cultures and give azithromycin if biofire is not available. 2-3 days of azithromycin is not going to do any harm to the patient.
Even the drug reaction to quinolone and metronidazole or tinidazole combination are very high.
Very high, true.
No, thank you, Devendra and the chairpersons.
With this
I think we have to wind up the session because we
can close the session.
Thank you.
Thank you, sir, for your valuable insight on watery diarrhea. So our next session is Symposium on Endoscope and Inspections, for which I call expert discussions to be seated on right side of the screen. Dr. Nivesh Sira, sir, consultant gastroenterologist at Synergy Hospital, Bhopal. Dr. Sunny Bherwani, gastroenterologist in Indore. Dr. Manish Tiwari, consultant gastroenterologist in Jabalpur. And Dr. Raghuveer Chandra, consultant gastroenterologist at Sagar Multispeciality Hospital, Bhopal. Our moderators for the session will be to be seated on left side of the screen. Dr. Piyush Ranjan, sir, senior gastroenterologist at Gangaram Hospital, Delhi, Dr. Arvind Namdev sir, gastroenterologist at Shivalaya Hospital, Bhopal. The first session will be disinfection and reprocessing of endoscopes and accessories for preventing infections by Dr. Shalapati Rao from Vizag.
सर फिर आप दोनों चीज़ें कर लेना, सर कर लेना वाला स्लाइड चेंज आ रहा है, ठीक है।
तो ये सिर्फ देखने के लिए ना?
हाँ, सिर्फ देखने के लिए।
ये इसमें आएगा?
नहीं, उसमें नहीं आएगा, आप इससे स्लाइड चेंज कर लेना, वो उधर से हो जाएगा फिर।
Yeah. Good morning, everybody. At the outset, I would like to thank Sanjay sir for the opportunity and excellent conference and a very nice concept. So the topic allotted to me is disinfection and reprocessing of endoscope and accessories to prevent infections. A little bit straightforward and more controversial topic probably. So we know that nosocomial infections are a significant problem in India, causing almost 2 million cases every year and almost 80,000 deaths annually. And the infection rate in ICUs ranges between 10% to 60%. Majority of these kind of infections are because of poor hygiene, overcrowding, high patient to staff ratios, and antibiotic misuse. We just had an excellent talk on just watery diarrhea, but there is a lot of antibiotic misuse in many other diseases as well. So if you see one of the study published some 5 to 6 years back, medical device related outbreaks, many of these probes or scopes that we actually use in the body by various specialists like vaginal probes, ENT endoscopes, hysteroscopes, transrectal truss-guided prostate examination, tonometers, laryngoscopes, transesophageal echocardiograms, cystoscopes, and GI endoscopes, everything can cause some or other kind of infection to the patient. And to the matter, GI endoscopes or bronchoscopes lead to majority of these infections. The scope-related outbreaks, especially the GI endoscope, one of the study almost 10 years back, EGD showed 19 outbreaks. Okay, so EGD showed 19 outbreaks, sigmoidoscopy and colonoscopy showed almost 5 outbreaks, ERCP was maximum 23 outbreaks, and bronchoscope 51 outbreaks. Majority of them were bacteria like Pseudomonas, Salmonella, H. pylori, and some hepatitis C virus and mycobacteria, especially in bronchoscope. So scopes, entire body as well as GI endoscope has been reported to cause some kind of infectious outbreaks. We are more worried about ERCP related infections, especially in 2014 after this report. They have reported as New Delhi metallo beta-lactamase producing carbapenem resistant E. coli with exposure from duodenoscope. There are kind of 20 outbreaks causing more than 20 deaths, and it is found that even after thorough reprocessing and following the guidelines, still these deaths were happening. And so there was a serious suspicion about is there any human error or any scope design related issues, and that has become a big debate. So the potential for infection transmission is because of many factors, especially when we are putting the scope in the...
Dr. Achanta, I think slides are not changing.
Oh, okay.
It's the same.
I'm so sorry. Yeah. Actually, there is some kind of disconnect here. I'm sorry. So, so there is beta-lactamase producing carbapenem resistant Enterobacteriaceae, which has caused this. Sorry. I think this is causing confusion to me. Okay, so gut is with lot of loads of bacteria, and whenever we put a scope inside, the scope is contaminated with bacteria and we need to clean it. And there are certain endoscope related designs also, design related difficulties also, which can cause a biofilm formation. Endoscope has a lot of long, narrow and complex internal channels. There are a lot of hidden areas, and there can easily lodge with organics and microbes. So any kind of inadequate cleaning can lead to this kind of biofilm formation. So we need to understand this, because otherwise if we don't clean it properly, then the cycle of infections can happen to the other patient also. We know that there are wide range of endoscopes, gastroscopes, colonoscopes, enteroscopes, duodenoscopes, EUS scopes. The last two are with actually the elevator, which makes it more difficult. So whatever it is, Ultimately, the endoscope has a very complex design with long tubes, flexible tubes. And if you see the distal tip of endoscope, we have adjustable wire for stiffness. There are biopsy channels, there are air channels, there are angulation wires, there is a water channel, there is a CCD signal channel, the water jet channel, and the light fibers. All these things are incorporated in a very thin scope ranging from 5.5 to at least 14 mm also. And there are long tubes with lot of these channels, suction valve, and air water channel, and there's a distal tip also. So imagine it's a very complex scope, complex design with it, and it's flexible. Additionally, duodenoscope also has a complex tip design because of this elevator, because of this elevator. If you see this, there is an elevator which actually moves your accessory towards the ampulla. So the accessory goes in a right angle. So there is a elevator wire, there is an elevator, and there is a big dead space kind of thing which causes difficulty in cleaning. So this is a difference between other forward viewing scopes and duodenoscope. So biofilm can form in the endoscopy channel if it is not cleaned or pre-cleaned appropriately. And once there is a delay in cleaning process, then there is promotion of this or building up of this biofilm in the scopes. So if you see the infection control, it starts directly from the endoscopy suite design. There should be a reception area, there should be a reception area, there should be a preparation area, and there we generally have more than 1 or 2 endoscopy suites. And at the end, majority of the standard endoscopy suites are actually designed for the soil scope cleaning and high-level disinfection, scope drying area, scope storage area, equipment storage area. So it's generally not 1 or 2 rooms, but it starts right away from the suite design itself. Once you do this, then we can segregate various steps of this procedure versus cleaning and storage areas. So if you see the scope cleaning area, of course, the personnel should, the staff or people who are cleaning these scopes have to wear these kind of PPE kits like what we were doing in the COVID era. The scope comes in a separate tray and then we clean it in these sinks, and then we do a leak testing, then scope inspection. Once we see that there are no scope damages and all, then we send the scope for high-level disinfection. So if you see the various steps of reprocessing, in the procedure room itself, once the scope is taken out of the patient body, pre-cleaning happens, out of which there is almost 10^3 reduction of bacterial load on the scope, and then you do a leak test, and then manual cleaning is done, then visible inspection for any cracks or any kind of damage to the scope is done, and then the scope is transported to high-level disinfection, then it is sent for drying and then storage. So by doing so, significantly the bioburden on the scope decreases from 10^9 to 10^12, and almost it becomes nil. So pre-cleaning and manual cleaning are identified as the most vulnerable steps by WHO and FDA, and any kind of lapses in these things can happen in these 2 kind of steps, and so that we need to be very careful. So if you see the infection control, cleaning and reprocessing is labor intensive. We need to adhere to the manufacturer recommended instructions. Like there is a study from 72 Dutch centers involving EUS and ERCP scopes. The scope contamination can still be around 15%. After a first HLD, that is high-level disinfection process, still 18% of cultures were still positive, and upon further cycles of high-level disinfection, culture positivity has come down. Cultures should be obtained from all the channels as well as elevator recess. If culture is not there, then ATP test is also now used in certain countries. If scope is still culture positive or ATP test positive, repeat the whole cycle or use a double HLD or ETO sterilization. There is some use of parasitic acid now in the market, not in India, but outside, especially in Japan. If still scope is positive, then it is better to quarantine the scope and then repeat the process. Periodic scope autopsy is needed to identify any miscommunication during the HLD process or damaged parts or repair issues. And now we increasingly use disposable scope tips and elevator seals, especially when we are doing ERCP. So steps for efficient scope management. It is not just disinfection or high level disinfection. We need to identify which scope is being used and what is the inventory, and we need to maintain and repair these scopes. Routine inspection is very much needed. We need to trace back to the scope, which scope must have led to this infection to the patient, and we need to make staff also accountable. We need to comply with the regulatory standards. Cleaning and disinfection of not only the scope but entire room and other disposables are needed. We need to understand the endoscope shelf life and also document and record keeping of which scope was used for which patient and how many cycles of HLD were done. Coming to the other topic, that is endoscopic accessories. If we see the Spalding classification of medical devices, endoscopes come in semi-critical category. That is, it gets in contact with the mucous membrane and it is vulnerable to infection. But other accessories like surgical instruments, injection needles, sphincterotomes, they directly come in contact with sterile tissue or vascular system, and those are actually labeled as critical devices and they need sterilization. Other non-critical devices like stethoscopes, stretchers, or blood pressure cuffs or bedpans are actually in the non-critical category. They just come in contact with the intact skin. So if you see the reprocessing of accessories, majority of our endoscopic flexible accessories are in this category. That is, this is an ISO label, that is any reuse is absolutely not recommended. Or in certain situations for the same patient more than one use is recommended, but this is very rare. But if you see the regulatory landscape in the entire globe, you see India falls in the red. So many countries like India, China, US, or in Saudi Arabia or Africa, there are no regulatory standards for reuse of single-use devices. There is a survey conducted by SGEI some time back, and there were 179 reports. And the question is, what is the biggest hurdle in adoption of single-use devices in your practice? And the first and foremost thing is, more than 57% people responded, endoscopists, they responded that affordability is the major issue. So affordability of single-use devices make us to reuse all these things, and because of that, it's the biggest hurdle. Other logistics like affordability and carbon print were also considered, and logistic issues were also marked. The second question is, what is the perceived challenge of reuse of single-use device? The perceived challenges of reuse is obviously the response of 68%, all of them, like infection risk, prolonged procedure time, and suboptimal device performance. So still nobody want to reuse the single-use device, but that is the realistic scenario. So how do you determine the number of times a critical device or accessory should be reprocessed? It is actually seeing that effective device performance. You keep using the device again and again. In almost 52% of respondents, they have said that we keep using these devices till it works. So that is the answer. And 21% as per the hospital protocol and 17% as per JCI or NABH protocol. So this is the survey conducted some 2 years back by SGI, and I am showing these results. So if you see the issues about reuse of single-use device, it has a lot of environmental impact, especially the carbon footprint is up to 91 to 96%, and there is a massive non-renewable waste generation. There is an issue of sustainability and cost, because switching to fully disposable options will increase your cost by 4 times as well as the waste by 4 times. There is a safety and risk issues also designed to prevent the cross infection versus massive adoption. It is debated. There are operational challenges as well, and there is more waste and more burden to the environment as well. So the dilemma is always safety today versus sustainability tomorrow, and it is always a balance between infection prevention and environmental sustainability. So if the following criteria are met, probably we can reuse a single-use device. If the device is retrieved in toto, it is cleanable thoroughly, reassembled in its original form. I'm almost completing, sir. It can be sterilized effectively. It has a mechanism to check the integrity and functionality. It ensures a performance similar to first use. Probably in this kind of scenarios, you can reuse a single-use device after effective sterilization. So SGI is coming up with these statements. It is approved now in preparation of manuscript. The first statement about endoscopic accessories is, it is used in GI endoscopy, may be categorized as reusable devices, single-use devices, or partially disposable or reloadable devices based on their design and manufacturer instructions. Statement 2, reusable endoscopic accessories offer potential.
Slides.
Oh, sorry. I think there is some confusion. This computer is causing me a lot of this confusion, sorry. So statement 2, reusable endoscopic accessories offer potential advantages in terms of cost, environmental sustainability, and should be preferred to single-use accessories. Reusable accessories should undergo standardized and validated cleaning, disinfection, and sterilization protocols in accordance with manufacturer instructions and institutional infection control policies. Statement 2C is reusable critical accessories should undergo prompt cleaning after use followed by validated sterilization prior to reuse. Statement 3, single-use accessories can be reused provided that such practice is governed by the institutional policies incorporating risk assessment, verification of device functionality, validated disinfection or sterilization process, robust quality assurance measures, and comprehensive device traceability. Last, fourth statement, the ancillary equipment used during endoscopy like water bottles or tubing systems should be cleaned, disinfected or sterilized and replaced at periodic intervals recommended by the manufacturer instructions and infection control policies. So to summarize, ladies and gentlemen, infection control is an important issue in the GI endoscopy unit. Step-by-step method needs to be followed for proper scope reprocessing steps along with staff competency, training, assessment and audit. Always prefer single-use devices where and whenever possible, but reuse of single-use devices is widely practiced in reality. Of course, there are a lot of criteria that are laid down and proper local and hospital policy is needed during implementation of this without compromising patient safety. Thank you so much for your patient listening.
Very nice comprehensive coverage of this very practical topic. Dr. Achanta, you have said that cleaning personnel should wear PPE kit.
Yeah.
So is it really practical? Because I have
It
never
is not
seen
really
in any
practical,
unit.
but it is still recommended widely across. Even SGA also recommends the same thing because, once you're cleaning it, there can be aerosol exposures. And also, if you see practically in some hospitals, there is sharing of the same CDS room with the bronchoscope also. So it is always better at least to wear minimum like face mask or gloves, at least that is the minimum. At least that's what we practice in our, but putting entire from top to bottom like in COVID situation is impractical. And we know that many guidelines that are recommended in this area are mostly impractical. But minimum is best.
We can have Sharat's talk also and Dr. Chalapati can take a seat here. Okay. We can have discussion later.
Thank you, sir. The next session is treatment of infections with endoscopy by Dr. Sharat Chandra sir, consultant gastroenterologist at Migraj Memorial, Jhansi.
First of all, I'd like to thank Dr. Sanjay for giving me this opportunity. The topic which has been assigned to me is treatment of infection with endoscopy. Now, the commonest indication where endotherapy is used to treat infections is in case of biliary tract obstruction with cholangitis. Yeah. Okay. Yeah. The commonest indication is cholangitis caused by biliary tract obstruction, which can be because of a malignant obstruction. Like this is a patient with a hilar block where we deployed a SEMS and following which bile is infected, the pus is coming out. Or it can be because of a stone disease where after removal of a stone, pus is seen coming out of the ampulla. And once we clear it, we place multiple stents. So this is the commonest indication, that is ERCP is the most common modality we use for drainage. But what if you don't have access to the ampulla? This is in setting of malignant biliary obstruction. If you have cholangitis, there you can do a choledochoduodenostomy where you place a covered stent between the duodenum and the biliary tract if the obstruction is at the lower end. Or you can go ahead and do a hepaticogastrostomy where we directly access the segment 3 duct from the stomach and deploy a stent which is partially covered, with partially covered part being within the biliary tree and the covered part through the liver parenchyma, stomach, and one end inside the gastric lumen. So these are the indications of doing drainage. by endoscopic modalities. There are situations where you can have access to the ampulla and you have a cholangitis, you can access by doing a rendezvous technique, and also it's possible that you can do antegrade drainage of the biliary tree. So this is in a commonest indication of doing, managing infection with endotherapy. Now coming to the next common indication is managing infected pancreatic fluid collection. We all know that EUS is the modality of choice in managing pancreatic fluid collection. So this is the patient where we were doing a cystogastrostomy with a Nagi type stent which is cautery enhanced. So this is what we do is that just like a surgeon do, we do a cystogastrostomy and place the wide flanged biliary stent or lamps for drainage. Now what next? Like if you do a cystogastrostomy in a setting of wall of pancreatic necrosis, so this same patient next day presented with, started having high-grade fever, and what was there was the necrotic tissue which was within the cavity of the Vaughan blocked the stent, and we did a necrosectomy. So with that, we have got a lot of accessories to take out the mug from the cavity, and we use different equipments, and this is the way we clear the infected debris from the Vaughan cavity. So these are the two most common indications where we are dealing with infection with endoscopic therapy. Coming to the third common indication, this is in my clinical practice, I use it for EUS-guided drainage of liver abscess. Now abscesses, if are not radiologically accessible, we can use this EUS-guided drainage. Now coming to the steps of drainage, this is a patient with a large caudate lobe abscess which had ruptured. So what we do is that transgastrically, avoiding a vessel, we enter into the cavity of the abscess cavity, we aspirate the pus, then we deploy guide wire within the abscess cavity, ensuring that it takes a round, because in a ruptured abscess, it can go even into the peritoneal cavity, following which we dilate the tract first with a cystotome, then with a 7 French, and then a 10 French Soendra dilator. We have a policy that once we have 10 French dilators inside the cavity, we aspirate the content of the abscess cavity. By doing this, we debulk the abscess and avoid any peritoneal spillage. Following which, we deploy a 10 French nasocystic drain within the abscess cavity, ensuring that all the side holes of the nasocystic drain are within the abscess cavity under fluoroscopic and endoscopic guidance. This is another case where we did the transesophageal transcaudate drainage of segment 8 abscess, which was situated below the IVC. So we went into this abscess transcaudate alongside of the IVC, and rest of the steps were the same, except that we did not use a cystotome because we were going by side of the IVC. So with this technique, we have drained approximately 60 patients of these radiologically inaccessible abscess, and the technical and clinical success was 100%. Now coming to the next issue, that why do we use a nasocystic drain? Why not stent? So nasocystic drain has a definite advantage over stent, because for deploying a nasocystic drain, you just need to do a concordant dilatation. If you are using a 10 French nasocystic drain, dilate till 10 French. But if you want to deploy a stent, you have to dilate it liberally. This is number one. Here you know what is happening. Suppose you are place NCD, whatever drainage is occurring, you are calculating it. You know that this is a predictable drainage going on. Other advantage is that you can use it in all situations. Like you can use nasocystic drain transgastric, transesophageal, transduodenal, because if you use a plastic stent transduodenally and you dilate liberally, there is a high chance that the contents of the intestine will leak out into the peritoneal cavity. So these are the advantage of using a nasocystic drain, and if you are draining abscesses which are far away from the lumen, still this is the best modality to do. Moreover, it can also give you an idea about the biliary communication if it is there. Now, following the drainage, what we do is that we have an innovative technique. We use a syringe-in-syringe technique to aspirate the content actively. By doing this, we decompress the abscess cavity, and once the abscess cavity starts decompressing and the drainage becomes less, then what we do is that we put the NCD on spontaneous drainage by gravity. And we internalize once we have the more than 50% reduction in the size of the abscess cavity and patient is asymptomatic. We cut this nasocystic drain and place it into the stomach. And we remove this at 4 weeks once the fistulous tract between the abscess cavity and the gastric and the stomach wall gets materialized. So this is the way we drain these abscesses. Now, not only you can drain liver abscess, you can drain a bilioma if it is accessible to your EUS guidance. This is a patient where it was a transrectal drainage, the same patient who had a liver abscess which had ruptured. So a part of it we couldn't drain with percutaneously placement drain in the in the peritoneal cavity. We went ahead and did a EUS guided transrectal aspiration. So EUS allows you to aspirate anything which is accessible to a EUS scope. Now, coming to a few interesting cases which were managed by InfeCON. This was a very interesting patient. The patient underwent cholecystectomy and was about to be discharged, started having high-grade fever and cholangitis. So what was point is that in the CBD, we did a EUS, we could see a worm. There were 2 hyperechoic lines and central hypoechoic zone, suggesting of the intestinal tract of the worm, which we could diagnose. And the same patient, we immediately took it for an ERCP, and we could visualize the worm inside the bile duct. And with the help of a balloon, we just got the worm out and extracted it with a forceps. So these are rare conditions, although not common these days, but one should have in our mind, whenever we're dealing these atypical presentations or patients, we are not able to explain the patient's symptoms. One should always think about these rare conditions. And this was a very interesting, gratifying patient like result. We did a EUS and we could diagnose ascariasis. Although this is not a true infection, it is more of an infestation. I'm sorry. The next patient which I'm showing you, this is a patient where we had a recurrent acute pancreatitis. And this patient had a worm in the neck and body of the pancreas. This was the live worm, and that was causing recurrent pancreatitis. So we managed the patient conservatively and gave anti-emetic therapy, and there was no recurrence of pancreatitis. This was a very interesting patient. This is a patient with hiated cyst with biliary rupture. Now, it is not uncommon for hiated cyst in our region. So this patient had membranes which were jetting out of the ampulla, and we just did a nick, and we could extract all these membranes and the pus which came out. This is another indication. We should always suspect biliary communication if there is jaundice or if the patient has got cholangitis. This is another interesting patient which was, there was a large cystic lesion in the head of pancreas with upstream dilated main pancreatic duct, which was dilated and tortuous. This was reported as chronic pancreatitis with Vaughan by the radiologist. So we went ahead next day with the EUS guided drainage. So what was important in this patient is that this patient had a hiated cyst. Actually, this was mistook. I missed it, and as soon as I punctured the cyst, we could see all the constellation of signs which are characteristic of hiated. So what you will see first, there is separation of the membrane. That is floating membranes. As soon as we give a nick, these are changes of chronic dilated main pancreatic duct which we are seeing. Now I'll show you the findings, what happened. So as soon as we punctured the cyst, as soon as we punctured, the membrane got separated. This was the floating membrane. And as we did a little dilatation, the entire membrane came out, and you had the water lily sign, which is classical for hiated cyst. Then what we were interpreting as Vaughan, it was a sandstorm sign. So this patient showed us all the characteristic signs of hiated. And even retrospectively, we found that the cyst wall was having multiple layers. So this was a case of isolated pancreatic hiated cyst. But now we went ahead with drainage. This is the first report where anybody has drained a pancreatic hiated cyst endoscopically. So we dilated the tract and placed 2 plastic stents. And this patient did very well, and the cavity collapsed, and now she's under follow-up for the last 3 years, and there's been no symptoms. So we removed the stent at 6 weeks. So this was a case of isolated pancreatic hiated cyst, which was managed with endotherapy. This was another interesting patient, a young lady presenting with jaundice, cholangitis, high-grade fever, and there was a large lesion. This was at the level of porta. So it looked like a multicystic lesion with, I thought it to be hiated. So I did not touch the lesion, and I did sent a hiated serology, which came out to be negative. Now this patient, after this negative serology, we just punctured it. It was frank pass AFB4+ positive. This was a case which mimicked hiated cyst, but it was tubercular. Now this was another patient, a young lady. She was a staff. She presented with high-grade fever and had a caudate lobe abscess. So we did a EUS evaluation, there was no liquefied material inside the cavity. We just put a needle inside and it was tubercular. So we do encounter these rare infections in a clinical practice. So what I like to just conclude is with that endoscopic intervention is the first line in managing infections requiring drainage if they are accessible to endoscopic therapy. So this was tubercular caudate lobe abscess. I think there are a lot of other indications where endoscopy is used for treating infections. We do have a lot of leaks, fistulas, where definitely, yes, endotherapy definitely helps in managing these patients. There are a number of indications. I think we have a very learned audience. I think we can also comment on their concept about it. Thank you so much.
You can join us on the stage. So we'll have this discussion. So let me set the ball rolling by asking Chalpati. So you talked about infections prevention. So when we talk of prevention, it's mostly centered around the duodenoscope. With upper GI scope and colonoscopes, what kind of infections can be introduced? Say with colonoscope, if they're not adequately reprocessed, can they cause diarrhea? Because when we understand that all the outbreaks which you mentioned are they are basically cholangitis due to inadequately sterilized duodenoscopes. And equally important than the scopes are the accessories, say the cannulas, because they are the ones which are used and they have a thin complex design, and they are mostly we do not ETO them, and then they can be a big source of infection. And what about as far as upper GI endoscopes and lower GI endoscopes are concerned, what about viral infections, hepatitis B and C transmission? I mean, what should be the practical take in a busy endoscope unit when you don't have too many endoscopes, and what should be the turnaround time?
I think this is relevant to mostly our Indian practices because a majority of us still work in a single run clinic or a small endoscopy suite with limited scopes, and still manual cleaning is widely prevalent without availability of any automated washers. Maybe couple of times I could recollect patient comes back on the next day saying that I have a sore throat after endoscope. So probably that is one kind of infection that we might have transmitted, but after those complaints we have become very careful, and even we follow the thorough HLD protocol and all. The major attention to this issue has come up after the reports of these CRE infections, because US FDA and WHO has intervened, and it is for therapeutic purposes. When ERCP is supposed to treat kind of infections like what Dr. Sharath has said, it has introduced infections. So and then the complex design of duodenoscope was all identified. It has changed the practice and all. The manufacturers have changed their scopes. Practical tip to at least buy 2 scopes, at least because we are busy with gastroscopes than colonoscopes, probably at least 2 gastroscopes, and maybe turnaround time at least 10 to 15 minutes in between, at least minimum, but that is still not recommended. Probably some kind of jugaad, I am telling, there is no proof for it. And colonoscope, obviously you can space 1 endoscope, 1 colonoscope, so that in between you need, your staff has some time to clean and disinfect the scope. So probably in that kind of situation, you may alternate between a colonoscope and an endoscope, or 1 endoscope to another endoscope, at least 2 endoscopes and maybe 1 colonoscope. Maybe it's a most practical tip that I would give.
Mechanical automated washers versus manual.
So I think some steps come down. The human compliance improves with automated washers, but there are no studies majorly saying that automated is much better than manual cleaning.
Any more questions from the hall? No?
I think I am more interested in your presentation on endoscopic ultrasound guided management of primary pancreatic hydatid cyst. I think the diagnosis was based on US finding. So do you think that placement of drains and doing the internal drainage was alone sufficient to take care of the pancreatic hydrated cyst in this particular case?
I'll just add one more rider to that. Had you known from before that this was a hydrated cyst, would you have intervened?
I totally agree. The diagnosis was missed by me because as per the CT findings, they just reported as chronic pancreatitis, so I just went ahead. So only once I had punctured there I realized. So I completed the procedure. This was not even under GA. It was under only sedation. So, but everything went fine and the patient improved and the cyst collapsed. It totally disappeared. We have removed the stents and she's under follow-up for the last 3 years and she's doing well.
Because if you have a suspicion of hydrated cyst, I think before doing any kind of intervention, it is better to start with the albendazole for at least a week.
I totally agree with you. Basically, once you have committed, you have done a needle and now you have realized the diagnosis, there is nothing to fall back. You have to go and complete the procedure. If I would have removed the needle, it would have caused more contamination at that time. Or the spillage chances would have been more. That's why I went ahead. But I had informed my anesthetist that you might need to give a GA if something goes wrong. You need to intubate.
So how did you confirm the diagnosis? By aspiration, you sent the fluid for?
No. Yes, scoliosis was seen after that.
Okay.
Whatever we confirmed it also. And once you put the needle, we saw all the classical signs. We don't see in a single patient, even the radiologist would not have seen 4 signs together in succession. This was constellation of signs.
So did you inject any scoliosis agent?
No, I did not inject anything. I just drained it out and it was a cystoduodenostomy. It is from the duodenum and everything drained out. Normally what happens is that when you have a bile and this acid going into the cyst cavity, it gets sterilized. So my problem was not of the cyst would definitely, all the living elements would have disappeared because you have the bile and everything entering into the cyst cavity. My main intention was it should not spill into the peritoneal cavity. That was more concerned. And any anaphylactic reaction.
Sir, after then, how long you continued with the oral medicines for the patient? 8 to 12. I think Dr. Vishal had a good case of surgical management of hydrated pancreatic. Okay. So I think with that we can conclude this session. Thank you. Thank you so much.
Thank you so much, sir. The next session is a panel discussion on infections in cirrhosis. I would like to invite upon stage the panelists to be seated on the right side of the stage. Dr. C.C. Chaubal, Consultant Gastroenterologist, GastroCare Multi-Specialty Hospital, Bhopal. And Dr. Sandeep Pandey, Consultant and Head Department of Gastroenterology, Ramakrishna Care Hospital, Bhopal. Dr. Neeraj Jain, Gastroenterologist at CHL Hospital, Indore. Dr. Piyush Pathak, Assistant Professor at AIMS, Bhopal. Dr. Amit Singh Barpa, a liver transplant specialist at Apollo Hospitals, Indore. And Dr. Ayush Gupta, Additional Professor, Microbiology at AIMS, Bhopal. The expert discussants for this session are Dr. Akhilesh Argal, Anesthesiologist at GastroCare Multi-Specialty Hospital, Bhopal. Dr. Sanjeev Gulati, Senior Physician, Bhopal. Dr. Apur Tripathi, Pathologist and Microbiologist at Mansarovar Medical College, Bhopal, and Dr. Vikas Raikwar, Gastroenterologist at Apollo Sage Hospital, Bhopal. This session will be moderated by Dr. Mridul Kumar Daga, Professor of Internal Medicine and Infectious Diseases from IIBS, Delhi.
The permission, I think we are late by 30-40 minutes, but I see a lot of interest in young physicians and senior gastroenterologists and consultants here. At the outset, let me thank Dr. Sanjay for giving me this opportunity in such a wonderful city of Bhopal. When you fly in, you see the lake. So without much ado, just a very simple case, but had a very we had a 32-year-old gentleman who came into the ER with just 1 day of altered sensorium, known CLD but well compensated, ethanol-related recidivism was present. The present issue was 2 days back he had the last alcohol intake. His CTP was 8 and male was 22. He was little restless and disoriented, tachycardia, but there was slight icterus, no other positive finding in the ER. Chest, cardiovascular system, central nervous system, except little agitation and disorientation, there wasn't much. Abdomen was little distended, where there was palpable liver, little dull, but there was no free fluid as such, and bowel sounds were still heard. And these were his initial labs when he landed up on 20th, with normal counts, slightly raised INR, a creatinine of 1.55, bilirubin of 4.7, and ammonia of 170. When we did a ABG, things look okay with lactate being little high. This was the X-ray. You could see it looks like there might be an ascites or a distended abdomen. Rest all looks okay. And if you look at the CT done, it showed liver and spleen both little enlarged. And if you look at this shadow, I'm not running the whole film. There was some evidence of some collaterals already present. There was no free fluid. So we thought it is a CLD with probably an alcohol withdrawal or an associated hepatic or septic encephalopathy. So through the panelists, Dr. Chaubal, what do you think the most common infections you come across in cirrhotics, tuberous cirrhotics?
So if you look at this thing, what is mentioned and what we see in clinical practices, these patients, spontaneous bacterial peritonitis, in fact, almost 40%. Next comes your urosepsis, which is around 28 or 29%. Then comes your pneumonia, which is around, say, 15 to 20%, followed by subsequently either a spontaneous bacteremia or skin or soft tissue infection. So that's the usual thing which has been reported in most of the places. And we also see that, especially if the patient has ascites. But this patient doesn't have any ascites, that is very important. So the question of SBP is out in this particular situation. But any patient who has a CLD and deteriorates for just no reason, you have to consider infections as one of the first possibilities in these situations.
So you're so right. This famous study from Paolo in 2019, Piano, it showed that UTI, SBP, but when they compared America, Asia, and Europe, what they found in Asia was UTI was little less than SBP, but pneumonia was much more in this part of the world rather than UTI being number 2. And a lot of Indian centers were included in this. So I fully agree with what you say. And if you look into another study which was in South African country, South African nation, there again you see that SBP, UTI, these are the common infections. So you may have those, but it then also depends on is the patient having some other risk factors besides a cirrhosis or has had anything. So my question to Dr. Sandeep, is the Dr. Sandeep, please?
Yes,
yeah.
Yes, sir.
So what do you think are the risk factors for infections and cirrhosis?
Well, sir.
And I would also like house to, anyone can raise a question and give a comment in between. Yeah.
Well, sir, as we already know, these patients with CLD are already in a state of immunocompromised state because of various reasons. They have got reduced complement levels, they have impaired neutrophil functions, they have impaired opsonization also. So this is also known as cirrhosis-associated immune dysfunction syndrome. So they are more prone to catch infections, both community-acquired as well as hospital-acquired infections. So the patients who are hospitalized, they can, especially with on central lines, on catheters, with a history of diabetes, or if they are receiving corticosteroids, they are more likely to catch infections.
All right. So if you look into, you've already enumerated this. So if they have even a severity of disease, which I wanted to add, If you are CTP class B or C, you're likely to have it more. If you have frail, malnutrition, again a predisposition. If you have a lot of PPI use, which so commonly being used, these patients will have predisposition to infection, and then previous hospitalization and the prophylactic antibiotics. So as you so rightly enumerated, these are the various risk factors. And when do you suspect that? I mean, you would suspect what are the common bacterial in a community acquired? That's what I wanted to know from the panel. And I think Dr. Nirmal is there. Sorry, Dr. Neeraj is not there. All right, anyone can take that, common microorganisms, if you have a community-acquired infection. So,
usually gram-negative bacteria are the one which gives us trouble in patients with liver cirrhosis. And on gram-positive side, strep and staph are the usual culprits.
yeah, so rightly as seen here also, but again, somehow or other, I don't know, the house would share with me, we do not see that commonly gram-positive. We see predominantly gram-negative organisms. And also MRSA is not so commonly seen. We do see Staph aureus, but on the other hand, we all know as physicians that there are not a lot of MRSA in the community as well available, and there are people walking in the facility with a community-acquired MRSA also. So upfront, it's very difficult to discern until unless you have the profile of the patient, was patient admitted in other facility and being transferred to your facility, was already on some antibiotic. So primarily gram-negative, but as rightly said, gram-positive is also there. And then the question comes of, whether these organisms are drug resistant or not. So the bottom line is, if Dr. Piyush is there, is Dr. Piyush?
Yes, sir.
Sorry. So what are the hospital-acquired infections most commonly?
As we all know that nosocomial hospital-acquired infections develop about 48 hours after admission to hospital setting. So what is more important in these patients is that the same piano study showed that MDR organisms are up to 73% in Indian population. So we can expect an even higher percentage of MDR organism in the nosocomial setting. What are the main infections? What are the bacteriology? Usually remains same, and you have some specific factors like central lines. You have catheters. You have procedures. You have ventilator-associated pneumonias. All these are coming in the picture. But bacteriology then also gram-negative are more common, especially Acinetobacter in our Indian ICUs. Then Klebsiella, MDR Klebsiella, then MRSA, VRE. All these are coming in the picture. So bacteriology remains a bit same. Western studies, gram-positive in the US trial, but Indian gram-negative mainly, more prevalence of MDROs.
Of course. So that's one study which showed very high prevalence of 73%. But at the moment, we do not have any collective data from a lot of gastroenterology centers or hospitals to say that the figure is that much, but it's very scary. You should understand. So the problem is that not only the MDRO, you have now PDR, you have XDR, and you have a lot of those scenarios. So my question to Dr. Amit there? So upfront in this patient, on day one in my ER with that picture, I'm just taking you back to that. Will I start an antibiotic?
Definitely.
Provided I tell you that he is coming directly, not from any facility. He's directly walking into the hospital. And secondly, what would we like to start in such a patient?
So definite yes for antibiotic, because we are dealing with a cirrhotic patient who has come with complication. So as you said that he has no episode of previous hospitalization, and his synthetic functions of liver, they are not very bad, but at the same time they are not normal. So it is child B cirrhotic with as of now, no obvious multi-organ failure. So definitely we should start an antibiotic, and the usual choice is third generation cephalosporin. But that too should depend on the antibiotic gram of the hospital and the usual pattern of antibiotic resistance what we can see in the hospital.
Absolutely right. The last line is very critical. Just do not follow the guidelines blindly. It's not a must that you will start a third generation cephalosporin straight away. If your hospital antibiogram shows sensitivity to other group of antibiotics, maybe a simple amoxicillin clavulanic acid, you may even think of that, although I see that practice very, very rarely. Of course, third generation cephalosporins are preferred, and you need to follow very, religiously that practice. That's very, very critical. So what I wanted to show you here in this before we go to the discussion is that when you have XDR bacteria, look at that, where we are. We are much, much high in comparison to, factors of geographical area or antibiotic use in previous 3 months, or when there is a nosocomial infection, or where there is an XDR bacteria, and which is very, very frightening. So in this patient, a cefepime was started in our hospital, but he was doing fine, was in just a normal floor, but on 25th or 26th, he became little dyspneic, was tachycardic, he developed fever, and was, despite during that period the blood cultures and other cultures were not showing anything, his sensorium was okay, but he started showing signs of a hospital-acquired infection, and presumptively he was started on a different antibiotic, which I'll come to you. And that is, he was shifted to a ESBL-producing piptaz, which was combination of third generation with ESBL, because he wasn't having any hypotension, no shock, nothing to worry significantly, but yes, his oxygen requirement were little more. This was the report where we showed a rising TLC count, bilirubin was rising, his procalcitonin was little high, and his PO2 ratio was getting bad with PO2 of 67. Although X-ray still did not show any shadows. So having said that, now would you think of changing, which we did, piperacillin tazobactam? We did send fresh cultures, but we're still not localizing anything else. So if you think of upgrading them, would you like to add a gram-positive coverage with piperacillin tazobactam, or would you like to switch him over to a carbapenem, provided you have your antibiogram, and wait, because most of the gram-positive except MRSA would be covered by carbapenem as well. But the problem with carbapenem in our ICUs and recent scenarios are there are a lot of CREs. So even if you give carbapenem, and if you are not thinking of a CRE, carbapenem resistance enterobacteriaceae, you might not be good. But the treating unit decided to give a carbapenem anticoplanin in this. So what is your take on this?
No, where, see, the situation that would arise is, was initial part he is not responding to initial antibiotics. Subsequently, there are two issues. Whether you have a very high incidence of multi-drug resistance in your setup or a low this thing. If you are suspecting a combination of both gram-positive, negative and gram-positive, usually what we do is combining carbapenem with some glycopeptide like vancomycin. Sometimes you may have to combine it with either daptomycin or linezolid can also be given along with carbapenem. So that's the usual policy that is followed.
So these are some guidelines in this 2024 World Journal of Hepatology, and little bit from ASLD and EASL also. But we probably do not use that common quinolone, as rightly pointed out earlier. We don't use cotrimoxaz also commonly. We also don't use very commonly a clindamycin in our setting. And in aspects, maybe we would use in a skin and soft tissue sometimes. But we switch over to these, and this is what was done in this patient also. And if you see, these are some with septic shock, but fortunately this guy was still maintaining his perfusion, organ perfusion was good. There was no hypotension, urine output was good. So would you now think at this stage, after changing to a carbapenem and teicoplanin, and suddenly you observe that, patient is getting sick. Now, he shifted from a flow to a high dependency unit. And then, due to, further worsening, was shifted to ICU. And that's when the first culture report came. So after 15 days of hospitalization, things we did were bad for the patient. We introduced infection. We could not bring him out of oxygen, just on a face mask to begin with. And this is what we started going. He was intubated on 4th or 5th with this scenario, very high lactates, creatinine, bilirubin further rising, TLC high, and he was intubated suddenly on 4th or 5th of March. And he developed post-intubation shock still, and you can see in the lung, there was a shadow on the left side. Now, at this scenario, when they did the CT, it showed bilateral little bit pneumonia, as you can see in the next picture. So now this patient is in shock, has this, and this is the culture report. The arterial blood culture report shows Klebsiella, resistant to most of the antibiotics, as you can see. Sensitive to ceftriaxone. So at this point of time, this patient was switched over to this drug. That's on 7th, from meropenem, teicoplanin, what he was getting. And despite cholesterol showing, resistant, the PCR respiratory panel showing nothing, and a mini ball showing Acinetobacter. So you had Klebsiella, you had Acinetobacter, so you had a dual hit in this patient, and again sensitive to this drug. Now a word of caution about, from the panelist, anyone, about this drug. As of now, this drug is not approved in US FDA, but we are using it quite commonly, and we are finding some very good results, not only in these severe patients, also in some post-liver transplant patients. We are collecting some data, and we'll soon come out with a paper on that. So we had limited option, and we had to start this patient on this along with colistin or polymyxin, despite the fact that polymyxin, colistin resistance with MIC of 16. So what I wanted to ask the microbiologist, sir, what would you say seeing this report? So for 2 weeks, despite 3 cultures, and at this point of time, we had also changed his lines. He had lines we had changed, and this, the reports came like that. So what is your suggestion?
Sir, on the initial screening of the report, one thing, what they have done is a BAL sample, and they have not reported the colony counts. So for one of the important factors regarding the, particularly from the respiratory samples, BAL or ET, the colony count has to be significant. Because Acinetobacter baumannii, very commonly it colonizes when the patient is on carbapenem therapy used empirically. So that is the first thing. Second thing, regarding the susceptibility profile of this bug, what I can see is that this drug, ceftriaxone, EDTA, and sulbactam combination, there are no interpretive breakpoints as of now. As you rightly said, it is not FDA approved, neither CLSI breakpoints are there. So it is a drug which is right now and since a long in transition. I have personal experience of testing this molecule as an in vitro susceptibility, and it shows very good in vitro susceptibility. but regarding its clinical application, it is still in doubt. Third point I would like to make on this is regarding the colistin susceptibility. So colistin MIC is less than 0.5, so it is coming under a sensitive. But the problem with colistin is that colistin is no longer recommended as a monotherapy. So most of the time, the guidelines, they refrain from, reporting it as word susceptible. So they call it as intermediate, and we should take it. Intermediate is almost equivalent to susceptible.
Absolutely right. So the problem with this drug and this thing is that with the ceftriaxone, disodium, Eloris, Selbactam, because we now have reports that if you use high dose of Selbactam to the tune of 12 gram a day, and if you use with a third generation cephalosporin, it has got fantastic results. The papers are being brought out by Dr. Narvekar from Bombay, ID specialist. I recently discussed in InfeCON in September 2025. So the question is that using that high dose, which is as such pure Selbactam, people are not very happy. Or the other option is using high dose of carbapenems. The practice which I find is that people are using less doses of carbapenems in patients of cirrhosis or associated infection. I don't know what is the reason. So if you want to use either high dose of carbapenem or you use high doses of Selbactam, there will be probably no need to use this particular molecule. But this is what we use, the treating physician used there. Yeah, any comment?
And one more thing to be emphasized is, I think the continuous infusion of these drugs works much better than giving intermittent doses.
Absolutely right.
That usually is not seen in the hospitals.
Absolutely right. Continuous infusion is the order of the day, and that should be done. Sir, again to you. So what do you say about the test we are doing? Because we have to wait for 48 hours, 72 hours for these results to come and all that.
Yeah. Sir, regarding the testing modalities, right now, as in this case, we have the blood cultures, and we have obviously gone for the respiratory cultures. Urine cultures also. So as of now, there are no directly rapid tests which are directly from the sample. Like in blood culture, BioFire is there, but it requires pre-enrichment. So it has a limited, organism profile. It cannot give the whole antibiotic susceptibility profile. It can only direct you towards certain carbapenemase genes. So those are limitations. So as of now, we have to rely on the conventional cultures. One way we can speed up the diagnosis, like after flagging, there is now concept of direct phenotypic testing from the positively flagged blood culture, which definitely reduces time with a very, significantly, plus coupled with the identification method, that is the MALDI-TOF. If you have, it can very well,
I know, but again, for that you require at least some growth.
Yeah.
So you won't have the results so quickly.
Yes.
So there are now these new tests like T2 biosynthesis, which is not available anywhere in our country as of now, as I know, where you can get results very quickly. So these are the tests in work, genome sequences or, NGS. But those are very expensive and very, scenarios are difficult. So what happened was that despite adding these drugs, he again continued to worsen. His FiO2 requirement were fluctuating between 40 to 60%, and a high galactomannan persuaded a physician to add a echinocandin in this patient. Despite their lungs showing little clarity in this, this was added. So my question to for fungal infection, so when would you suspect or when would you like to add Dr. Neeraj or anyone?
In these patients, actually, in CLD patients, 0 to 10% is the prevalence rate of fungal infections. And the patients who are prone to get fungal infections are like this patient with prolonged hospitalizations, with central lines, various catheters, broad spectrum antibiotics receiving for a long time. These are the patients who are prone to get infections. So we have to be careful for diagnosing these patients early for fungal infections because that is associated with better outcomes.
So I think this was one rare scenario where antifungal was added after more than 2 weeks. I find it is added within a week. A patient is on antibiotics and not getting better, even if there is no source known. So you have to be cautious. If you are using galactomannan, you have to be sure that the drugs which can interfere with this are not being used. They will give you a false result. So just don't blindly follow these practices. So subsequently, the result showed some little less colony count, but I just want to know from him, there's, sometimes this colony count coming less and patient not getting better may be a red herring. So just don't follow that. Clinically, if the patient is not improving, you are not able to take him off the ventilator or not wean him off, then probably you. So this patient continued to be on the same drug for another, from 5th till almost 22nd or so, paucity of time. So again, same thing was growing. And I just want to tell you that the colony count in the mini bowel was more than 10 to 5 and 7, both the times. So he continued to grow that. So what happens is that suddenly on 22nd or so, he developed shock, his urine output dropped, his bilirubin increased, required vasopressors, fresh lines was put, and even after 12 hours, vasopressors could not be tapered off. So Dr. Chaubal sir, would you now think of, doing something else? You are giving antibiotics, you are ventilating, you are supporting therapy. Would you like to consider a CRRT?
CRRT and cytokine filter sometimes can be used. And moreover now we have to think about certain newer antibiotics which are now coming in. I think one of them is used in the India also. You're using ceftazidime and avibactam. There are some Weberbactam also. Ceftazidime, nuzobactam which is there, the plasmomycin, so many of us, and cefiderocol, and so many of them are there now. I don't know, a couple of them are available in India. I don't know whether your hospital is using those medicines or not. But this is what we can do actually. Finally, of course, cytokine filter you add, put the patient on CRRT and of course supportive management.
So this was thought of, but luckily after 12 hours the patient started improving. So just for the audience, the CRRT might be thought of in such a patient. And if you want to use filters on a septic shock, if you don't start it within 24 hours of onset of a septic shock confirmed, most of the filters would not be effective, whether it is cytosorb, whether it is oxyris. So if you are very sure that this is septic shock, despite all therapies, and want to use now a filter, do it at least within 24 hours. That's very important. So this is what indication for CRRT, the difference between the two, how this can be used, positive time. I'm not able to give you that information more, but this is what a comparative chart that this is, kind of a benefit in these patients. And the studies have shown in patients with cirrhosis with infection, definite good outcome. And we are going to bring about a paper within next couple of months from ILBS about the use of these in almost 130 patients, 130 patients. So this patient was not getting better, continued to grow this. These are the tests which sir was talking about, can help you, which are still not available with us, T2 magnetic resonance or the NGS, which can give you a very good turnaround time within 3 to 5 hours or 24 to 72 hours, 1 to 5 hours with biofire. But again, with a blood biofire, there are challenges. We can have the CRISPR based. These are more now in experiment and are not being used very commonly. So a repeat blood culture. Now this time, blood culture grew both. There was nothing in the minibal, but blood culture grew both. And again, sensitive to the same. This was the PCT trend. So sir, any role of biomarkers? Any taker for that, doctor? Any role of biomarkers in these patients? Sir.
Yes, sir. Biomarkers definitely have but they are to be monitored over a period of time. Then only they can, show, like IL-6 and others like STRAM. So they have a role, but still not that much. Particularly they are more in withholding the antibiotic treatment rather than,
Absolutely.
continuing with the
Absolutely.
antibiotic.
Absolutely right. So use them for de-escalating, reducing your antibiotic. That's the best thing to use. And despite limitations in liver disease patients with PCT and CRP, still these two tests most commonly available, they are still too good. So continue to use either of the two and do for more of de-escalation rather than, thinking of these are others, there are many more. So now finally, when he continued to grow this, what did the unit do? Again, his condition became worse. Again, a shadow appeared. And this time, patient was started on avibactam. The microbiologist was contacted, and patient was shifted to this antibiotic. And to the best luck for the patient, we started showing improvement. Not that I'm trying to promote this drug, but this drug would also become useless if we start using it left, right, and center. So it's not simple, but the bottom line is that, yes, you may use that. The reason is that you have a lot of these serine and metallobacterial practices, and which now shows resistance to most of the antibiotics. So it is very important that we use them judiciously. So luckily, this patient was after 6th or 7th day intubated, put on BiPAP, and subsequently moved out. The reports which came on 28th, 31st showed that there is no growth now, and subsequently we were able to wean him off. So just to summarize, just wanted to say a few words. I'm sorry that I did not use the panelists very judiciously. That's my mistake. But just wanted to summarize by saying that 5 things are very, very critical. Number 1, there are only definite indications for using antibiotics in a cirrhotic patient landing into your ER. If he's coming from other facility, already an SBP from outside, or if he doesn't have any of those things, no previous antibiotic use, has either altered sensorium, is suspecting hepatic encephalopathy, or an acute GI bleed, variceal bleed, except those settings, never put the patient on any antibiotic prophylactically if you find he is not in shock. Now the question is, a lot of your patients have blood pressure which is 90/60 or 88/60. Don't consider that as shock. If your lactates are fine, hold antibiotics. Those are the only 2 conditions when you give antibiotic, you will do a lot of service. Number 2, upfront covering without a person coming from other facility with a gram positive like MRSA is not needed still in our setting, except real situations. Number 3, try and de-escalate as early as you can. So that's not knowing all that, because 30% of the mortality in cirrhotics world over is because of infections. So you cannot be casual, but you have to be very, very practical. So thank you very much. If any other comments or anything from the house, I'm sorry I took longer time.
Any comments from the expert discussants?
Experts, please, yeah.
Sir, how many times you suspect the multi-organism infection in the cirrhosis, and especially like bacterial as well as fungi simultaneously? And one more thing I would like to say that since this scenario is a quite a number of different type of organisms may invade because of the immunodeficit condition. So we should go for the syndromic approach, and we should combine both the things like the biofire, that is multiplex PCR, and then culture also. And it gives the important information for the correlation and for sometimes excluding or including other diagnoses as well, when time is very precious and when you have to hit hard, especially in such cases where the nosocomial infection is also common and multi-drug resistance is also common, multi-organism infection is also common. So we must consider biofire quite regularly.
Sir,
yeah, absolutely. Yeah, please go ahead.
One comment and one question. It is not only the choosing the right antimicrobial, for the even the escalation or the bug. It is the time that is at the right time. If you are using the antimicrobial, the outcome will be better. If you are choosing even the right antimicrobial in the delay in the course, when the organ perfusion already set, the mortality will be definitely high. Study are very well. So my question is, at what time you are early recognition of that this is the resistance or this patient is not improving? What are the early marker, clinical, biochemical or other, that we can escalate the right institution of the antimicrobial?
So the best indicator would be the condition patient came in and what has happened to the patient. So if you have evidence of new onset fever, new onset infiltrate, if you have a leukocytosis which is increasing, and you are not able still to point out. So like in this patient who came with altered sensorium, we had no choice but to start him on an antibiotic on day 1 within few hours of landing under ER, but we did not escalate it for next 3-4 days to anything because he was doing okay. His sensorium had improved a little bit and he was getting better. Suddenly on 4th day he took a hit. So these are all everyday parameters. You know, you can't have a single pointer. If you are lucky, like we grew in something, because most of the time the culture positivity in best of the center is less than 30%. So you can't rely on that.
I think the point is well taken. It was a very nice panel by Dr. Daga. And as Shailen said, the important decisions are taken on clinical grounds. And we have a full session on sepsis coming up. And we'll continue this discussion further. Thank you.
Thank you, sir. For the next panel discussion, the topic is infection, acute pancreatitis, when and how to manage. I'd like to invite the panelists, Dr. Ajit Sevkani, Consultant GI Surgeon, Bhopal, Dr. B.S. Thakur, Senior Consultant Gastroenterology, Apple Hospital, Indore, Dr. Kamlesh Talesra, Vascular and Interventional Radiologist, Bansal Hospital, Bhopal, Dr. Iqbal Nabi Qureshi, Gastroenterologist, Indore, Dr. Saransh Jain, Consultant Gastroenterologist and Interventional Endoscopist, Jainam Shri Multi-Specialty Hospital, Bhopal. I'd also like to invite the expert discussants, Dr. Girish Ramteke, Senior Physician, Shahdol, Dr. Pradeep Nigam, Gastroenterologist, Rewa, Dr. Abhinav Anand, Gastroenterologist, Liver Specialist, Bombay Hospital, Indore, and Dr. Pravesh Mathur, Assistant Professor, Surgical Gastroenterology, AIIMS, Bhopal. I'd also like to invite Dr. Savan Bopana to moderate the session. He's a gastroenterologist, Associate Director, Action Institute of Liver and GI Sciences, Sri Balaji Action Medical Institute, New Delhi.
Good morning, everyone. So the next panel is on infections in acute pancreatitis, when and how to manage. As we all know, the prognosis of acute pancreatitis depends mainly on two things: good critical care and management of intra-abdominal sepsis. And intra-abdominal sepsis, the adequate management will generally decide whether the patient lives or dies. So to begin with, we have a panelist, an esteemed panel, and I hope we have a fruitful discussion. So let's dive into the case capsule. So a 17-year-old male student from Delhi presented with severe pain abdomen with raised amylase lipase. Ultrasound showed enlarged pancreas, peripancreatic free fluid, and gallstones. At presentation, he had systemic inflammatory response features like tachycardia and tachypnea. So he was diagnosed to have acute pancreatitis. So in the first week of illness, he had persistent cysts, increased oxygen requirement, no renal failure. Patient was hemodynamically stable, but ileus was present. So he was admitted in the ICU and started with management with fluids and analgesia. In the second week, he developed respiratory function worsening and was put on NIV. He had grade 2 respiratory involvement. ileus resolved in the second week and he was started on nasojejunal feeds. But then he started developing fever and with a high TLC count of 22,500. So at this point, antibiotics were started. So to set the ball rolling for the panel discussion, I'd like to ask Dr. Thakur, can extrapancreatic infections lead to this kind of a picture, and should we consider extrapancreatic infections also at this stage? And if such a patient comes to you, what common infections do you actually consider at this stage?
So yes, if a patient is coming in first week and you are suspecting infection, so we usually look for extra pancreatic infection, we all know, and patient who have got say biliary pancreatitis, so we have to look for cholangitis simultaneously. In addition to that, most commonly we look for pneumonias and urinary tract infections. Bacteremia can also occur in patients, but most of the time we get UTI or pneumonias.
Thank you.
Almost 1/3 of the patient will be having extra pancreatic infections.
Yes. So around 1/3 of the patients may have extra pancreatic infections in a patient with acute pancreatitis. So as gastroenterologists, cholangitis is something which we have to manage in our domain. So one of the important questions that comes here is what is the time when we should do an ERCP if we suspect cholangitis. So ERCP is actually indicated for cholangitis only if the patient has acute pancreatitis and you have evidence to suggest biliary sepsis. So if you look at the ideal empirical antibiotics for patients with acute pancreatitis, the tissue penetration of antibiotics in pancreatitis is very important. And studies have shown the best antibiotics with good penetration into the pancreatic tissue are generally carbapenems, metronidazole or fluoroquinolones. So this patient was actually started on carbapenems. Now coming back to the case capsule, on day 9, because he continued to have fever, we got an imaging done, and this is the imaging CT, and which showed a lot of hypoenhancing areas showing extensive necrosis. There was only small amount of parenchyma which was enhancing in the distal body and tail, extensive peripancreatic fat stranding associated with ascites and bilateral pleural effusion, thus having a CTSI of 10 on 10. Now, to ask the radiologist, Dr. Kamlesh, how would you like to classify these pancreatic collections and what is the nomenclature according to the revised Atlanta classification?
Yeah, so if we talk of Atlanta classifications, the main takeaways, especially from radiological point of view, pancreatitis being divided into 2 types. So one thing is interstitial edematous pancreatitis and second is necrotizing pancreatitis. And based on the same, based on the timelines, whether we are talking of acute or after 4 weeks. So before 4 weeks and after 4 weeks. So before 4 weeks in interstitial pancreatitis, collections are peripancreatic acute collections, we call them. And in the necrotizing pancreatitis, collections are called necrotic collections, acute necrotic collections that can be pancreatic, that can be extra pancreatic or that can be combination of both. And when we talk of same thing after 4 weeks, so we use terminology for these plain cystic collections of interstitial pancreatitis, they becomes pseudocyst. And same thing with the necrotic collections, we call them walled off necrosis. So that's very important. Previously we used to term vague terms like phlegmon, infection, abscess, pancreatic abscess. All these collections what we talk about, again we say whether infected or sterile. So all those vague terms are taken out and these specific terms being used based on the interstitial or necrotizing pancreatitis and based on the timeline before 4 weeks, after 4 weeks.
Thank you. So yes, we have to divide these collections into either occurring with interstitial or necrotizing. When they're less than 4 weeks, they're acute pancreatic fluid collections which could be sterile or infected. And after 4 weeks, they become acute necrotic collections. You want to say
I would just like to add one thing. So in our case, what we are seeing is this is severe necrotizing pancreatitis involving the parenchyma as well as extrapancreatic tissue, more than almost 70% replacing the pancreas. Yeah.
So that is how we differentiate and label these collections. So coming back to our case, so in the 3rd week, the patient did not have any improvement in respiratory status. There were fever spikes daily, TLC was rising and antibiotics were upgraded. And at this time, at the 3rd week, again he underwent an imaging in the form of a CT because his fever was just not improving. And that showed peripancreatic and perisplenic collections extending into the left paracolic gutter and a large pocket which was around 13 into 4 centimeter in the region of the lesser sac. And one important thing to note here was that the patient was in the 3rd week, the wall of the collection was not yet well formed. And at this stage, patient is continuing to have fever, TLC is high, there are regular spikes, antibiotics are already being given. At this time, would you actually drain these collections or would you wait? And ideally, what does evidence say for timing of intervention in pancreatitis, early versus late? So Dr. Ajit, please.
I mean, he's running in 3rd week and it's not the ideal time to intervene right now. And we already escalated the antibiotic. Either we can wait for another 72 hours to see the clinical response with the escalated antibiotics, or if the patient is deteriorated with the escalated antibiotic, we can put either an endoscopic or percutaneous drain. Surgery is not indicated at this stage.
So we have several trials to this regard now. One of the important trials we have is the Pointer trial, which is actually forming a basis for our decisions these days, especially with immediate versus postponed interventions. So what this trial actually looked at is it took patients with infected pancreatic necrosis and randomized them into endoscopic drainage or percutaneous drainage, either immediate, that is within 24 hours of diagnosis of the infection, or late, that is after 4 weeks. And they actually found that there was no superiority in draining the collections earlier, and postponed drainage was actually preferred. Postponed drainage, the patients who underwent postponed drainage, that means after 4 weeks, actually required less number of interventions. And when you postpone drainage, around 40% of patients actually did not require any intervention at all, and only your antibiotics started working. So the trial clearly showed that you should wait as much as possible before diving into intervening in these patients. And there are several other studies also which looked at less than 4 weeks versus greater than 4 weeks of drainage, and they found that no early drainage did not offer a benefit in changing mortality, and it's always better to wait, and endoscopically centered step-up approach was actually better than surgery in all these patients. So our patient, the antibiotics were upgraded, but the TLC started to show a downward trend. And after 3 days of upgraded antibiotics, fever actually settled and patient improved, and the patient eventually was discharged. And this is the same case, like we said, 40% of patients actually do not require any drainage, and antibiotics eventually work, and this patient was then discharged. But then he presented 2 months later again, now with high-grade fever, pain abdomen, nausea, vomiting, again TLC rising, and evidence of systemic inflammatory response. And this is the CT that was done at that time after 2 months, which showed a wound with clear-cut wall and also a lot of air foci within. So in the panel, if somebody could comment whether this collection looks infected, and what is your take on it, and what do you actually see in this collection that tells you that the thing could be infected?
So yeah, the collection is favorably placed, centrally placed. Both the approaches are possible. So endoscopic approach is possible, percutaneous is possible. So preferably the patient is with GI people, and if endoscope, in any case, endoscopy, if possible endoscopic drainage, then that can be preferred. But many of the time the collections are at the periphery, in the lumbar region, reaching up to iliac fossas. Those are the collections which are not approachable from endoscopic approach, can very well be done with the percutaneous approach. For the percutaneous, especially, I will say one more scenario where anesthesia cannot be given. These cases can be done bedside, just under local anesthesia. There it is possible. Yeah, any.
So I think the collection is infected with a lot of air foci. And now actually we move on to the drainage part. So indications for drainage when you see such a collection, and what is the standard indications? Open surgery versus step-up approach. So what would you do? And endoscopic treatment versus percutaneous drainage with minimally invasive surgery. So what will you prefer in this case?
In this particular patient, the patient is having the gallstones also.
Yeah.
As an index, that's the cause of the pancreatitis. So I will do a minimal invasive necrosectomy along with laparoscopic cholecystectomy in this patient. If the patient is not having gallstones, then we can put a drains, percutaneous drain, and later we can modify a procedure. I mean, with the dilatation of the drain tract, and do a retroperitoneoscopy and necrosectomy and lavage drainage of the infected collection. But in this index patient, I will do a minimal invasive necrosectomy, surgical, with cholecystectomy in the same setting.
So I think, Saransh, what are the indications for drainage?
So I would also say that, but do you plan to do a surgical cystogastrostomy and debridement along with the lap cholecystectomy? Yeah, so this modality may be there, but if you are thinking of VATs, then VAD, then VAD will not look at the gallstone removal itself. So surgical cystogastrostomy with lap cholecystectomy may be one of the options for this patient.
So
yeah, that's it. So when we see a patient with infection, first of all, everybody must know how to interpret that CT. We were clearly seeing air foci in that CT. That's very important. You should see that CT and understand that this is what you can interpret from it. A lot of air may be due to a communication with the gut, but this is an infected necrosis. If there is infection, if there are compression symptoms like jaundice or gastric outlet obstruction, if there is pain, if the patient is having suspicion of infection, but you cannot find any other source, that is the time when in a well-defined collection you will look for drainage.
So there are several trials which have been done to answer these questions. So there is an important trial called as the Panther trial, again in NAGM, which actually looked at open necrosectomy versus a step-up approach, which included antibiotics and a percutaneous drainage, or antibiotics and an endoscopic transgastric drainage. And after that, a necrosectomy, either transgastric or by ward, as you were saying. So when they looked at the results, they found that a step-up approach, that initially antibiotics was then a pigtail and then necrosectomy was actually better. And only if you put a pigtail or if you drain by endoscopic methods, that drainage sometimes was successful in around 35% of patients, and no more necrosectomy was necessary. And when they looked at open necrosectomy and the step-up approach, they found the mortality to be the same. Now the next thing is whether you want to do it endoscopically or you want to do a surgical step-up approach, that is placing a drain and then catheter drainage and a ward. So this is also a Lancet trial, which is called as the tension trial. It looked at endoscopic step-up approach, that is EOS-guided drainage and necrosectomy versus a catheter drainage and ward. And they concluded that endoscopic and surgical step-up approaches were actually comparable to each other. That is, either you can do a endoscopic drainage and then necrosectomy, or you could place a pigtail and then do a ward. Both of these things had similar outcomes, so you can choose whichever is easier and available for you. And when they looked at these trials, there's another trial. Similar things were looked at it, which is called as the Miser trial. And in this, they actually found that the endoscopic approach was much better than the percutaneous drainage of these collections and infection. So both the trials together showed that either you do it transgastric or you do it percutaneous, there is no difference in mortality, and no difference tension trial, but favorable in the Miser trial. And you have to look at the kind of patients that were also looked at in this trial. They were all stable patients, they were all walled off necrosis, and therefore they were fit for endoscopic drainage. So where you have patients with infection, they are stable and they can undergo endoscopic drainage, then you can choose any of these modalities. On long-term follow-up also, they looked at either endoscopic or percutaneous drainage, and they did not find much of difference in the outcome of these patients, except that the pancreaticocutaneous fistulas that were there, that was more common in patients who underwent a PCD drainage. Now this patient actually, we took up for endoscopic drainage. So the next question is, EUS guided or would you do a direct endoscopic drainage? And what evaluation would you want to do if you want to do with transgastric drainage?
Yeah. So if the facility of EUS is not available in a center, then one must go for a direct drainage. Preferably if the patient has one obvious bulge in the stomach, then go for a direct, and there is no obvious aneurysm or vessels or varices in the CT scan. So before going for EUS guided drainage, we should look for few things. We should have a good quality MRI or CT. Look for the wall completely formed around the cavity, this WOPN, so that we can drain. Its relation to the stomach, its relation to the duodenum, whether it is in cross approximation, whether there is some collection in the paracolic gutters. We have to also look for aneurysms, because if there is any aneurysm in the vessels in the cavity, then we should go for a embolization followed by drainage. The other thing, we should also look for the disconnected duct syndrome, about the PD status, whether there is leak or disconnected ducts.
Okay. So where US is available, US is an important modality.
I wanted to add one point. We must also assess the percentage of necrosis in that collection. So that is also important. That can be done by MRI or by sonography. Usually CT does not give a very good answer in that. And second, I want to emphasize that EUS is now become the standard of care, and we must attempt to do it under EUS guidance.
Yeah.
Maybe we can check how many of us are still doing without EUS.
Yeah. So I think anybody here in the audience still doing a direct puncture of the cyst rather than a EUS guided drainage?
I don't think anybody is.
So I
and
think
that's not ideal also.
Yeah, even trials have shown that the risk of complications, especially bleeding, is much lesser in US guided drainage. The randomized trial also showed that. So when possible, you have to do a US guided drainage to keep your patient safe from bleeding. Now we come to the next tools. That the important thing is stents, which have actually improved our ability to do these drainages. So Saransh, metal versus plastic stents, what do you do? And now we have something called as the lumen opposing metal stent, and whether you use that versus a normal fully covered stent.
So if you look at the percentage of debris, if less than 30%, plastic is equivalent to metal stent. If more than 30%, you might need more necrosectomy sessions. Then metal is preferred over plastic stent. This was also supported by trials that if you have plastic stent, you have more re-intervention rate than metal stent. If I look at metal stent, if I have to plan a direct endoscopic necrosectomy, then I would prefer a lumen opposing metal stent than opposing a just a fully covered metal stent, because the migration rate is much less in lumen opposite metal stent. Anyhow, whenever we place a metal stent in a collection, it is important that after 2 to 3 weeks we remove that metal stent along with necrosectomy and replace it with a plastic stent. So you don't just keep them there and forget about them. You remove them after a time and replace it with a plastic stent. That's very important.
So the message is, when you have a lot of necrosis, you would want to use a metal stent. And in a metal stent, if you have an option between a lumen opposing metal stent and a fully covered metal stent, and if cost is not an issue, then lumen opposing metal stent is the thing to go, because most of these patients eventually will need some form of necrosectomy, and LAMS or a lumen opposing metal stent actually makes your life easier. And that's the major difference between these.
I'll just add that cost is always a major hindrance here, because LAMS, for the knowledge of audience, is costing about 2 lakh rupees. Yeah. So it's really not possible in most of the patients.
So metal stent, either LAMS or fully covered. So in this patient, the patient underwent a US guided cystogastrostomy, and we placed LAMS in this patient. And this is how it's done. The cyst is punctured and the stent is deployed between the collection and the stomach. So with the help of a LAMS, the procedure becomes easier, but yes, cost is a major constraint. Now, once you do this procedure, you have to be aware that if you're draining these collections, you have to be ready to go to the next step, that is to actually go into the collection and then remove the necrotic debris. If you're not ready for that, you should avoid doing this procedure. And when you do these procedures in your practice, Dr. Iqbal, what percentage of patients will actually need a necrosectomy after drainage? And do you immediately on the same day do a necrosectomy, or do you delay it till the patient actually shows some features of sepsis?
Nearly 40% will not require a necrosectomic session. Nearly 50 to 60% patient will eventually require this session. If we have two options like upfront or later, upfront we can do, there are trials which indicate that by doing the upfront necrosectomy, the reinterventions are less and hospital stays also less. But if by drainage 40% patients are okay, then why we should go for upfront? We can plan that later, necrosectomy.
So yes, so the best way to go about this is to do a step-up approach, and generally around 30 to 40% of patients may require interventions, and others will just get away by placing a stent. And if you look at patients who may require further intervention, are large collections, a large amount of solid debris, more than 30 to 50%, and in patients who have paracolic extension may require further intervention. So to answer the question of upfront versus delayed, the recent trial in Lancet GastroHep, which showed that actually both can be done, and they actually showed that if you do it upfront, the need for reintervention is reduced, it shortens the hospital stay, and there's no difference in adverse event, and it reduces healthcare costs. This is actually what the trial says, but most of us are actually more cautious, and even if you delay necrosectomy for 48 hours, it really doesn't make a difference. And it's always better to assess whether the patient has actually improved with the SEMS rather than do the necrosectomy, because as we saw in the data, around 40% of the patients do not require any necrosectomy at all. So you can just put a stent, wait, and only if the patient develops fever or if the patient develops features of sepsis, you can go ahead and do a necrosectomy. So our patient had multiple spikes of fever after drainage on day 2, and on day 2 the stent was actually blocked by the necrotic debris, and following declogging of the stent, the patient had to undergo 2 sessions of necrosectomy. Now, when you're actually doing necrosectomy, one of the important things that you have to consider is the adverse events. And what do you actually consider about while doing this necrosectomy, Dr. Thakur? So what do you think is one of the major problems here that it should be very careful about and you should have all the backup when you're actually doing this procedure.
So I think while doing necrosectomy, there are two important things. One is bleeding and second is perforation while doing a necrosectomy. And I have personal experience with this perforation and patient had to undergo surgery immediately. So these are the two things. Then stent clogging can happen because of, but that is a little bit later complication which you may come across.
So I think one of the most catastrophic events that can happen while doing necrosectomy is bleeding, which can be really troublesome, and that's where our radiology friends come into picture. You have to have a backup of a radiologist in case there's severe bleeding. You would want to take the patient up for angiography and embolization, and that's one thing you should be careful about. So this patient, the necrosis was cleared, the infected pancreatic debris was taken out, and the entire cavity was cleaned. And following which, as Dr. Saransh mentioned, after 3 weeks, the patient, the lamps was removed and no plastic stent was placed. So to wind up this panel discussion, the revised Atlanta classification for nomenclature of pancreatic fluid collections is today the standard. Early drainage versus late drainage. Suppose the patient has sepsis, early drainage versus late drainage, there's actually no difference in outcomes, but it is always prudent to wait until the collection is entirely walled off, which happens around 3 to 4 weeks. If there's worsening organ failure, then yes, you may be pushed to drain the collection early also, and in that case, a percutaneous drainage is always better. Endoscopic drainage with necrosectomy has similar outcomes to percutaneous drainage with or without ward, except for the occurrence of a pancreatic cutaneous fistula, which was seen to be more in patients with pigtail drainage. US-guided transgastric drainage should be considered wherever possible, and it should be preferred with vis-a-vis percutaneous drainage because of one important thing, that is the percutaneous fistulas that are formed. And metal stents preferred whenever you have a lot of debris in comparison to plastic stents, and where you expect to re-intervention rates to be high. If the patient can afford a lamps, that's the way to go nowadays. Around half of the patients will definitely require intervention after necrosectomy. So suppose if you are doing a transgastric drainage, you must be ready to go in and do a necrosectomy also if it comes to that. Upfront necrosectomy will reduce reintervention rates and hospital stay, but it needs more studies to actually validate that you should do an upfront necrosectomy, because as I said, around 50% of patients actually do not require any necrosectomy at all. And bleeding is one of the dreaded complications during necrosectomy, and it should be done only in centers where you have adequate backup to control the bleeding if it occurs. So with this, I conclude my panel discussion, and the house is open for comments and any questions. Thank you.
Thank you so much, Dr. Savan. I would invite any questions from the house. Before that, I wanted to add 2 comments to it. One thing was bleeding is a complication of necrosectomy. Bleeding can be avoided when you do a necrosectomy and you do not be over-aggressive about it. You take out only that debris which is lying freely around. You don't try to take out debris that is stuck to the walls. You can repeat the procedure if you need, but don't be over-aggressive. That's very important. Second, I wanted to emphasize what Dr. Kamlesh said, situations where you can do a percutaneous drainage. So sometimes the collection is not near the stomach. It extends to pelvic gutters or in lumbar space. There, percutaneous drainage is very useful modality to control the sepsis also. And you can even do a percutaneous necrosectomy in those cases once the drain size has increased. So it is also a very good modality. It is readily available. In small centers also it can be done, and it helps control the infection. So be aware of this modality and ask your intervention radiologist to guide you regarding that. Please, love question.
The same question which I was about to ask, sir, you have already answered, sir. Regarding the things, we have to know more about ward, sir. If we are doing a ward, suppose the CT is showing that the collection is predominantly in the paracolic gutters and it is not involving so much in the peripancreatic area, then we have to take a call for the ward, sir. Then what are the steps regarding this, and what actions we have to take care of the pancreatico-discutaneous fistula, sir? That fistula's part.
Yes, please.
I think the procedures, the management of acute necrogenic pancreatitis after 4 weeks for all the patients is tailor-made approach should be decided. Not all patients are fit for any one of the procedures. So if you are doing a minimal invasive necrosectomy and there are chances of pancreatic duct disconnection, There are the cases where the chances of persistent pancreatic, but in most of, you asked for? Yeah.
Actually, I have a question that you take out the metal stent and leave the plastic stents forever. So now I have done a lot of patients and I am getting patients with migrated plastic stents which have the coil inside and inside the cavities, and one patient even presented with a pseudoaneurysm. This was the plastic stent. This is after 7 years of drainage. So what is the recent concept? Should we remove the stents after maybe 3 months, 4 months, 6 months?
Yeah.
Or we leave it forever like that? Because now I am finding such patients who are coming with all these complications.
So I didn't cover it because of the lack of time. So disconnected pancreatic duct is a complete topic in itself. So the most important thing to do is when you have a LAMS and you remove it, you do an MRI before that, see whether the patient has a possibility of a disconnected pancreatic duct. In fact, this patient did have disconnected pancreatic duct because the necrosis is so much, obviously the duct is disconnected. Now, if you have a disconnected pancreatic duct, only then you need to put the plastic stent when you replace the metal stent. Suppose they can see the continuity of the duct or there is no parenchyma viable at all to cause, you don't need to put a plastic stent. The second issue that you face is it's easy to say put a plastic stent, but when you actually do it, the entire cavity is collapsed. And many a time, even if the patient has disconnected pancreatic duct, there is no place to put a plastic stent. Once you remove the lamps, there is no place to put. In such a case, the recommendation is don't put a plastic stent and just monitor the patient for redevelopment of collections. But in case you can put a plastic stent and the patient has pancreatic duct disconnection, then you put a plastic stent, and obviously there is no recommendation on when to remove it, and for now the recommendation is to leave it for lifetime. Yeah, so before it gets atrophied, the problem is the collection recurs. So if the collection recurs, then you end up doing another cystogastrostomy. So if you have a distal viable pancreas, it is still recommended that you place a drainage until, of course, we have further evidence saying that there's too much complication.
I think there should be some work on them, some guidelines for its removal also.
So, so one issue was that replacing a plastic stent while you are taking out the lamps. So what about doing a conventional pancreatogram rather than an MRCP once you remove the lamps? That is number one. And the second issue is that this is the late story of the pancreatitis. What about the early stage? Do you still go with routine use of antibiotics? If you use routine antibiotics in early stage, do you see more fungal infections, more MDRs in the later stage?
So there the question, the question would be, what do you consider early? What according to you will be early? Is it less than 4 weeks or greater than 4 weeks? Or whether it's the first week?
First week.
So first week antibiotics are not recommended. Let me be very clear about that. Even in this patient also, in the first week there was no antibiotic that was used. Only when the patient then, second and third week, it's a gray zone. Still we don't know whether there is only systemic inflammation or whether the infection has already set in. So I think it's prudent to say, I mean like practical to say, in the first week, don't use antibiotics even if the patient has fever or if the TLC is high. But as you move on in the course of pancreatitis, there has to be a timeline when you will actually start using antibiotics. That is not very clear. So second and third week, I think it is quite okay that if you start, if the patient is worsening organ failure, if the patient is worsening organ failure, not doing well, there you can probably use empirical antibiotics, and the best are carbapenems, fluoroquinolone, metronidazole.
I think we'll wind this up.
Thank you so much, Dr. Savan.
Thank you.
It was a wonderful, very fruitful discussion on acute pancreatitis with infection.
Can I make just one point, sir, if you allow? This regarding the leaving the plastic stent in situ after the LEMS removal in case of disconnected duct syndrome. So there is a fear that the cyst will recur, right? So that you want to leave that stent for lifelong. But again, there is an apprehension regarding the migration of that stent because you are leaving that thing, and we know that the prognosis and this behavior is very unpredictable. Why not to send these patients to a surgeon for the definitive surgery in the form of cystogastrostomy rather than leaving a stent in situ with very unpredictable behavior?
The number of people who actually require this leaving the stent in situ is very, very small.
Yeah,
For that sake, all patients doing surgical cystogastrostomy
no, not
would
all
be
patients. Not all patients. You have MRCP or CT scan, whatever.
You mean when the cyst recurs?
I think that's a fair option because most patients will not need it. We move on.
Thank you everyone for this wonderful session on acute pancreatitis. So the next session is management strategies on acute cholecystitis, acalculous cholecystitis. For this, I invite the chairpersons, Dr. Arvind Rai sir, Professor of Surgery and ex-Dean in GMC Bhopal, Dr. Abhijit Deshmukh, Senior Gastrointestinal Surgeon, Bhopal, Dr. Sudhir Singh Pal, Neurosurgeon at GMC Bhopal, and I call upon speaker Dr. Uday Somshekhar sir, Professor, Department of Surgery at NSCB, Jabalpur.
Good morning, ladies and gentlemen. My thanks to Dr. Sanjay Kumar and the organizing team for having given me this opportunity to be talking today. Let us start off with this case scenario. So this was an elderly male who was a diabetic who presented with sepsis with pneumonia, and he was admitted and in the ICU. He was put on ventilatory support and on vasopressors. Following this, he showed some clinical improvement, but by day 4 in the ICU, there was deterioration, and the patient developed fever, there was tachycardia, and the patient again had worsening of his blood pressure, the hypotension developed. On examination, on abdominal examination, the abdomen was distended, and there was some tenderness in the right upper quadrant, especially on deep palpation, but there was no significant guarding or rigidity. His lab parameters showed a rise in the WBCs. There was also some alteration in the liver function, and ultrasound of the abdomen showed a distended gallbladder. There was edema in the gallbladder wall, there was pericholecystic fluid, and there were no gallstones seen on the ultrasound. So based on this clinical scenario and the ultrasound, possible diagnosis of an acute acalculous cholecystitis was made. And then let us see what literature says about how do we manage this condition. So this is an uncommon problem. It occurs in only around 0.2 to 0.4% of the critically ill patients. But the problem is that it carries a very high mortality of nearly 30%. And that is primarily because these patients are critically ill, they are elderly, they have comorbidities, and often the presentation is vague. It is not recognized in time, leading to difficulties in management of the patient. There is also an increased risk of perforation and of developing gangrenous gallbladders. Quite a significant difference between the calculus and the acalculous disease. We can see that in the acalculous cholecystitis, the mortality and the chances of gangrenous cholecystitis are much higher. So these are the risk factors which are known to be associated with the development of acute acalculous cholecystitis, severe illnesses, severe trauma, major surgeries, burns, sepsis. These are all known factors, which also can, other factors which can contribute include patients who are on immunosuppression, patients who have vasculitis, and who have obesity, diabetes, and hypertension. So not only that, patients who are immunocompromised, they also have other chances of they also have opportunistic infections which can further aggravate the problem. So this is the underlying pathophysiology. If we can see, okay, I can't make the laser pointer work here, but if you look at the center, there is shock. The shock by itself can lead to a decrease in the splanchnic flow. Also, use of vasopressors will cause a decrease in the splanchnic flow, and these will cause a decrease in the blood flow to the gallbladder, causing gallbladder wall ischemia. Prolonged starvation, use of parenteral nutrition, and other factors which will reduce gallbladder motility, all of them in turn will lead to a reduced contractility of the gallbladder, These in turn will lead to gallbladder wall ischemia, they will cause bile stasis, there is gallbladder distension and increased pressures in the gallbladder. These would lead to an increased risk of perforation, and the stasis can have an increased risk of gallbladder seeding with bacteria, and the ischemia can lead to bacterial translocation. So because of all of this, there is development of the acute acalculous cholecystitis. So in addition to the conventional features of a patient with cholecystitis, what is important for us to recognize is these patients may have very masked symptoms in the form of worsening of the sepsis or a change in the mental status, which must not go unrecognized. The ultrasound when the bedside is probably the mainstay of diagnosis. So there are certain major and minor criteria which have been listed. So if we have two major criteria, or if there is one major and two minor criteria, then these would raise the suspicion of the patient having acute acalculous cholecystitis. Similar kind of criteria have also been mentioned on CT scan. The CT scan may have been done for other conditions, or if the ultrasound has not been explanatory or diagnostic for us. There has also been some literature about the HIDA scan. The HIDA scan, if it does not show filling of the gallbladder after the installation of the contrast, that would suggest that the cystic duct is blocked and the gallbladder is inflamed. However, the problem with this modality is that it is not practically usually feasible. There are a lot of challenges in the day-to-day implementation of it, and so most often it is not commonly used in clinical practice. Based on the severity of the symptoms and based on the ultrasound findings, one can classify these patients according to the Tokyo classification from grade 1 to grade 3. Grade 1 would be healthy patients with minimal changes on the ultrasound, and going on to grade 3 in which you would have end organ dysfunction. So depending upon the severity of the symptoms and the changes on the ultrasound, one can classify the patient, grade these patients into different classes. Treatment options would include antibiotics, surgery in the form of cholecystectomy, and very importantly for these ill patients is gallbladder drainage. This gallbladder drainage could be in one of three forms: a percutaneous route, an endoscopic transpapillary route, or what has come up over the last few years, especially the US-guided gallbladder drainage. As far as antibiotics are concerned, obviously the first line when you start off these patients has to be broad-spectrum antibiotics awaiting the culture reports. These broad-spectrum antibiotics by themselves are not probably going to be sufficient. We need some additional therapy. The antibiotics should be continued for at least 4 to 5 days beyond the control of the source control for these patients. As far as the choice of antibiotics is concerned, one can be guided by the class of the patient, but overall you can see most of these patients would need either a third generation cephalosporin with metronidazole, or you would need piperacillin tazobactam with metronidazole. So one of these kind of combinations would be needed. And for the extended ESBL producing organisms, similarly, you would either need the carbapenems or piperacillin tazobactam and metronidazole. As far as surgery is concerned, probably cholecystectomy would be the final treatment modality. But when it is indicated, it should be done early. It should not be delayed, preferably within 24 hours before the patient deteriorates. When done in the acute settings, it should be done for all patients who are physically fit, or if the disease is advanced, the patient has developed gangrene of the gallbladder or a perforation of the gallbladder, which necessitates surgery. So these are the patients in whom you would offer surgery in the acute settings. Electively, some patients may need surgery. These are patients who have been managed with gallbladder drainage initially, but after that initial problem is over, then they can be offered surgery at a later date. Coming to the drainage options, what has been the mainstay till now probably has been a percutaneous approach, usually under ultrasound guidance. It could be a transhepatic or a transperitoneal route, and it is very successful, more than 85% success rates with the procedure. Compared to surgery, it reduces the cost, it reduces the mortality, it reduces hospital stay. What needs to be realized is that once the gallbladder drainage is over and the patient has stabilized, then after 6 weeks, this patient could go on to surgery. Or if the patient is otherwise stable, at 3 to 6 weeks, maybe the tube could be removed. If the cystic duct has shown to be patent on a contrast X-ray, then the tube could be removed and the patient could be followed up. The second modality is the endoscopic approach, that is an ERCP approach to put in a stent through the papilla into the gallbladder, but it is technically more demanding. It more needs a greater level of expertise. And what is third now, which has come up, is the EUS guided approach. The EUS guided approach basically involves the placement of a stent or a LAMS through the duodenum or the stomach into the gallbladder. It has a very high success rate, and it has adverse events which are acceptable. This has specifically increased now with the use of LAMS and with the availability of the hot axios, which has enabled the procedure to be done with minimal complications and with more ease. If we look at all the three options of the gallbladder drainage, you can see that the success rates are highest with the percutaneous route and the US approach. Complication rates are similar in all of them. The recurrence rates are least with the LAMS, and therefore it is considered that when patients have been treated with LAMS, then maybe we can treat them only with the LAMS and not go on to any other further treatment. As far as literature is concerned, you can see that the EUS guided approach has been proven to be better in all respects over the percutaneous approach. The caveat here is that all of these trials that we have, they have a mix of all patients of both gallstone disease as well as acalculous. So we do not have literature specific only to acalculous cholecystitis available to us at the moment. So if we were to draw an inference from this, if an expertise is available and the patient is fit, then probably an US approach would be better. If the resources are limited or if the patient is unable to undergo this procedure, then the percutaneous approach would still be the gold standard for us. One thing that needs to be considered here is that when we put in a LAMS, we are creating a 1.5 centimeter defect in the wall of the duodenum or the stomach. So subsequently, if this patient were to need surgery, then it creates a more complex surgery. It creates a surgery which is more difficult because we also need to tackle the fistula that we have created by putting in the LAMS. So there is a school of thought which says that if you envisage that this patient is going to need surgery later, then it would be better to do a percutaneous approach rather than put in a LAMS. However, it is not a necessary rule about that. There has now been some meta-analysis also on this, that even after putting in a LAMS, it is possible to do a surgery successfully, but still the consensus of opinion would be that if surgery is planned subsequently, then probably a percutaneous approach may be better. So the final question which needs to be answered is that do patients of acute acalculous cholecystitis who have undergone a drainage, do they need any definitive surgery at all or not? This is quite in variance with calculous disease where you would advise surgery for all. However, in an acalculous cholecystitis, if the triggering event has been relieved, the gallbladder has been drained, then these patients subsequently the problem may never recur, and therefore surgery is not mandatory in all of them. We can have a selective approach that patients who become fit for surgery or patients in whom there is a persistence of the problem or recurrence of the problem, or those subset of patients in whom a follow-up ultrasound shows as gallstones which had been missed earlier, these are the patients who should be offered surgery, but otherwise surgery may not be needed for them subsequently at all. So to just summarize, we would have that it is an uncommon entity but carries significant mortality, and we need a high index of suspicion to diagnose them, treat them aggressively. If possible, take these patients up for surgery. Otherwise, gallbladder drainage could be life-saving. An endoscopic US-guided approach is probably the best if possible, but if not, then a percutaneous approach would be good. And all of these patients do not necessarily need surgery subsequently. We can have a selective approach for these patients who would need surgery subsequently. Thank you.
Thank you, Dr. Uday. The house is open for any questions from the audience. I think there are issues relating to ICU patient with sepsis and suggestive of acute cholecystitis along with it. So to differentiate between sepsis due to other causes, in the ICU setting, a lot of other things are going on in the abdomen, so that becomes a big tricky to diagnose it comprehensively, because we come across so many patients of viral infections where the peritoneal thickening, the edema of the peritoneum is quite significant. and sometimes to differentiate between acute cholecystitis, acalculous cholecystitis, and a general edema of the peritoneum would be difficult. One.
Yeah, you're right, sir. That is why to help us narrow down these guidelines on the ultrasound, that any gallbladder wall edema should not be labeled as acalculous cholecystitis. Quite often the ultrasoundologists report there is gallbladder edema, so they report it as acalculous cholecystitis. It is only if you have those major or minor criteria, then you could, with some degree of reasonable assessment, say that it is acalculous cholecystitis.
Definitely, definitely. The other issue probably is related to sludge or microlithiasis. Basically, some literature does say that if you find sludge in the gallbladder, probably it indicates a presence of microlithiasis, which would, even if you treat the patient in a minimally invasive, by endoscopic or percutaneous method, and or it subsides with antibiotics, these are the patients who would definitely need surgery even once the primary source control is done. So one thing is that, and the selective approach of not offering surgery, a little skeptical about that. Being a surgeon, probably that that option appears to be a little out of place for me.
That's perhaps because most of these patients are too sick to undergo surgery at that time. These are ICU
immediately,
patients.
yes,
Yeah.
but
So
at a later date.
Yeah, only if sludge is persisting, and we can always follow them.
As far as the LAMS was concerned, probably the stones pass away, or microlithiasis or the sludge that passes away through post-operative, they'll have a better outcome. But again, as you said, surgery might be difficult in these cases.
Right, sir.
Thank you.
So which one? It was slide changer.
Can MOCs announce the next session? Or shall I do it?
So for the next session, we have a very short 10-minute session on interesting facts, pearls of infection.
Yeah, so before sepsis, we had our DNB residents has prepared a small quiz because people, even after morning breakfast, sometimes can doze off. So just to, awaken you. So Akshay will read out certain sitters. These are simple questions. So
Good morning, everyone. In between the session, we will take a small question answer session. This will be taken as in a question answer format. Questions will be displayed on the screen, and someone, especially young audience, will come on the mic and answer the question. So the first question is, a 35-year-old male from rural area presents with high-grade fever since 7 days with headache, myalgia and mild jaundice with bilirubin around 2.5, AST ALT 180, 150, ALT mildly raised and platelets 90,000. On examination, there is a painless black necrotic lesion seen in the axilla.
Say loudly. Scrub typhus. This is Ishar of scrub typhus.
So what will be the most appropriate next step?
Doxycycline. So our audience is very aware. Next.
After removing 6 liters of ascites fluid, what is required? No albumin, 20 gram, 40 gram, 48 gram, or only saline?
48? 6 to 8 grams per liter. Right.
Next question. An immunocompromised patient presents with odynophagia. Endoscopy shows large linear ulcers and characteristic histology pattern.
Practicing gastroenterologists are not allowed to say answers. So what is this picture suggestive?
CMV esophagitis.
CMV esophagitis. This we discussed yesterday.
A patient of H. pylori initially taken standard H. pylori triple regimen but fails sclerithromycin triple therapy. So the next best regimen will be...
What is the next best regimen? Quadruple regimen. People know everything here. Best proven strategy to prevent post TRCP pancreatitis. Antibiotics, rectal endomethacin, PPI, steroids, heparin. तुम्हें नहीं बोलना है. Rectal endomethacin, though we practice other things also like putting a pancreatic stent and IV hydration. But yes, rectal endomethacin for all nowadays.
Best test to confirm H. pylori eradication.
Eradication.
IgG serology, RUT, stool antigen, culture or histology.
Best time is 6 weeks. That means 2 weeks treatment, then 4 weeks after that. Rightly said by someone, stool antigen. We can do urea breath test also, as we discussed yesterday.
Patient on steroids present with odynophagia. Endoscopy shows following picture.
Endoscopy shows what?
What is this? Best treatment?
Fluconazole. So candidiasis, fluconazole.
Next, a patient with UC on remission with tofacitinib suddenly presents with 8-9 episode loose stool since 3 days with blood and high grade fever. Sigmoidoscopy shows following picture. What is the picture?
Patient on tofa develops such lesions. Sigmoidoscopy. ये भी कल discuss हुआ. Is it flare, is it C. difficile, CMV or eosinophilic? So the picture is classical of CMV colitis because we can see large deep ulcers.
A cirrhotic patient with ascites presents with fever.
Something we
Ascitic
discussed.
fluid shows PMN neutrophils 800, protein 2.5, glucose 30 and LDH elevated. What is the next best step?
There is some catch.
Either start cefotaxime or start peptase, immediate laparotomy, repeat paracentesis or add albumin.
No, I think there are good pointers in this. He said, Mohit said rightly, I think, this immediate laparotomy because glucose is low and LDH is elevated. This is secondary bacterial peritonitis, not SBP.
A 24-year-old male presents to ER with complaints of retrosternal burning and coffee ground vomitus since 3 days after prodrome of fever. Upper GI endoscopy shows following picture. What is the diagnosis?
A classical picture, not very often seen in upper GI endoscopy. Nobody? Candida, CMV, HSV or GERD? It is HSV. I think we'll stop here. Ab to jaag gaye sab log. Thank you very much for your attention. Now I'll proceed with my sepsis panel. Can you invite the panelist?
I'd like to invite upon stage the panelists for this session, Dr. H.P.
Situation has changed in last a decade or so. I never thought of sepsis as a major issue till I did my MD medicine, but realized soon that it was not uncommon. I used to start seeing cases, but now I would say that the sepsis is rampant. In fact, sepsis is one of the most frequent causes of death worldwide, representing 20% of all global deaths. It's a huge figure. Almost half of the estimated sepsis occurred in children under 5 years of age. For every 1,000 hospitalized patients, 15 will develop sepsis as a complication of receiving healthcare. So healthcare associated is very common. It's more common in lower middle income countries, and the cost of treatment is exorbitant. In our country, it would be about 30 lakh rupees per patient, although this is transpolated from US data. Key facts about sepsis is that it is usually caused by bacterial infections, but can be due to viruses, parasites, fungi, as we saw in COVID. Originates commonly as pneumonia, UTI, or GI tract. Sepsis acquired in healthcare setting is often due to resistant pathogens. Early diagnosis and timely management increases survival, and this is what we'll be discussing today. Every minute of management in sepsis is important. And preventive measures, good hygiene practices, vaccination, sanitation, and water quality, they will go a long way in preventing sepsis. People who are prone to develop sepsis are older persons, pregnant ladies, or recently pregnant women, neonates, hospitalized patients, ICU patients, patients with weak immune systems, HIV or cancer, people with chronic medical conditions like CKD and CLD. So in day-to-day practice, we see many patients OPD who come walking, but we feel that they are in sepsis. It's very difficult to take a decision. Sometimes he has come with a mild fever of a day or two, but he has fever, tachycardia, rapid breathing, confusion, body pain. TLC is raised, hematocrit and CRP are raised, borderline raised BUN, OTPT. So there seems to be a little multi-organ involvement. You know that this patient could be in sepsis. It's very difficult to convince them for admission, and more so for ICU admission. So I think with this, we know that sepsis has got many challenges. So we have devised this panel discussion based on a case. You already know the panel and the expert discussant. So we'll start with the case. We had a 24-year-old female who came to us with abdominal pain and distension 5 days, vomiting for 3 days. She had lap cholecystectomy 22 days back somewhere else, and an upper GI endoscopy and stent removal was done 5 days back. There was history of ERCP and stenting 1 month back. So ERCP 1 month back, then 8 days later she underwent lap chole, and somebody removed a stent about 5 days before coming to us. So when she came, she had tachycardia, hypotension, respiratory rate was 32, ABG showed severe metabolic acidosis. She had to be intubated immediately. Vasopressors had to be started. She was on fluid resuscitation. So she was in frank sepsis. You can see here that the TLC was 36,000, platelet 25,000, BUN 45, creatinine 2. Bilirubin was raised, but OTPT was normal, alkaline was normal. Procalcitonin at admission was 4.85. CRP was 329. So we sent cultures, antibiotics were started, Mero, Poly and Ciplox. We'll discuss why this. Arterial line, invasive monitoring, low dose steroids. NCCT abdomen was done because she had raised creatinine. It showed moderate ascites with internal septations, mesenteric edema, soft tissue and subcutaneous edema. So we had a collection in the abdomen, and the first thing was to drain it. 3 pricktails were put by our interventional radiologist. Subhepatic drain brought some bilious fluid, even pelvic showed bilious, and pleural fluid on the left showed straw-colored fluid. Next day she was clinically better. ERCP we did because she was settled down. We found a major leak in the lower mid CBD, and we placed a fully covered SEMS because the leak was too big. And the drain culture showed carbapenem resistant Klebsiella. Day 4 to 5 she was clinically better, drain output reduced, vasopressor reduced. We extubated her on day 6, mobilized on day 7, but continued on prophylaxis for DVT, enteral parenteral feeding, shifted to HDU. But on day 9 she had high grade fever with chills again, and she was hypoxic, shifted to ICU, again intubated, moderate ascites. On this time we could do a CECT, showed similar findings, but a hydropneumothorax. Perhaps it was iatrogenic. Mini laparotomy was planned on this because now she had gone into secondary sepsis, and we knew that there were a lot of collection in spite of putting 3 drains, in spite of putting a fully covered SEMS in the bile duct. Antibiotics further stepped up, Ceftavi, Azinam, TG. Day 12 she was better, shifted out on day 16. Procalcitonin came down, antibiotics de-escalated. So in summary, we had a young female who had history of surgery and major endoscopic intervention, presented with septic shock, required extensive ICU management, antibiotics, fluid, invasive lines, source control was done, IR plus endoscopic both. Laparotomy was done for persistent intra-abdominal sepsis, nutrition and physio taken care of, and she was with her for more than 20 days, so required a lot of counseling and daily briefing. So based on this, I would start my discussion with my elite panel. So firstly, Dr. Rajesh Bhagchandani, how do you define, for the benefit of our audience, how do you define sepsis, septic shock and SIRS?
I would like to take in a reverse order, like SIRS, that is systemic inflammatory response. Now, systemic inflammatory response is the acute inflammatory response due to any insult, including infection or non-infection. So in that we measure temperature, heart rate, tachypnea and white blood cell counts, and that is basically done once the patient is admitted. Now second we will go to sepsis. Now sepsis is a life-threatening, it's a dysregulated immune response of the body where the cause of SIRS is an infective organism. So all sepsis are SIRS, but all SIRS are not sepsis.
Right.
Then once the diagnosis of sepsis is confirmed, now the first goal is to do a volume resuscitation by a fluid, maybe RL or normal saline, appropriate, whichever it is.
That we'll discuss.
That is different story. Now, if this shock is refractory to fluids and is requiring inotropes, that is known as septic shock. So the idea is to recognize all these things in a rapid manner, because sepsis once diagnosed is making a detrimental harm to the body, and it should be recognized early.
Well said.
So that's why it is the class.
Yeah, so SIRS will be the presentation in all based on the vitals, and then you can categorize as sepsis or septic shock. So Dr. Saurabh Sehgal, how can you quickly assess a septic patient on admission, because time, as I said, is very important, and do you regularly follow a scoring system?
Sir, as you have given in your case scenario, the patient had tachycardia, hypotension and metabolic acidosis, and most important, tachypnea. I think so. Most critical indicator of anything is the tachypnea. It can be due to metabolic cause or it could be a respiratory cause. So 2001 we started with SIRS. Then in 2012 we came with some quick SOFA, and again sir we are back at clinical emergency warning scores. Only sir half a minute about Q SOFA. What happened sir in 2012? Q SOFA was quite promoted. Important thing is they took 3 things. They said respiratory rate, blood pressure and altered sensorium. And if the score is more 2, then you shift to ICU. But what the problem was occurring, the patient deteriorated much more. So we get a call of sickle cell crisis. The patient is having respiratory distress, but the resident says, sir, abhi unconscious bhi nahi hai, BP bhi theek hai. And you miss all those hours. So sensitivity is hardly 23%. So sir, we are old back to 2001 system where we look all vital parameters which you show, metabolic acidosis, hypotension, tachypnea, I think so is the most important indicators combined with low urine output. These patients needs ICU care.
Perfect. So no individual scoring system can help you, although you have scoring like News, Muse systems are, even Trius has come, which is targeted. QSOFA has been in use for many years, but as you said, it is very important to keep a watch on each and everything. The hypotension, especially the respiratory rate and the lactate levels are important. So Dr. Yadav, do you start empiric antibiotics before taking cultures? If at all, which antibiotics and how soon?
See, in sepsis, antibiotics are very important tools to reduce the mortality, and this should be started as soon as possible. The time guidelines are within 1 hour. And
within 1 hour of admission?
Within 1 hour of your admission. And before starting the antibiotic, we should take the cultures. But whenever the facilities for taking the cultures are not available, like in remote areas, but antibiotic administration should not be delayed for waiting for the culture. And now regarding the choice of antibiotics, like in this patient, it is intra-abdominal infection. Patient, there is a history of abdominal surgery and interventions, ERCP, stent removal, and most common organism in intra-abdominal infections are gram-negative. The patient should have coverage for gram-negative. And another thing, this patient is having the severe sepsis, septic shock. So in this situation, we should cover the resistant organism as well. And the other indications for covering the resistant organisms are previous exposure to antibiotics, exposure to hospital, and this patient has all these things in history. We should cover the resistant organism also.
So as rightly said, you should start within 60 minutes. Even in ambulance, you can start. Decide on clinical grounds rather than PCT. Infusion, as discussed in the morning, is preferred over bolus. De-escalate when cultures are available. This is from Surviving Sepsis Guideline 2026. Use PCT plus clinical evaluation, not only PCT.
News 2 guidelines are recommended that you can start antibiotic while in ambulance. So the administration of antibiotic can be preponed in the sepsis. Right. And for one more clearance, that the term severe sepsis has now been redundant. It is now
only septic shock,
because sepsis itself is severe.
True. So Dr. Chakravarti, how should we take samples? That's a very critical step. And how many cultures would you recommend? And are there some rapid identification techniques available? Although we discussed in the morning in the cirrhosis panel also, are these feasible?
Now the thing is, you have to, the patient is in sepsis, you have to start antibiotic. So by that time you are doing laparotomy or anything, patient is already exposed to antibiotics. So very unlikely in this kind of scenarios anything will grow. Now what we can do during laparotomy in OT itself, we can inoculate those samples, one aerobic and one anaerobic blood culture bottle. That will help to grow. Although in those blood culture bottles, meropenem neutralizing regimen is not there, but there are more chances to get a positive culture, because from intra-abdominal, all those lavage sample, there is no rapid identification method. Once the culture grows anything, then and there you can do some rapid identification like Malditov or Carba, Carba-NP, all those things.
NGS.
For carbapenemase detection genes.
So how many cultures samples?
One aerobic, one anaerobic of that fluid
from two different sites.
That is blood culture, sir. And that introp lavage sample, that is also should be inoculated in culture bottle.
So I wanted to convey that if you are taking blood cultures, take from two sites at least.
Definitely two
and
sites.
Concurrence of the two reports will confirm that your diagnosis is right. Dr. Sandesh Sharma, what is the current recommendation for fluid management, liberal or restrictive? And what is role in your practice in the post-operative patients of using procalcitonin?
So the current recommendation is restrictive food management to the tune of, and it has to be individualized at the rate of around 30 ml per kg body weight for the first 3 hours till you achieve a reasonable capillary perfusion. Fluid overloading is to be avoided for the chances of potentially pulmonary complications. As far as role of PCT is concerned, in post-operative patient. So PCT help in actually differentiating between SARS versus infection like sepsis, and PCT also help in actually de-escalation of the antibiotic. So much so, according to surviving sepsis guidelines, this has also been recommended as a tool to discharge the patient who has an insult of the sepsis.
Ninad, you have to add something about the hydration. How do we do check capillary refilling?
So after all the monitoring, we have moved back to capillary refill time being a monitor of fluid resuscitation. But in most of the septic shock patients, initially it was a 30 ml per kg since last 12 years, which has changed in these guidelines now. That 30 ml has moved, and now it is fluid resuscitation with dynamic indicators of resuscitation being seen via bedside ultrasound, a capillary refill time, and looking at your lungs, whether they are being filled with the fluids that you are giving.
So good role of bedside ultrasound also to look for B lines actually. So fluid monitor, as Dr. Sandesh said, it's more restrictive now because people were giving a lot of fluids and people were developing ARDS and more complications. So Ninad, again to you, what is the role of multiplex PCR in a septic patient? We discussed this for stool, and how feasible these tests are.
So these are good tests for bacterial identification. There are various panels which are available, but it has to be kept in mind that they are just going to identify bacteria in the secretions you send. Plus, the panel you send, it has to ensure that वो bacteria आप जो identify करना चाहते हो, that is included in it. Plus, it also identifies dead bacteria. So they can help us with identification of a bacteria, but it may be polymicrobial, it might be dead, and it might not be the causative organism in this case.
I think this I can skip because of want of time. So after that, once we have a patient for initial stabilization, once you have done, how to assess in ICU? Do you do hourly, 2 hourly, or a daily basis? Obviously, it is a continuous monitoring of heart rate, BP, urine output, TLC. So basic things have to be monitored, and that helps. And consciousness, as Dr. Saurabh said, general well-being. So do you apply any scoring systems during this, Dr. Saurabh? During this time?
Sir, basically what we can, heart rate, BP, urine output, we monitor hourly. TLC, we do it for the septic patient daily. Other thing is that you can calculate the SOFA score and see what is happening to your SOFA score, whether it is rising day-wise or it is falling down.
So scores like SOFA are good in the sense that they are sequential. Sure. They help you in sequential monitoring of these patients as far as the organ dysfunction are concerned. Role of AI at this stage, Ninad, any comments? Are there any approved models?
So now we are in the AI stage now. FDA has approved immunosepsis model. But the problem with all of this LLMs is that they are trained on Western data and they need electronic medical records. If you try to apply that score in India, say in monsoon season, we might pick up septic patients wrong and miss some patients. So Indian data is needed. In India, we still don't have any.
So AI will come in perhaps, but not a ripe time for this at the moment. So as I said, after initial resuscitation and antibiotics, the source control becomes the most important thing. So how urgent it is or emergent it is, Dr. Yadav, like in a case of liver abscess, how early you would like to intervene in terms of drainage, and to Dr. Sandesh for surgical patient.
So source control is very important in management of sepsis and should be done as soon as possible after optimizing the patient. And without controlling the source, you cannot stabilize the patient in many situations. And recommended guidelines should not be delayed more than 6 hours. Like your patient, you did the ERCP, and after stabilizing the patient and try to control the sepsis by putting the drains. The source should be controlled as soon as it is possible.
As soon as the patient is stabilized. Dr. Sandesh, in case
of
optimizing
the patient.
Yeah. So like appendicular perf, we often see patients who have come in sepsis. So would you like to put a drain, or you would like to go upfront for surgery?
So regarding difference between the urgent and emergent is, emergent means doing something which will help in stabilizing the patient and also controlling the infection part. So if somebody is having an appendicitis with the features of sepsis, this patient required an emergent surgery. But somebody having an acute appendicitis but did not have features of sepsis, then the surgery can be deferred till the patient gets adequate hydration as well as antibiotic. So it could be done anything between 12 to 24 hours.
So that's a very common situation. This patient is in shock and we know that there is a perforation, appendicular perforation, but the team feels that the patient is not very fit for immediate surgery and the mortality could be higher. So it's best to settle the patient. It's not necessary to operate patients at 12 midnight or night. You can settle them for few hours, maybe 6 hours or so, and then proceed. So source control remains the mainstay of treatment, and then the antibiotics and of course targeted sepsis interventions. So another situation which commonly creeps in septic patient is that they develop some cardiac dysfunction, either ACS, global hypokinesia on echocardiography, or as we sometimes call it, septic cardiomyopathy. So Dr. Rajesh, when do you suspect, how do you confirm, and do TROP-I, CKMB and ProBNP help in this regard? Yours and Dr. Saurabh's comment.
Yeah, in sepsis, when you are putting a lot of fluids and antibiotics and inotrope supports, the patient with the concurrent sympathetic overactivity is very likely to go into cardiomyopathy. And these patients, they do show very often the myocardial injury, sometimes sepsis-induced cardiomyopathy is also seen. So TROP-I and CPKMB are raised, and that can be predicted. If the patient is already healthy, anti-pro-BNP can be done, which will give you an earlier sequence that yes, this patient is likely to go into heart failure or a pulmonary embolism. So these patients can be picked up in a very early stage.
Dr. Saurabh?
Sir, what happens like you are pumping fluids, you are increasing vasopressure, still the BP is not rising up. Then only thing which can diagnose septic cardiomyopathy is just do a echo. Echo may if the ejection fraction is low or your LAP is high, we do E by E dash. It could be either as a systolic or diastolic, but EF has to be low and the patient left atrial pressures are too high. Then we suspect the patient is having septic cardiomyopathy. So it is main of echo. Then sir, TROP, you all know it's non-specific. It is
not
just
useful in sepsis.
Sepsis. It could be due to mitochondrial dysfunction. It could be due to some leakiness from the myocardium and renal failure. All then can increase TROP. If ECG is showing ST elevation with raised TROP, then you can think of something STEMI or something. But this TROP would not help. It's already high in our patients.
So clinical parameters again, worsening shock, new ECG changes, chest pain, arrhythmias will suspect, and you can differentiate if it's a type 1 MI or type 2. Type 2 basically means supply-demand mismatch, not truly an MI, not truly a coronary artery disease. So invariably other systems get affected, obtunded consciousness, low urine output, rising creatinine, ischemic hepatitis. So do you involve a neuro, gastro, nephro at this time? And I would also ask Dr. Puneet at this moment as a urologist for source control, how soon you get into these patients?
So source control is most important thing in any patient of sepsis, and we always drain the kidney and put the stent or put the PCN, especially in case of emphysema pyelonephritis. So source control within 6 hours is very critical for saving patient life.
So you will go for a URS in a case of urinary obstruction very early? Just put a drain. Just put a drain, catheter and a ureteric DJ stent. So that also is a very common situation, an obstructive uropathy coming in septic shock. So Dr. Sehgal, would you involve other specialists or it doesn't help?
Sir, in this case, like the patient came with abdominal, it started, gastro is needed. But obtunded consciousness could be due to poor perfusion. So probably neurologist is not needed at this point of time.
Only when source control is required by a urologist or a gastroenterologist or an interventional radiologist. Otherwise, usually it doesn't help and critical care specialist has to take all the decisions usually. So we are running out of time. Dr. Chakravarti, how do you read a culture report briefly? Because we get reports like sensitive, resistant, intermediate. How to decide antibiotics based on MIC? I think that's a very important thing to discuss. And does it depend on the pharmacokinetics and pharmacodynamics of the particular antibiotic also?
So the culture report need to be with MIC based. We need to get the MICs of the culture report. So sensitive is below that MIC, the antibiotic should work. All these MICs are validated on blood. So if you are getting something like minocycline MIC is 8, that will be resistant. But if you are treating a pneumonia, same minocycline despite being reported as resistant is likely to work because minocycline concentrates 4 times more than plasma within lung. So with a resistant antibiotic also we can treat pneumonia if it is minocycline, if it is like fosfomycin MIC 64, that concentrates very much within bladder. So we can treat resistant for E. coli with fosfomycin if it is cystitis. Now the intermediate is something like within a range, in that if you have to give the beta-lactam antibiotics in a longer infusion, like if you are giving a antibiotic over 2 hours, make it 4 hours. Longer infusion, longer exposure, the antibiotic might work. Now about PKPD, like for this patient, at the end of all the culture report, that was CR Klebsiella, and the antibiotics were used Cas-IV, aztreonam and tigecycline. Cas-IV aztreonam is having a beautiful PKPD. It is having 70% intra-abdominal distribution. So tigecycline may be avoided in this scenario. So Cas-IV aztreonam can cover CR Kleb in blood, in lung, and intra-abdominal soft tissue, any kind of location equally.
Right.
So
I think that's clear that you have to look not only at the culture report, but the PKPD of all the drug also. So at the end, other things also become important, like nutrition, fluid strategy, mobilization, preventing bed sore, preventing HAI and preventing DVT, etc. So Dr. Yadav, quickly, do you, in a septic patient, enteral parenteral feeding, whether NG or NJ matters?
Definitely enteral is always better over parenteral. If gut is functioning, we should not delay the feeding. And NJ versus NG. NG is equally good until otherwise, if there's any contraindication for giving the gastric feed, like gastroparesis, then you can push the tube into the jejunum. Otherwise, NG is better.
Dr. Rajesh, how often you use TPN in septic patient?
TPN basically required in very selective number of patients when enteral feeds are failed. And it is most of the time it is problematic if it not used judiciously.
So preventing bed sore, preventing HAI, preventing DVT, PT, any, when do you start? Right on day one? Or
yes, sir, as early as possible.
What is your strategy of giving anticoagulants to these patients?
Sir, we start it if it's no contraindication, but we go with pharmacological, not too much of mechanical. It could be a neurosurgery post. Then we basically we start as early as possible.
When you anticipate a septic patient to remain in ICU for some time, for a long time, then you have to start it at the onset. So I think this I can skip. Role of PCT, we have discussed since morning and since yesterday that it's mainly used for de-escalation, not for institution of antibiotic. Shift out criteria is very well known, and should you know your antibiogram, I think I would like to convey to everyone that try to have your own antibiogram, because all institutions may be having it different, and you have to know to choose the right kind of antibiotics. Role of AI, Dr. Sehgal, I want to comment. Ninad has already said.
Sir, just brief, like all these scoring system are being done manually. So in some hospitals it could be done 1 hourly. Suppose a nurse does it 4 hourly. If these scoring systems are integrated in our monitors, then probably we'll get rapid alerts. So probably picking up patients will be fine. Only thing problem is that it will not replace us. You can put a closed loop. If MAP is less than 65, start NORIT. But you have to feed into that computer whether it is a hypovolemic shock, cardiac shock, or it's a septic shock. Matlab, it can't replace us, it will only augment us. And as sir said, there could be a lot of ethical issues. Some treatment decisions we are taking through AI and doing to the patient, we have to inform them. Probably we use this algorithm. And other thing, what will happen 5 years down the line, you might receive so much alerts from AI, we will have alert fatigue. शेयर आया अब की बार तो आया ही भी सेट अरे ये तो ऐसे ही करता रहता है. So these are things which can next 5 years down the line we can face.
So all in all, we do have certain models, and some of them are yet approved by FDA also. Hari, anything quickly?
No, same.
He's already said that AI will come. I'm sure AI will infiltrate into this area at least, because it's very important to have a precise monitoring in patients who are septic and who are admitted in your ICUs. And manually, obviously, we cannot perform that well as the AIs will do. This is InSight early sepsis prediction, and they've shown that each hour delay in treatment yields 8% increase in patient mortality. So that basically AI will obviate these delays. You will not be delayed in starting any particular measure. Yes, Rajesh, you want to
Yeah.
say?
By the time AI comes, we are here and most of the residents are using the apps like ABG apps. It's not only the ABG that you are getting the metabolic acidosis or alkalosis or respiratory acidosis, alkalosis, but the next step is that you should go to AA gradient. That what is the requirement of oxygen and how that will definitely give you that bedside CT scan is not possible, but the sequence of impending ARDS and all these you can pick up very early. Like in COVID we did. And there are so many other tools like corrected sodium, corrected potassium. So whatever labs are measuring, your clinical definitions of hyponatremia, hypokalemia may be different.
Point well taken, yes.
We should complete these steps first, then we can look for AI.
So AI can help you, but it cannot supplement your clinical knowledge and your clinical decisions. So I think takeaways from this session would be that there is significant improvement in ICU care, the diagnostic test, the concepts, the guidelines, scoring systems, and we have access to AI also now. And the current strategy, I would say, is that the rapid identification should be focused on strong recommendation for administration of antimicrobials within 1 hour in septic shock patients, structured screening, individualized antibiotic stewardship, dynamic fluid management aiming for 30 ml per kg in first 3 hours, source control, post-discharge follow-up to address long-term outcomes, as we said, the anticoagulation problem, the bed sore issues, those have to be tackled. A patient may keep on suffering for few months after they are discharged after a episode of sepsis. I would invite any comments from anybody in the audience.
Dr. Sanjay.
Yes, that was well said. Sir is saying that fluid administration based on IVC diameters and of course based on your lung ultrasound. I will also emphasize here that good ICUs should have bedside ultrasound and echoes available. That's very, very important.
Yeah.
Yes,
Yeah,
Shailen.
Dr. Sanjay.
Yeah, Harish.
Yeah, in this patient, the stent was removed at 22nd day and without doing a cholangiogram. What is your policy for removing the stent after when you place for the CBD stone and stent?
Yeah, it was done somewhere in periphery.
Yeah.
Yeah.
So it was done somewhere else, but what is your policy?
See, we at the time of index ERCP, we would mention that how good was the clearance of CBD, and if we know that the CBD was cleared nicely, we will remove the stent by plain endoscopy, will not perform a cholangiogram. But if it was a large stone, if there were multiple stones, if there was sludge in CBD, if there was a doubt about stricture, if there was incomplete clearance, then of course we will do a cholangiogram.
What about timing?
Timing is usually 3 weeks after the index ERCP.
Yeah, this patient, most likely the leak was from the cystic duct stump.
No, there was a major leak. There was actually a CBD perforation in this patient. We don't know how somebody could, how this complication could have occurred, because removing stent is a very simple job. And during this procedure, maybe there was some hitch and he tried to get inside CBD again, use something, we don't know. But there was a perforation in CBD at about 3 centimeters inside, suprapancreatic part.
Yeah, or one
very
more,
unusual.
Yeah, one more thing related to this patient. The intraabdominal collections, there were multiple septations. Okay, so immediately to stabilize the patient, laparotomy or doing the laparoscopy may not be possible because the patient was too sick. So putting the multiple drain was a very good option. I think we should follow the septate collections by doing the routine sonography, maybe on alternate day, whether there's complete drainage or not. By following that, we could have avoided the second time ICU admission.
We generally do NCCTs usually in this patient. That's quite sufficient to do. Rather, because ultrasound you are not able to pick up collections.
Or we can put the additional drain.
Yeah. Yes, Shailen. Last point.
Yes, sir. Very nice and informative session, sir.
Thank you.
One thing that we are talking about the sepsis in the general patient, but a lot of resident here are in the audience. The cirrhotic patient, difficult to identify the sepsis early in the course because they are on the beta blocker, they will not have a high heart rate, they are in the low systematic vasodilation, so they are not having a blood pressure, they are changing in the, and they may have cirrhotic in a lot of the cirrhotic immune paralysis, so they do not pick up the fever. So these patients to identify sepsis in the early in the course, very important and very tricky. The one thing
we had a
can
full
do
session
the
on
serum
cirrhosis.
lactate
Yeah.
also. So that is become within the 2 hours serum lactate. If it is more than 2, it is very informative and guide for the sepsis. One importance. And so in cirrhotic patient to identify, it is very important to keep the clinical ground, and also so that is the
So
most important.
very important point
These are-
highlighted that in patients, especially cirrhotic or any other chronic disease, elderly patient, you always do an ABG at admission where there you have doubt so that you can see the lactate levels. And in particular in cirrhosis, we have good data of PCT being very useful because as you said, the clinical parameters may not help. If you are slightest in doubt, we do a PCT report is available within half an hour. And it actually helps you. You do take cultures in suspected sepsis, but do a PCT and start with a good antibiotic if it is raised. Thank you. I thank my panelists and expert discussants. Thank you.
Thank you all the members for putting insight on sepsis and AI models. We move on to our next session. The chairpersons for the next session, I invite Dr. V.K. Ramnani sir, Professor and Head at Microbiology and Director of PG Studies at Allen Medical College, Bhopal, Dr. Atul Agrawal sir, GI and Laparoscopic Surgeon at Bell's Hospital, Bhopal, Professor Vijay Saxena sir, Physician at Smart City Hospital, Bhopal, and Dr. Harsha Gupta, Intensivist at Allen Medical College, Bhopal. The first session is on the topic antibiotics, rationality and stewardship, and the speaker will be Dr. Amit Singh, intensivist at Bansal Hospital, Bhopal.
Hello. Good afternoon, everyone. First of all, very thank you to Dr. Sanjay Kumar, Dr. Ninad and GastroCare team to invite me for this talk. So, एक minute. So, my talk is on antibiotics. So, I'll start from the basic, this is basically brief history of antibiotic. The penicillin was discovered in 1928 by Alexander Fleming, and afterwards many antibiotics were invented, and simultaneously the resistance developed to the many antibiotics. So Alexander Fleming, basically he received the Nobel Prize in 1945 and gave a statement that the microbes are educated to resist penicillin, and a host of penicillin fast organism is breed out. In such cases, the thoughtless person playing with the penicillin morally responsible for the death of the man who finally succumbed to the infection. So, who is the thoughtful person? Thoughtful persons, we doctors, prescribers. So actually we are the responsible for the antibiotic resistance and the death of the patient. Suppose some person who never used antibiotic in his life, never took any antibiotic, but because someone else is having some drug resistant organism and he is infected with the organism and he died, that the responsible person are we. So I'm starting with the basically origin of life. So when the origin of life is there, the starting, it is around 4.6 billion years ago, when the prokaryotes develops in the seawater. So what happened? These were the anaerobic bacteria. There was no oxygen. So then the cyanobacteria developed. They basically gave oxygen and nitrogen to the environment, and then the anaerobic bacteria developed. and finally the evolution life of develop, and we human created over the period of time. So basically, we actually invaded the world of the bacteria. The bacteria is not the enemy. Actually, we are the enemies of the bacteria. And that is the basic principle. Ki we have to have a peaceful coexistence with the bacteria. So they are basically, our environment is full of bacteria, our gut is full of bacteria, and these are basically our friends, not the enemy. So what we are targeting with the antibiotics, my talk is basically send a message that when and should be used, when not used should be used, and how to optimize the things. So how the antibiotic resistance develop? Antibiotic kills both the normal bacteria which are helpful and the pathogens. So when we are giving the antibiotic, what happens? The one bacteria who is powerful and having drug resistance, that only remains. Whatever all bacteria which is present, which is helpful, which are pathogen, they are killed, but the one bacteria which is remnant, that becomes the superbug. And that is the responsible for the multi-drug resistance nowadays. So this is the basically a statement of some scientist, Frederick, that which does not kill us, make us stronger. So this is the statement of bacteria. अगर आप मुझे नहीं मारोगे, तो मैं और strong होऊंगा और problem बनूंगा. So this is the recently published article or research in the Nature in 2026 that antibiotic use actually change your gut microbiome, and the one single short course of antibiotic eliminate the gut microbiome for 18 years. It took almost 18 years to achieve same microbiome. But after 18 years you can achieve the same microbiome, and the single course of antibiotic actually kills all the helpful bacteria in your gut. So this is a global health problem. We are inventing antibiotic. After 2-3 years, we are having resistance to the same antibiotic. We started from the penicillin, now we are having with ceftazidime vectum plus astronam. And maybe after 2-3 years, we will have the resistance to these antibiotic also. So this is not the inventing new antibiotic. It is not the basically solution of the problem. It is the restrictions of the antibiotic or optimizing the use of the antibiotic which are actually helpful. So what is the causes? The inappropriate antibiotic use, not only in humans. It is using in the poultry farms, it is using in the cows, buffaloes, people are using colistin. This is the strongest antibiotic we have, but it is used in the poultry farms and in the cow milk and dairy farms. So actually we are having the resistance from there also. So now coming to the case scenario, 22-year-old woman presented with a stuffy nose, rhinorrhea and mild fever for 4 days. There is no cough or sore throat. What antibiotic would you choose? We are having many choices. Azithromycin, cefixime, doxycycline, amoxicillin, clavulanate, which is actually people are using from the over the counter. People are having at home and they started having fever and running nose and they start taking azithromycin or amoxicillin, clavulanate. So the treatment is symptomatic. It is the viral infection. Antibiotic will not help. So why are you using? The data shows during the COVID-19 pandemic that ICU admitted patient, 80% of ICU patient received the antibiotic because of no reason. It was the viral illness. There was no use of antibiotic in COVID-19, but 80% received, and even high antibiotic, meropenem, teicopenem. My patient is not getting benefited. Then I will come on round and I will start meropenem. Okay, fine. Patient ठीक नहीं हो रहा, antibiotic start करो. So this is the CDC data. People of having pneumonia and people of UTI and other infections, more than 70% patients received wrong antibiotic for the wrong disease. Sometimes people are using and whatever the written in guidelines that these antibiotics should be used, but they are using different antibiotic. For pneumonia, they are using meropenem and colistin from starting, but it is actually requiring only ceftriaxone or azithromycin. So wrong antibiotic prescription it is worldwide and it is having global health problem. So how we can combat this antimicrobial resistance? So there are four-pronged strategy. The one is that development of new drugs, but I think this is not a option, because we are getting a new drug, we will have a resistance after that. Second, alternative non-antibiotic approaches prevent horizontal spread of antibiotic resistance and judicial use of existing antibiotics. So fourth is the most important prong which we should emphasize on that. Non-antibiotic approach is like the vaccination, immunomodulation, or whenever antiviral therapy is required, don't use antibiotic. Horizontal infection measures are the hospital infection control policy. Clinicians think that their hands is sterile. Whenever they go to the patient, they touch the patient without any hand hygiene, and they think that their hand is sterile. Juniors requires hand hygiene, but senior persons doesn't. They go to the patient, touch the patient, and so hand hygiene practices are very poor in India. So first of all, the first most important thing is that. And again, the other infection control measure like environmental cleaning, education, and bundle care approach. I will take 2-3 minutes more. So most effective strategy is judicious use of existing antibiotics. So as already discussed, we can do a point of care diagnostic approach, in which we have already discussed in previous lecture that the MultiTOF, BioFire, respiratory multiplex PCR panel. So they can give you results in 3 hours, and you can narrow down your antibiotic after you have the patient with sepsis or any infection. Coming to, I'm not going into detail because time is out. The first thing is we have to take in our mind, does my patient have infection that require antibiotic? The first thing, whenever you see the patient with myocardial infarction with shock, it will not help from the antibiotic. Second is, before prescription of the antibiotic, have you sent any cultures or relevant cultures? My patient is having UTI, we are sending the culture from the endotracheal tube. It will not benefit. So you have to target which culture you want to send. And if I have started the antibiotic, we have cultures, now can I narrow down the spectrum of antibiotics? Can I stop antibiotic, and can I switch to the oral therapy? And fourth is the duration. One of the paper from the for intra-abdominal infection, if the source control is achieved, 4 days duration of antibiotic therapy is similar to the 8 days antibiotic therapy. So prolonged use of antibiotic also goes to the antibiotic resistance. Now finally, I am just discussing some myths. Oh, sorry. Sorry. So I am just discussing 5-6 myths because time is short, which should be discouraged. Number 1, give high-end antibiotic, no use of culture. Always send culture whenever you are prescribing the antibiotic. So, and high-end antibiotic, मेरे को ना best antibiotic देना है. I will start from the mirror, but please follow the guidelines. Number 2, all positive cultures reports need to be handled aggressively. My patient is having UTI, I am suspecting, but there is no pustules, there is no fever, no costovertebral pain. And this is culture is showing Pseudomonas aeruginosa. Should I treat it? No. If the patient is not symptomatic, not having fever, we should discourage the culture report. Treat the patient, not the bug, not the sample. So always you see patient clinically rather than treating the bug. The number important thing is that our nature is that push antibiotic immediately. So we should think that there are 2 classes of antibiotic. One is the concentration dependent and the one is the time dependent. Concentration dependent antibiotics are aminoglycoside and fluoroquinolone. They require 1 shot in a day. There is surgeons practices that we should give the amikacin twice daily, 500 milligram twice daily. but it actually, the dose is the 1 gram 12 hour, 24 hourly. So we should give with one shot, and the carbapenem and beta-lactams should be given in infusion, prolonged infusion. So we should not like that ki we should give immediately the antibiotic. Change antibiotic if not responding in 25. My patient is not improving, we are changing the antibiotic daily. This should not be done. All stem infection are best treated with vancomycin. Learn to say no to the vancomycin for methicillin sensitive Staphylococcus aureus because the flucloxacin is a better drug than the vancomycin for the gram positive methicillin sensitive infections. Winning horse should not be changed. I have started with the carbapenem. Now the patient is, the bug is sensitive to the piperacillin satisfactum. Please de-escalate. It is not like that. My patient is improving on meropenem and colistin, so we should not de-escalate. Always de-escalate the antibiotic. So take-home message is prescribe antibiotic only when truly necessary. Know your patient, your bug, and your drug. Know your microbiologist, and the is a message for the microbiologist. Please talk to the microbiologist. Microbiologist should talk to the clinician. Otherwise, you are just treating the paper, the culture report. So always talk to the microbiologist. And he will be very helpful. Now they are also in the infectious disease specialists also, some microbiologists. Thank you.
Thank you. Can we invite Dr. Varun Chandra? The questions can be taken later.
Is there any questions?
Any question?
Thank you so much, sir.
One from audience. Thank you.
Thank you so much, sir. Next topic will be an interesting infection snippets, which you should all know, by Dr. Varun Chandra, sir, consultant clinical microbiologist and infection control from Bhopal.
Good afternoon. To begin by sincerely thanking the organizing team, especially Sanjay Kumar sir, to giving me this opportunity to speak here regarding interesting infections. So these infections, as a perspective from a microbiologist I am speaking, not as a clinician, right? One thing is, the objectives are to raise awareness among clinicians regarding importance of simple microbiological tests which can help into concluding a diagnosis, right? How identifying a causative organisms helps in targeted or an appropriate treatment, and awareness about few neglected tropical diseases. When it comes to GI tract infections, definitely some tropical diseases are, many times it gets neglected due to not very commonly seen, or it might be misdiagnosed as well. Next, as a microbiologist, I would say I hardly get any history from the clinicians or about the patient actually. So anything unusual I get, it surprises me. Okay, I have got a simple stool sample and I am getting something else. So it will be basically 5 cases which I will be representing. The first case is a 48-year-old diabetic male patient was admitted with fever, breathlessness, having pain in the right and left quadrant pain. History revealed a patient was having on and off fever for the past 6 to 7 months, right? A chronic disease. So pathological workup showed there was raised in neutrophil counts with raised ALP, SGOT, SGPT, right? CT was showing, CT was done because the patient was having restlessness. So the CT was done. There was some cavitation in the lung as well. And USG abdomen was also done. So it was showing some hypoechoic regions in the liver and spleen, which was very suggestive of abscess. So both the organs was having abscess. So any differentials? On the basis of the history, can there be any differentials? Common? Tuberculosis, right. Tuberculosis, pardon? Melioidosis, okay, right. So in Indian context, TB is so rampant, any chronic infections with abscess and all, we basically first diagnosis is always a tuberculosis, right? So we will see. So next, the samples were sent for ZN stain and CB NAT for TB workup. Okay, and blood and sputum samples were sent for cultures. The liver and spleen abscess were also drained out and they were sent for cultures as well. So next, what happened was ZN stain and CB NAT, they both came negative. And the sputum culture was also not very significant. It was insignificant. But from the cultures of the blood and from the abscess which was drained, a neglected yet an important risk class 2 organism which has a potential for a bioterrorism agent as well was isolated from the blood and abscess samples, right? That organism was Burkholderia pseudomallei. This is an organism which causes a disease called melioidosis, right? What to say, it is a neglected disease basically. This was isolated in the lab. So what is melioidosis? So melioidosis is a great mimicker or a Vietnamese time bomb. Patient may acquire the disease, the infection or the pathogen, but he may not present you any symptoms. He may remain symptomless for a very long period of time. That is why it is called as a Vietnamese time bomb. It is very common in the Southeast Asian countries. Since it is very common in Southeast Asian countries, the environment is very apt in India as well, but it is not being diagnosed very frequently, okay? Because it is very underreported and underdiagnosed, lack of awareness among the microbiologists and as well as among the clinicians. It has a very diverse clinical pictures, difficult to diagnose, and mimics other infections as well, like tuberculosis. So diabetes has been shown to be a risk factor for melioidosis, transmitted through direct contact. Still, it has not been included in the neglected tropical diseases, though it is very common in the tropical countries. 3 forms, usually acute, subacute, and chronic. The abscess and all will be seen in subacute and chronic cases. In acute cases, it will be more of a lung involvement will be there with the septic shock or septicemia. So prolonged treatment is required in such patients. Intrinsically, the organism is resistant to many class of antibiotics like cephalosporins, penicillins, aminoglycosides, macrolides. Even colistin is not sensitive against this organism. So intensive phase, so you have to give antibiotics, meropenem, imipenem, or ceftazidime are recommended drugs for 7 to 14 days. The eradication phase has to be continued again for 2 to 6 months, which may be cotrimoxazole, amoxiclav, and doxycycline are the drug of choice for a prolonged eradication phase. Right? The second case was a 38-year-old patient with watery diarrhea. Now the next 3 cases are on diarrhea. And we will see how the outcome was very different.
Varun, you can expedite.
Yes, sir. So the case 2 was a 38-year-old patient with watery diarrhea for 15-20 days. Patient stool sample was sent basically for opportunistic pathogens. This probably Sanjay Kumar sir will be remembering this case. He called me and said, what is the history of the patient? So there was immunosuppressed patient, the patient was immunosuppressed, recent kidney transplant. So opportunistic pathogens, A modified ZN stain was done just to see what opportunistic pathogen could be there. So I could find the oocyst of Cryptosporidium species in this patient. Right? Cryptosporidiosis, again a parasitic infection, could be zoonotic or non-zoonotic, transmitted through contaminated water and food. Usually in an immunocompetent patient, treatment is not required. It is self-limiting, probably within a month it will be under control. But in severe infection and in immunocompromised patient, like in these patients, definitely treatment should be given to such patients. Case 3, a 55-year-old pharma patient with fever, abdominal pain, diarrhea for the last 15 to 20 days. Not very significant findings in pathology or the USG. Okay, stool culture was sent for culture as well as for finding any opportunistic pathogen. So when I did the ZN stain, the ZN stain revealed a pathogen, a parasite. Okay, this was a strongyloid stercolaris larva, and it was incidental finding. I was also not expecting that I will find this parasite in this ZN stain. So this was the wet mount. There were plenty of the larvae were present, in plenty. So when you see lot of larvae in there, a detailed history was taken and it was found that the patient was on steroid for the last 2 months. So this was basically a case of hyperinfective syndrome or hyperinfection syndrome. Parasite, this parasite, strongyloids, they can cause auto-infection basically. So the larva gets evolved and again cause infections in the GI tract. Always check for the immune system, immune status of the patient whenever a strongyloid is suspected or having appropriate treatment was started. The case 4 was again a patient with on and off fever for the last 4 months, diarrhea for the past 1 month and significant weight loss, right? Blood workup showed pancytopenia. A stool culture was sent for ZN stain and for opportunistic pathogens, and a culture was done. Culture was routinely non-significant. But on ZN stain, I could find acid-fast bacilli. Finding acid-fast bacilli in stool sample is like finding pin in a haystack. Usually you won't see acid-fast bacilli in stool sample. So the moment I found AFB, acid-fast bacilli, I asked the lab to confirm what is the immune status of the patient, and it was found that patient was HIV positive. So if you find stool sample having showing AFB, it is definitely extrapulmonary TB, or you have to go for immune status of the patient. Case 5, this is the last case. 55-year-old male presented with fever, right upper quadrant pain for the last 4 to 5 days. There was neutrocytosis, and the USG abdomen was done, and in the liver segment 7 and 8, there was a cystic lesion, hypoechogenic, and impression from the USG was, it was possibility of a liver abscess, right? So it was aspirated, a culture was sent. So culture was negative, but a routine simple wet mount. I always do a wet mount of a liver abscess just to confirm if I could find any parasite, especially amoeba. So I could find the scolex of Echinococcus granulosus or a hydatid disease. It could be challenging. At certain situations, hydatid cyst diagnosis could be challenging. If you aspirate and this was unlikely, I don't know how surprising I also found this. So hydatid disease, humans are the dead host, intermediate host basically, and only larval form are seen in the humans. Dogs and other canines are the definitive host. Liver is the most common organs involved, but other organs like spleen, lungs, and other organs can also be involved. Sometimes can be a diagnostic challenge. If there is any doubt about hydatid cyst, always go for serological test first, and then you aspirate that cyst, right? And newer techniques like pair techniques might be available in certain centers or everywhere, where these techniques can be done for this hydatid cyst, right? The take-home message is simple microbiological tests can also play an important role basically in concluding a diagnosis, right? Definitely you should provide some history to the microbiologist. The moment you say something, some history, we think, okay, these things could be there in this sample. I can remember with ki, acha, opportunistic pathogen hai, I want to see in the stool, so I'll be looking for Cryptococcus or Microsporidia or Isospora. So at least a simple history or talking to or informing your microbiologist can definitely help in coming to a diagnosis, right? Thank you.
Ramnani sir, although you are there, I would request for a very, very brief, he has already given nice slides.
I was trained with the conventional methods, and there was a sample of India ink preparation for Cryptococcus where I found tumbling motility of a bacteria rather than finding Cryptococcus over there. So this was a sample where Listeria monocytogenes was reported purely on the basis of trained eye with an appropriate tool called microscope. So there are so many methods which are with this simple stents or simple wet mount preparations. We can diagnose even Negri bodies, we can diagnose even inclusion bodies using only toluidine blue O, Leishman stain, modified ZN, actual ZN, grams, KOH mount, LPCB. So there are so many small tools where we have to invest only 5 rupees, including glassware as well as the stains. So only thing is that a fluorescent microscopy was done on one of the student in Sevagram, where a stout broken mycobacterium was seen under fluorescent microscopy. She had meningitis. Later on, she opted for microbiology, leaving aside pediatrics, and today she is serving NRL at Bhopal. Thank you.
Thank you, chairpersons and the speakers. I think we are way behind schedule, so we cannot allow any more questions. Let's have the next one.
And so the next session is a panel discussion on hydrated disease of liver. I would like to invite upon stage the panelists, Dr. Ravindra Kale, Senior Gastroenterologist from Indore, Dr. Vishal Gupta, Additional Professor, Surgical Gastroenterology from AIIMS, Dr. Roshan Chanchanali, Additional Professor, Pediatric Surgery from AIIMS Bhopal, Dr. Piyush Manoria, Gastroenterologist from Manoria Hospital Bhopal, and Dr. Pankaj Goyal, Interventional Radiologist, GastroCare Multi-Specialty Hospital, Bhopal. The expert discussants for this session will be Dr. R.S. Chachra, Senior Gastroenterologist from Bhopal, Dr. Krishnanand, Senior Surgeon and HOD, Ellen Medical College and JK Hospital, Bhopal, Dr. Harshal Shah, Consultant Gastroenterologist from Indore, and Dr. Nishan Jain, Consultant Gastroenterologist and Hepatologist, Vindhya Hospital and Research Center, Rewa, MP. The moderator for this session is Dr. Manish Bhatnagar, Director and HOD of Gastroenterology at InfeCON Hospital, Ahmedabad.
So, good afternoon. First of all, a big shout out to Sanjay, my dear friend, for giving me this lovely opportunity of doing this panel discussion on something which you have heard about from a lot of the other speakers, and we are going to be discussing this. It's not something we see very often in clinical practice, but I hope we'll have a very interactive and stimulating discussion because I have a very high-powered elite panel of experts along with senior consultants as discussants. So let's get started. The mandate given to me was to talk about the hydrated cysts of the liver, which is something which you all have heard of in the last few talks. So this will be the session roadmap, and I'll try to stick to the time, and I'll request my fellow panelists also to be concise in their responses. And this is the case which I want to present to you. Can I have a hand mic, please? Yeah. Okay. Hello. Yeah. Thank you. So this was a 48-year-old female who had comorbidities in the form of hypertension and diabetes, which were reasonably well controlled. Her chief complaint, she had been to other consultants before we saw her, was an irreducible right hypochondriac mass for 6 months. The onset was fairly insidious. It was gradually progressive. The pain was dull aching, which was localized for a few days. It was non-radiating, and there were no exaggerating or relieving factors as per the patient. She had fever intermittently. She had no GI symptoms. There were no allergies. And her past and family history was nothing significant. When we examined the patient, we found that the abdomen was distended. There was no visible mass or pulsation. She had a tender right hypochondrium with a 4 centimeter by 4 centimeter mass, which was palpable at the RHC. It was moving with respiration. It was cystic in consistency, had a smooth surface, and was non-reducible. On percussion, there was a dull note over the mass with no shifting dullness. And on auscultation, we found normal vowel sounds. So let me start first off with you, Dr. Ravindra. What investigations would you recommend? And if you could tell me what would be your choice and why that would be your choice.
So basically tender mass in the cystic mass in the liver. So it could be anything. It can be benign cyst, or it could be cystic neoplasm, or it could be hydrated cyst. So first of all, I will go for the routine blood chemistry and sonography of the abdomen to classify which type of mass it is.
Okay, so apart from the imaging, what blood investigations would you be looking for?
I will be looking for blood counts to look for any evidence of infection or sepsis. The liver function test to look for any evidence of obstructive jaundice or cholestatic features or increase in the liver enzyme.
Okay. So, perfect. So these were the labs which we ordered. Please feel free to disagree with them. They showed a raised LFOS. There was chronic hyponatremia, which was documented from her previous reports, which we also found. The CBC, LFT, RFT, and thyroid function tests were reasonably normal. There was trace proteinuria. The USG findings there are there for you, Ravindra. There was an enlarged liver of 22 centimeters, well-defined lesion in the right lobe with multiple thin septations and central stellate hyperechogenicity. The radiologist was quite confident of reporting it as suggestive of hydatid cyst. There was also the presence of a right-sided pleural effusion with basal consolidation. So a triple phase CT scan was ordered. This confirmed the presence of a hypoechoic cystic lesion in the right lobe. It also showed an enhancing hyperechoic cyst wall with no internal debris, no biliary involvement, and no apparent malignancy as per the report. So anything else would you want to ask for, Ravindra, at this stage? Sorry? Amylase lipase was normal. She already had it. I'm sorry, I didn't mention that. It was normal. Yeah, please.
I think beside this, I would like to investigate why she is having chronic hyponatremia. Either she is on any drug which is causing hyponatremia, or is it a Addison's-like thing?
We investigated, we couldn't find a reason for it, so we assumed it was nutritional in origin probably. She hadn't been vomiting or anything. But anything else would you like? I mean, any particular serology or anything which makes you think that you should be going for it? Or are you happy with these investigations going forward?
Serology can be additionally done, but I think the sonographic evidence and CT is clearly suggestive of hydatid cyst, so I probably do not need it.
Okay. So, since we have an interventional radiologist also, we will be coming to you. But before that, Dr. Piyush, do you feel there are any limitations in CECT in diagnosing hydatid cyst, or do you think that it is something you are comfortable in stamping it as hydatid once you have a CT?
Yeah, it gives most of the informations, but for biliary communications, for the pericystic layer, and for sometimes the detached membrane, some signs are more clearly depicted by the MRI. So we
Yeah.
should keep in mind these things.
Yeah, so absolutely right. So the sandy appearance at the base and the water lily sign and the stellate signs and all are definitely picked up better on MRI. So this is for the audience. What would you do next? Would you want to observe this patient? Would you want to start an albendazole already? Would you want to go for pair, which is puncture, aspirate, inject, re-inject? Or would you want to do surgery? So quick show of hands for those who would want to just observe. Mind you, the patient has been symptomatic for 6 months, so obviously I think we've observed long enough. So would you want to start albendazole? How many people would want to start albendazole considering that we are thinking of hydrated cyst as the likely possibility here? So I see quite a few hands there. Anyone for the procedure of pair? Okay, that's one hand. And how many of you would like to operate straight away? Okay, so Sanjay and Dr. Chaubal are on the surgical side here. I think that gladdens the heart of the surgeons on the panel. Okay, so this is exactly what we also did. The therapeutic intervention and histopathology, the pre-op prep was to correct the hyponatremia. She was on a diuretic earlier, which had been withdrawn. We switched her antihypertensive. The patient was adequately counseled about the risks and benefits of surgery. Albendazole was started 2 weeks prior, and the surgery was scheduled, which was basically pericystectomy. So these were the steps there, but we had a nasty surprise at the OT table. The surgeon reported 1.5 lakh liters of pus, which was drained and sent for culture and sensitivity. Imaging had failed to detect. Now, this is something which is a limitation of most of the imaging we do these days, and this is to be kept in mind. So the drain was placed, a thoracotomy was also done, and closure was achieved in layers. So to the surgeon, Dr. Vishal, and I'm told that you have significant experience in managing hydrated. Why did this case get infected? What do you think was the reason why the case got infected? Most of the times, hydrated cysts are non-infected. They are sterile.
So in general, the most common reason for getting infected hydrated cyst is the cystobiliary communication. So most commonly it is the cystobiliary communication that leads to...
Could you just speak closer to the mic? Yeah.
So it is the communication between the cyst and the biliary system which leads to the secondary infection. But sometimes even in the absence of such communication, it may be a secondary bacteremia, source is somewhere else in the body that can lead to infection in the hydrated cyst. For example, patient might be having gallstones, patient has developed cholecystitis, acute cholecystitis. Even if there is no obvious communication, the bacteremia can lead to the infection of the hydrated cyst.
Yeah, so that's a very good point, and the take-home message here for the audience is that in spite of the patient not having a clear-cut communication, this was a significantly infected cyst and a large amount of pus was drained out. So this was the case follow-up with antimicrobial management and discharge. The cyst culture showed E. coli resistant to the usual antibiotics. It was sensitive to a range of antibiotics. The ICD fluid culture showed Acinetobacter, and the follow-up showed that the liver abscess due to the infection of a hydrated cyst was treated with cefoperazone sulbactam for a period of 7 days, IV, and metronidazole along with pantoprazole. Hepatomegaly, the residual cyst collection and bilateral pleural effusion were seen. The drain was removed on the post-operative day, the 8th day, and on discharge, the patient was put on albendazole with cefixime. How many of you would agree with asking the patient to take the cefixime? Do you think only albendazole would have done after all this? And was it rational to have the cefixime? Any of the gastroenterologists on the panel could weigh in on that.
Definitely, because he has sepsis and liver pus was drained. So definitely he needs antibiotic for at least 2 weeks.
Okay. So I think we did the right thing, right?
Can I ask,
Can I
ask
please.
one question? What was the nature of this drain output in the post-op period? Because it was already pus at the time of surgery, and we expected some kind of cystobiliary communication. So did that the nature of drainage change from pus to bile, or it directly converted it to serous?
It converted to serosanguinous within 3 days.
So there was no obvious cystobiliary communication?
No, there wasn't.
Right. And second, I think in the management part, thoracotomy was also done.
Yes.
So what was the...
That was the call taken by the surgeon on table. That wasn't something I was pushing for, but yes, that was done. I'm reporting it to you just as it happened. So yeah, that's a good point. Even I had a discussion with my surgeon, didn't receive a very good answer, so I'm not going into that. But okay, so just to give you some disease overview, I think we've discussed the case. Now, we all know that hydrated is not a very common condition, but please keep in mind that it is not also a rare or unusual condition. So your causative agent is Echinococcus granulosus. The definitive host is not a human. These are dogs and other carnivores. They make the humans accidental hosts who are found to have mainly the liver involved in about two-thirds of the patients. And the whole thing is that the dogs, they pass these cysts in their feces. This is consumed by the herbivores like sheep and all, who are then having this infestation. Once the cysts break out, the scoliosis make out, and when human beings consume this, they become accidental, dead-end intermediate hosts. So we are basically accidental hosts for hydrated. But keep in mind that the liver is what is the target audience for most of this echinosis. So if you look at the biology and epidemiology, this is also important to understand, and since we have learned surgeons on the panel, we all know that the cyst anatomy is also a little complicated. So you have the pericyst, which is host-derived, you have an outer laminated acellular membrane, and you have an inner germinal layer which produces the scoliosis and the daughter cysts. So this is exactly how it looks with the brood capsule inside with the protoscolex. And the epidemiology is that it is a worldwide thing. It is more commonly seen in pastoral communities across the world. And in the US, because they are quite obsessed with figures, they have come out with this disability adjusted life years and billions of dollars in annual losses because of this. Please keep in mind that pastoral communities, like I practice in Ahmedabad, I get a lot of patients of hydrated from Kutch, which is our remote part of Gujarat, and from the pastoral communities of Rajasthan. So it is not exactly a very rare condition. One needs to have a high index of suspicion. Having said that, most of the times hydrated cyst will be either an accidental discovery on imaging for something else, or it might be a serendipitous discovery. It is seldom that you see a patient who presents the way this patient had done with pain and infection and all. So this is the WHO and the International Working Group on Echinosis classification of hepatic hydrated cysts. Sanjay is giving me looks already because we are already running late. So I'll not go into too many details, but this starts with C1, goes up to C5, with starting with a unilocular simple cyst, going to a completely calcified inactive lesion that appears hypointense on all MRI sequences with no residual cystic components, with whatever you see in between as the intermediate class. So this is the evaluation algorithm which we follow in our clinical practice, and I would like all my learned panelists and discussants to weigh in if they differ with this in any way. Our first thing, the radiologist is an essential friend when you are managing hydrated, because the USG abdomen is your first line of investigation. The cysts are categorized according to the WHO IWGE classification. Then you do the CECT or MRI, which is useful when the ultrasound is inconclusive. I would not say it is mandatory, but when it is inconclusive, when you have complex cysts, when you want to assess daughter cysts, membranes, pericyst, calcification, complications, and like Dr. Piyush has already mentioned, MRI is particularly useful for identifying the pericyst, where it shows you the rim sign, floating membranes, and biliary communication. Then, of course, you have the clinical and the labs, the risk assessment. Look for eosinophilia if it is there. LFT, the basic thing to look for is increased alphos, and serology, where you would want the IHA, the ELISA, the ARC5, and sensitivity depending on the cyst state. Additional workup can include an upper GI endoscopy to rule out any malignancy, to suspected fistulization, ERCP, biliary communication, chest X-ray, and always rule out a pulmonary involvement. And in many patients, when we have seen, they present with neurological symptoms because it is also known to affect the brain. And those are the most dangerous type of hydrated cysts, which are also unfortunately quite resistant to treatment. So what is the role of serology in hydrated cyst? If Dr. Ravindra or Piyush could take it.
Serology is basically to establish the diagnosis when we are not sure. Second thing is serology is found sensitive only for the active cyst
and will not be useful in C4 or 5 cysts. And serology may be helpful in assessing the complications also, cyst rupture and intraperitoneal, particularly or after treatment. If the serology level is going high, then it suggests recurrence.
So it's more of a prognosticating factor. Anything else you would like to add? Piyush?
It should not be used as a cure because it will be positive after the.
So it is
treatment
more,
also.
yeah, exactly. The point is well taken that you should not be using it as a surrogate for cure. You basically have to see the rising levels. So the management of hydrated cyst, which is a stage-based approach according to this, is to start with medical therapy. The pair technique which I talked about is something which I think is criminally underused and should be used more often now with good interventional radiologists we have. The medical therapy is a cornerstone. By giving, before you intervene, albendazole, the results are much better, the recurrences are much less, the cyst sizes decrease, and you are able to get good results with a dose of 10 to 15 milligrams per kg per day. And the indications are given there, the small cysts, CE1, CE3A, multiple cysts, and pre and post intervention. Just a quick word from the panel on the use of mebendazole, praziquantel, nitazoxanide. Is anybody in the audience using these drugs, or all of us are happy using albendazole? And which are the indications where you would want to use the other drugs?
So regarding praziquantel, it is said that it is an adjuvant to albendazole. Like it cannot be given separately. It helps, or it is a supporting action along with albendazole. Secondly, it is mostly used for the cases where there is a recurrence, where there is a multiple involvements. In that cases, praziquantel is interested. It actually increases the permeability of calcium, leading to death of these parasites. But it is having a synergistic action with albendazole. But it is given twice weekly, and it is not given individually apart from albendazole.
Yeah, that's a very good point you brought up, Roshan. And basically, praziquantel is something which has to be used as an adjunct. It helps only in disseminated disease where your routine has failed, and like he rightly said, you are never going to use it as a monotherapy. It will be any experience of nitazoxanide, Chobal sir?
No, I have been using only albendazole, and I have one more question to ask.
Yes.
Actually, we are discussing this. There is one very dreaded thing which can happen if you have a rupture in the peritoneal cavity where you develop abdominal hydatidosis. How do you manage this? Innumerable cysts lying in the peritoneal cavity. How exactly to manage that situation? I had one patient like that whom I have been managing with multiple doses of albendazole to keep the cyst size lower. This thing. Do we have any definitive treatment for managing abdominal hydatidosis where you have multiple cysts lying in the peritoneal cavity?
I think this scenario is just like disseminated malignancy. So what happens that it is difficult to have a R0 kind of resection in such scenario. Surgically, what we can do is a debulking kind of thing. So just evacuate, remove, excise as much as possible from various area of the abdomen, and then we have to continue with the albendazole therapy for longer period of time. Instead of giving for 6 months, maybe we have to continue with a 1 year or maybe a 2 year.
I've been managing it for several years now. It rises sometimes, then again we put the patient on the longer course of albendazole. They all shrink in size. The patient is doing well, but still having.
I think in that scenario, we can consider for redo surgery. Because we have one patient which had a post-traumatic rupture of the splenic hydrated cyst, and that got disseminated. So patient underwent one surgery by open method previously at some other center. Some evacuation was done. Still patient had recurrence. Then we did the laparoscopic debulking, and now he is on long-term therapy. So what happens that albendazole alone is not going to actually cover the, resolve the infection. Alone medical therapy is not going to be effective. So ultimately we have to make a combination of surgery with.
Yeah, Vishal, I think that point is well taken, that you will have to use the surgeon's knife judiciously in this, but these are the cases from hell, sir. It is absolutely almost impossible to make them disease-free. I think I would agree with the policy you are practicing where you are just keeping the patient in what you could term as reasonable, remission would be the wrong word, but maybe as symptom-free as possible.
We can add praziquantel to sir's case, sir.
Sorry?
Sir can add praziquantel to that case.
Yeah, he could definitely add praziquantel. He could think of nitazoxanide also, but when you have disseminated disease, it is very less likely that any of these will work. That does work in occasional cases, but the sort of case he's describing, unfortunately, I have also had the misfortune of seeing one such case, and the patient is miserable and makes us also more miserable every time they come for consultation. So, okay, Dr. Roshan, since you are the pediatric surgeon here, is there any difference between adult and pediatric hydrated disease?
Yes, sir. With the spectrum of hydrated, what we see here, like apart from the liver hydrated, we have very commonly seen pulmonary hydrated. Lung hydrated is quite common in pediatric age group. Secondly, the rate of growth of this hydrated cyst in lung and liver is very fast. As compared to the adult, which grows at a rate of 1 to 2 centimeter per year, in pediatric it grows at a rate of 4 to 5 centimeters. Then once the size is growing, then the chances of complications are more in these patients. So we have to keep a watch on the growth of these patients. Thirdly, CNS-wise, hydrated cyst in central nervous system is common in children. Fourth, once you treat these patients, the prognosis is good. Like the recovery of these patients in hydrated is quite good. Investigation, so the message is like when you have a case of a liver hydrated in pediatric and adolescent age group, you have to look for hydrated in the lung as well. Around 20-25% cases, we have multiple hydrated cysts. Investigations, ultrasound, X-ray, CT, MRI, the spectrum remains the same. Treatment-wise, we go for surgery. Pair is less indicated. We do pair only in those cases where the site is inaccessible. Like if there is a hydrated in the upper pole of the spleen lying close to diaphragm, in that case we will approach by pair. Otherwise, we go for surgery.
Okay. So, like Dr. Roshan said, it's a more aggressive disease in pediatrics. They tend to grow much faster, and they have more of a non-hepatological site as the involved organ too. So, this is just a sort of summarization of pair as well as surgery. If you look at efficacy, it is comparable to surgery as per the RCT evidence, though the panel seems to, I think otherwise. It is, surgery is obviously the traditional gold standard. The complications are lower in pair compared to surgery. This is from the same RCT. The hospital stay obviously is shorter with pair compared to surgery. The recurrence has been reported to be higher with pair compared to radical surgery. The indications obviously are uncomplicated hepatic cysts for pair and complicated cysts for surgery. Invasiveness, it's almost oxymoronic. Pair is minimally invasive, whereas surgery has to be invasive. So what are the complications of hepatic hydrated cyst? I would request each one of the panelists to just weigh in quickly on these things because time is pretty short. Superinfection, intrabiliary rupture, peritoneal rupture, thoracic involvement, fistulization, and vascular or organ involvement. How frequently do you see these? And is it a real concern with most of the hepatic hydrated cysts you see?
Most of the time, as a gastroenterologist, we see either intrabiliary rupture or superinfection. These are the usual two complications. We don't usually see peritoneal rupture or fistulization or various organ.
Okay. Do the surgeons agree, or is your experience any different?
No, I think this intrabiliary rupture or fistulization in the biliary tract, it does the same thing. The biliary communication is, I think it is one of the most common situation that we see either intraoperatively or sometime postoperatively.
Yes.
Preoperative presentation is different. If there is a communication or sometimes there is no communication but there is a compression of the biliary tree, especially if it is a large, if it is located centrally towards the hilum, there is a compression of the CBD. In those situations, the presentation is sometimes different. They present with jaundice, they may present with cholangitis, they may present acutely with fever and pain, unlike the uncomplicated hydrated cyst. But in general, I think biliary complications are much more than the superinfection.
Yeah, that point is well taken.
Two important points, sir, regarding thoracic involvement and biliary involvement. Once you decompress that cyst or take out the cyst, then with a drain, you find bile coming out. So you have to keep a drain for a longer time to settle. And secondly, for thoracic involvement, there is a lot of air leak in the ICD. So we prefer to close these small bronchioles which open up during surgery and then sort of do a capitonage and put a drain there.
Okay. So we'll just rush through this last few questions for you. Dr. Kale, would you have ordered serology test upfront in this case, and what thresholds change your management from wait and watch to intervention for CE4 and CE5 subtypes? Make it brief.
Serology, as I already told, that this is clear-cut case, but just to confirm, we can do this. And if in CE4, CE5, if there is change in size, if there is appearance of jaundice, or if there is symptoms, then we can change from not doing anything to surgery.
Okay. So, Dr. Vishal, how do you decide between pericystectomy versus liver resection? When is marsupialization preferred by you, and how do you protect against intra-anaphylaxis and spillage?
So I will start answering in the reverse direction. I think this protection against the intraoperative anaphylaxis and spillage that starts preoperatively. So you have to start with the albendazole at least 1 week before any kind of intervention, so that the pressure within the cyst decreases. So at the time of your intervention, the spillage is minimized. And during the procedure, you have to be very careful that when you are puncturing it, opening it, you have to keep ready with the multiple suctions with good suctioning of all the fluid which is spilling out from the cyst. Second, during the procedure, especially during the surgery, you have to use the multiple mops or gauze around the cyst where you want to open it, and then soak it with the sclerosis agent so that whatever content is coming out from the cyst, that is immediately sterilized by the sclerosis agent. Second, this marsupialization, basically it is the de-roofing, and it is the conservative kind of surgery. I would say it is the most common surgery which is being done for the hydrated cyst, especially when we have adopted the laparoscopic approach. So this is one of the most common procedure. Coming to the pericystectomy or liver resection, basically both are radical surgery, right? And if you want to choose between the pericystectomy or liver resection, you need to understand that this is a benign disease. So why to resect additional amount of parenchyma of liver beyond pericystectomy? If you can do away with the pericystectomy, it is better to do the pericystectomy. But at the same time, suppose there are a multiple cyst which is occupying one portion of the liver, for example, left lateral section, or there is a complicated cyst, then you can resect entire portion of the liver along with those cysts.
Thank you. Dr. Goel, my apologies for not having involved you till now, but could you let us know why my radiologist is also pretty good. Why did he miss USG and CT, did not show him intracystic abscess? Do you think he could have done something differently? And what makes his cyst suitable for pair in 2025? And when does MRI change management?
In this case, what happened is that sometimes if the cyst is infected, we may see air in the cyst. So in this case, air was not there. So it is one of the signs which we say that infection is there. So maybe that is the why, because in CT it was not diagnosed. But MRI is definitely a modality where we can be more sure of an infection, because in diffusion weighted MRI we get diffusion restriction. Also in T2 weighted imaging we see heterogeneous signal intensity if the cyst is infected. And plus in MRI we also see pericystic enhancement. So all these are features which are in favor of infection in MRI. And one more thing I would like to add is that we should always see the patient clinically. The patient is symptomatic, patient has come to us with a symptom. So we should always think that there is something wrong with the cyst. This is not a simple hydrated cyst. So we should think in terms of definitely infection or rupture or communication with the biliary tree, something should be there.
Yeah, I think I would completely endorse what you said. And since we are running short of time, I would just want the audience to focus on a few key takeaways. I have taken out the last two questions because they were pretty much answered during the discussion. An intact cyst on imaging does not exclude secondary infection. Please keep this in mind. Risk factors will include residence in endemic regions. So when you have people coming with pastoral exposure who are immunocompromised, diabetic or post-transplant and all, please do think of hydrated. Albendazole pre-op is recommended to reduce viability of scoliosis and prevent intra-op dissemination, as already brought out by our surgical colleagues. There is no single gold standard. You have to individualize based on cyst type, size, location, and the surgeon's expertise. This is extremely important. Hydrated is not something which anybody or everybody should be attempting without the required backup. Culture the cyst contents. Gram-negative organisms like E. coli and Klebsiella are usually responsible for secondary infection. Post-op surveillance is essential in this because recurrences are quite high, and the chances of spillage, in spite of the best technical expertise, is an ongoing risk. Thank you very much, and if there are any questions from the audience, I'd be more than happy to take them and also ask my learned panelists to weigh in.
Thank you, Dr. Manish Bhatnagar, for an excellent panel discussion. Sorry we cannot allow any more questions. So apologies to the discussants and chairpersons, but we already had decent discussion, and I think everything is very well told by, it was covered during the discussion. You can call the next chair. Till the time you can ask. Yeah, but please call the next panel first.
So for this next session, I would like to invite.
Do we need to rule out?
For this next section, I would like to invite the chairpersons on stage: Dr. Dinesh Upadhyay, nephrologist from Bhopal; Dr. Iqbal Ansari, pediatrician from Bhopal; Dr. Prateek Tiwari, assistant professor medical oncology from Gandhi Medical College, Bhopal; and Dr. Rahul Agrawal, surgical oncologist from Bhopal, Siddhanta Red Cross Super Specialty Hospital. So the first talk in this session is on adult vaccinations, and the speaker is Dr. Ravi Doshi, pulmonologist from Indore.
Yes. Do we need to rule out cranial involvement of high risk before starting medical treatment?
Before starting?
Medical treatment, albendazole or anything? Yes, definitely. I mean, whenever you have cerebral involvement, it's
Patient is asymptomatic.
Yeah, most of these patients tend to be asymptomatic.
Yeah,
but it is still worthwhile if you have more than a single cyst outside the liver to also look at the brain, because we do see a lot of central neural involvement with this.
I think you can proceed with the next session. Dr. Doshi.
Sir, may I start? Thank you. Thank you.
Please go ahead.
Sir, I understand there is a shortage of time. Lot of people are hungry. So believe me, just listen to my first 4 slides. Rest of the slides you can skip as I will be. There is a very famous saying, sir, कि हर बात का वक्त मुकर्रर है, हर काम की साथ होती है. वक्त गया तो बात गई, बस वक्त की कीमत होती है. Very important phrase, which is very relevant to this particular concept, which I have come to advocate over here to all my respected colleagues and seniors. Adult vaccination is one such research to molecule which is now translated into reality, and it is actually helping to change the whole scenario of infectious disease management. Well, you might say, what's the big deal? Vaccination is a very common thing. But the data is very much there for all of you to see. All the figures of all the researches done in India hardly cross the figure of 15%, 7% and 8%. Even post-exposure, even a common vaccination like tetanus toxoid is only given in 20%. What are the bottlenecks? The bottlenecks are our own thinking and our own lack of faith in adult vaccination, which I have come to justify. The commonly seen problems: lack of guidelines, treatment le lo, why to go for vaccination, cost issues, and the prioritization of vaccination is not there. I would just like to have 2 important slides over here. One is this one. Well, throughout the life, the slide is shifted up. The important point is that throughout the life you can be vaccinated, and there are particularly important vaccinations which are available. Instead of going through the busy slides, I will concentrate on 4. Most importantly, influenza, which you can give from your age of 2 years till you are 100-year-old. The vaccine of herpes, which is called as Shingrix, which can be given above 50 years of age. If you are below 50 but having immunocompromisation, then 2 doses can be given. The third is pneumococcal vaccination, for which a single dose is available. And the fourth one is DPT vaccine, which we are all given as a part of UIP, but a booster dose can be given once in pregnancy in females, and also if you have crossed the age of 40. The other important slide is this one. Well, as per medical conditions, all of you as gastroenterologists know that patients don't come in a single problem. They come with multiple problems. So what is important is, I can't be a gastroenterologist, I am a pulmonologist. But I see a patient with a multi-system problem, you see a patient with a multi-system problem. So at least आप उसको वैक्सीनेशन के बारे में बता दीजिए कि ऐसा कुछ होता है, relevant person से जाके मिल लेना. Maybe active disease में vaccinating might not be a good idea, but when the patient follows up with you, you can definitely advise adult vaccination. It will be a superb idea to prevent further incidence of infection in that particular patient. किस किस में आप सोच सकते हैं? Immunocompromised, who, apart from HIV, even in HIV, those having aspleninemia, those having CD4 less than 200 or more than 200 due to various reasons, all those on active immunosuppression, before the immunosuppression is started or biologicals are given, you can prescribe them this whole gamut of vaccinations which is available. Lot of hue and cry or lot of awareness goes about vaccination in children, but now that is a well set technique. In adults, it is a big challenge, and that challenge can only be taken care of by you and me. So, moving forward, I will really avoid going into depth. Influenza, why it is good to vaccinate is, it affects a lot of people, but by vaccination, you can actually decrease hospitalization, decrease mortality, decrease ICU admission. Then coming to pneumococcal, single dose is available. What is the advantage? Pneumococcal happens in all of these conditions, but again, decrease hospitalization, decrease mortality if you give vaccination. You go ahead and come to the main thing. The main thing is herpes. Herpes vaccination is a huge boon to society. Any and every person sitting over here might have seen a person, a patient or a family member suffering from herpes. The incidence is universal. 99.5% more than 50 years of age are affected with herpes in some way or the other. So the important point is you have to be very focused while advising these patients. It is not only going to affect the incidence of herpes, but it is also going to come down on the post-herpetic complications which several patients undergo. Not only post-herpetic complications, but even reactivation of herpes if the patient is immunosuppressed due to some condition can be prevented by giving herpes vaccination. So I would like to justify this slide for all the diseases. As we age, there is a phenomena called immunosenescence. He can be 100-year-old, he can be a person doing yoga daily, he can be having the best of diet, but still with a waning immunity, he can be predisposed to infections. So it is a good idea that you and me start putting in the idea of adult vaccination now, so that at least 1 or 2 years from now, adult vaccination becomes as standardized and protocolized as pediatric vaccination. So I actually have completed whatever I wanted to say. I feel that I have 2 minutes. If there are any questions that my chairs have or my audience has, I feel we should take up that time in that. Thank you very much. Yes, sir. That person can be vaccinated once the active phase of the disease is over. In the future, that person can be vaccinated. A minimum interval of 6 months is there, sir.
Because you were not audible, I am repeating for the audience. Dr. Badni asked if a person had herpes, should he be vaccinated? So the answer is yes.
Most definitely.
Even if you had herpes, you should be vaccinated again.
It prevents post-herpetic complications and recurrence, so it is always advisable.
So anything related to CKD, if a patient of chronic kidney disease is there, they follow the same vaccination schedule?
Mostly the schedule is same, sir. Stat dose given and 2 to 3 months later, the next dose is to be given deep intramuscular. Same schedules.
Would like to know from Dr. Upadhyay, like in CLD patients, we have started vaccinating all our chronic liver disease patients for certain disease. Like if they are NAFLD, we will vaccinate for hepatitis B and A. We will vaccinate for influenza every year. We will vaccinate them for Shingrix. And pneumococcus also we are trying to. So what about CKD patients? What all vaccinations you regularly do?
The first vaccination we advise our CKD patients is against hepatitis B. And here the dosage even is different from those, from normal patients. We recommend hepatitis B vaccine 40 micrograms in place of 20 usual, given as dosage is day 0, 30, 60 and 180. That means 4 dosages in place of 3 recommended normally.
0126, not against 016.
Yeah.
0126.
And plus usual as you give in CLD patients.
We have been managing IBD with various immunosuppressants for such a long time. Shingrix has come recently. There are many patients who are already on biologics. They may be on tofacitinib. They come. we usually ask them to have a vaccine. What is the, the response, immune response to this particular vaccine in an immunosuppressed patient? Do we have to have only 2 doses, or you have to give more doses of vaccine in these situations? And if you give 2 doses, how do you assess their immune response to that particular vaccine in an immunosuppressed patient?
So the protocol for immunosuppression straightly is told that you have to stop that particular immunosuppression for a period of time and then only vaccinate the patient. And the response will definitely be taken in terms of clinical response only, sir, whether there is a recurrence or not. There is no change in the protocol of vaccination in such cases, sir. There is no change.
Sir, as far as the kidney diseases and renal patients, especially the CKDs are concerned, we are more apt to give vaccination to our patients in the early CKD stage because they are immunocompromised as the CKD progresses. Do you recommend GM-CSF along with the vaccination? Because some of the reports or some of the recommendations earlier were that with hepatitis B vaccine, we should supply them with GM-CSF. Number one. Number two, as far as the pneumococcal vaccination is concerned, we used to give 2 types of vaccines. One is Pneumovax, another was Prevenar. Prevenar 13 and Pneumovax 23. Nowadays, Prevenar 20 has come. What do you recommend? Only Prevenar 20 can prevent and is recommended, or should be recommended? Or we should still be going with the 2 doses 8 weeks apart?
Sir, your first query regarding GM-CSF with Shingrix, sir, there is no official contraindication which is stated in the study material which is available. In fact, we give all 4 vaccines together, the first 4 adult vaccines. So I believe I work with my nephrologist and they give them comfortably together. We haven't seen any problem as such. As such as recommendation, nothing lies in the data against. So you can give. Second, I do recommend Prevenar 20 because it is a more serotype coverage as compared to 13 and 23 together. So it is always a good idea to vaccinate with Prevenar 20, even if previously vaccinated with 13 or 23. At a time interval of 6 months to 1 year, you should vaccinate with Prevenar 20.
Does it need to be combined with Pneumovax 23?
It doesn't, sir. The overall coverage of 20 is comprehensive as far as pneumococcal serotypes are concerned.
So now on only Pneumo 20 will be there because those 2 are not required. The single dose is sufficient. So I think we had a very good discussion on vaccine. Thank you, Dr. Doshi. We'll move on to the next question and we can discuss next session.
So for the next talk on the topic managing diarrhea in a neutropenic, I would like to invite on stage Dr. Aniket Goenka, Consultant Medical Oncologist, Chirayu Medical College and Hospital, Bhopal.
At the outset, I would like to thank the organizer, Sanjay sir, for the invitation and providing the stage. I would be talking about diarrhea in a neutropenic patient, and focus will be for the neutropenic patient and not just cancers. The topics that will be covered would be neutropenia, incidence of diarrhea, mechanism of diarrhea in neutropenic patient, neutropenic enterocolitis as an entity, the newer tools, role of multidisciplinary team, and key treatment-related aspect. If we look at diarrhea in a cancer patient, there are several reasons why we see diarrhea in a cancer patient. Firstly, the paraneoplastic feature as a manifestation of cancer itself. Then we have the therapy-related aspects such as a chemotherapy toxicity or a radiation toxicity or a immune-mediated toxicity. And then we have the infection-related because of the decreased immunity. And then we have the graft versus host disease, which is also an important aspect and a confusing picture when we see our bone marrow transplant patients where they have neutropenia, a rising titer of WBCs, and we have seen a graft versus host disease as compared to the infectious cause, which is most commonly seen with neutropenia. How we define neutropenia as an absolute neutrophil count of less than 500. If associated with fever, it is called as febrile neutropenia. This is the
entity which is associated with high mortality and is certainly something that we as oncologists really want to detect early, because the early detection of febrile neutropenia gives us promising results. If you look at the incidence of diarrhea in neutropenic patients, it can range from 10% to 70% diseasing based on different case series. So it depends on what kind of malignancy we are talking about. If we look at diarrhea in a stem cell transplant unit, it would be more than 40 to 50% patients would have symptomatic diarrhea. These variation is based on not only the disease, but also on the basis of the treatment that is being given. Some chemotherapies such as 5-fluorouracil, irinotecan will cause more toxicity, more diarrhea. There is definitely more instances of diarrhea in hematological malignancies because they are inherently immunosuppressed, as well as the chemotherapy protocols which are used in such cases are highly toxic. And then we have to identify those patients in neutropenia who are at a higher risk. And because of this, we have a MASC index, that is a multinational association for supportive care in cancer index, which is able to identify those patients who are neutropenic and carry a significantly higher risk of death, of morbidity, of mortality. And based on this risk factors such as hypotension, active comorbidities, solid tumor, no fungal infection, no dehydration, outpatient status, age less than 60. Based on these scores, if the score is less than 20, then the patient is supposed to have a higher risk of developing mortality. Now, if you look at the instance of diarrhea, it is very commonly seen. If we look at the critical care admissions in an oncology unit, we will see at least 50% patients having neutropenia and at least 20% patients coming with diarrhea. And diarrhea is graded based on CTCAE as increase of less than 4 stools as grade 1, grade 2, 4 to 6 stools, grade 3, more than 7 stools. And based on the grading, we'll plan a treatment. If you look at the etiological organisms which are responsible for diarrhea, the bacterial causes, Pseudomonas, Staph, E. coli, Group A Streptococcus are the most sinister causes which causes the neutropenic enterocolitis, while other causes such as Clostridium difficile, which is associated with pseudomembranous colitis, and other such bacteria and viruses are associated with commonly seen diarrhea. So if a patient comes to me with neutropenia and diarrhea, how am I going to start his management? Of course, apart from the symptomatic management, the most important thing is sending the blood cultures as soon as the patient arrives. The blood culture should be sent. And the empirical treatment. The empirical treatment, as per the guidelines, should be according to the local antibiograms. So an institutional specific antibiogram and antibiotic choice should be there. There are 2 options which are given in every guidelines, either starting with a cephalosporin associated with a combination approach that is targeting 2 antibiotics, or we have an approach of single antibiotic. It could be either a higher antibiotic such as carbapenems, or it could be piperacillin tazobactam combination. So that based on local antibiogram, antibiotic choice of empirical drug should be made. The time to antibiotic administration has been proven to be significantly important, and it has been associated with mortality benefit if the antibiotic is started as soon as possible. Now, the most dreaded entity in neutropenic is neutropenic enterocolitis, where the classical findings are diarrhea, fever, abdominal pain, and neutropenia, where due to the mucosal breakdown associated with an immunocompromised state and neutropenia, we see necrosis setting in the bowel. And the diagnostic criteria is fever, abdominal pain, neutropenia, and the thickening of the bowel wall, that is more than 4 mm for a thickness, for a length of more than 30 mm. And if this diagnostic criteria is fulfilled, we label it neutropenic enterocolitis, which is associated with a mortality of 50%. So the investigations, the relevant investigations are, of course, all routines associated with stool examination. And then we have the viruses, the PCR-based assays, which have really come up and has shown a higher sensitivity and specificity in detection of these things. An important aspect here is that the PCR-based assays are important because they have a rapid turnaround time, where the traditional testing methodologies require a 2-day waiting period. This can be, we can get these results within hours. And if you look at the treatment of neutropenic enterocolitis, it would be aggressive fluid resuscitation, correction of electrolytes, bowel rest, abdominal decompression with a nasogastric tube, and a blood component transfusion because it is associated with bloody diarrheas, and a broad spectrum antibiotic, the institutional choice of preference, whether mono or combination. Colonoscopy has to be avoided in a neutropenic patient unless there is a very strong diagnostic dilemma between a graft versus host disease and a CMV colitis. And GCSF administration, the growth factors should be administered in symptomatic patient. It is not associated with mortality benefit, but it is definitely associated with earlier resolution of the disease. The antifungals should be added empirically within 2 days if the patient is not responding. I would like to stress that the management of a neutropenic patient with diarrhea is a multidisciplinary approach which requires not only a physician but also a microbiologist, an infectious disease specialist, and more importantly, a gastroenterologist. There is a role of surgery as well in neutropenic enterocolitis where resection and resection of the bowel is to be done in patients where there is evidence of perforation, intractable bleeding, and clinical deterioration. So certain take-home points: neutropenic enterocolitis is associated with a high risk of mortality. Preferable empirical antibiotic should be chosen based on local antibiogram. Time to antibiotic administration is a prognostic marker. Neutropenic enterocolitis is associated with significant mortality. There are newer tests such as biofire-based polymerase chain reaction-based tests are more rapid and highly sensitive and specific. And treatment should be multidisciplinary, and colonoscopy should be avoided in patients who are neutropenic. Thank you.
Thank you, Niket. Any questions? Sir.
Since the regular and checkpoint inhibitors, we have now another category of colitis which is there now.
Right, sir.
I see. How does this immune checkpoint inhibitor related colitis differ from this febrile neutropenic colitis?
So, sir, neutropenia is mainly a chemotherapy-induced manifestation. Checkpoint inhibitor colitis is the mechanism of it is totally different, and it is more so like an inflammatory bowel disease. In fact, the immune checkpoint inhibitor related colitis, the treatment protocol has been totally borrowed from inflammatory bowel disease.
Because their colonoscopy will be required in immune checkpoint inhibitors, but
Yes.
at the same time, the neutrophil count is also low.
Yes,
How
sir.
do we decide between the two then?
Sir, first of all, neutropenia will not be there when we are using immune checkpoint inhibitors. Secondly, it would have a classical presentation more associated with CTLA-4 inhibitors. The timing of it will be different. The neutropenic colitis would occur after 3 to 4 days, while an immune checkpoint inhibitor colitis will take time, usually after second and third administration of the immunotherapy. So the timing will be different, not associated with neutropenia, and the presentation will be very different than what we see with neutropenia.
Thank you.
Thank you.
So just one question. Are there any prophylactic measures you would take to avoid neutropenic enterocolitis in your patients? Patient is on chemotherapy. What are the signs you would, you would see that there's a chances or you would want to, give some GCSF initially and how to, any diet or anything to avoid this?
Right. So there are three things which I would like to talk about in prophylaxis. The one aspect in prophylaxis is that certain malignancies, certain hematological malignancies, we give prophylactic antibiotics. Then in certain patients who are highly predisposed to development of neutropenia, we would teach them that they might develop neutropenia, and we would make sure that they keep antibiotics stored in their refrigerator. So this is part of our training of the patients, that we make it a point that the patients have antibiotic vials preserved in their refrigerator. So even if they are coming from a far off area, they should have access to antibiotic, and they should be able to give themselves injectable antibiotics within 1 hour of development of fever. And the third and important point is the role of prophylactic granulocyte stimulating factor has not been recognized. So it is several studies have shown that the role of GCSF is not there in prevention of mortality. It just reduces the period of fever. So those are the three important points. And another important aspect that has been discussed is the low microbial feeds. So we teach patients that fruits such as angur, which do not have a covering, or which do not have a thick cover, should not be taken. It should be low microbial feed, hot soups, whole fruit with thick cover. They should be preferred during neutropenic period.
So raw things should be avoided.
Yeah, those kind of raw things with rough covering which cannot be removed.
Thank you.
Thanks, Aniket and the chairpersons. Thank you.
Thank you, sir. We quickly move on to our next session. I call upon chairpersons Dr. Alok Verma, Senior Physician from Bhopal, Dr. D.P. Singh, Head of Department Medicine from LN Medical College, Bhopal, Dr. Sanjeev Johri, Internal Medicine Specialist from Hajela Hospital, and Dr. Kamlesh Tauri, Gastroenterologist from Tauri Gastro and Gynae Center, Amravati, Maharashtra. The first session will be enteric fever, what has changed in the last 50 years, to be spoken by Dr. Gopal Bhatni, Senior Physician from Sage Apollo Hospital, Bhopal.
So thank you, Sanjay, for giving me the opportunity to address from this august platform. Thank you. Since morning, we have been listening to very high funda talks, endoscopy, endoscopic interventions and all. Talk about the recent advances and about the future. But I'll be taking you back 50 years. So 50 years is supposedly the time when I entered the medical college. And at that time, in the medical wards, whenever we used to have a patient of fever, the first diagnosis would be malaria, and if it is not malaria, then it has to be typhoid. The diagnosis was basically clinical because not much reliance on the diagnostics that we had in those days. And what we were taught was to offer chloramphenicol, 50 milligram per kg body weight to a maximum of 2 grams per day. And once fever abates, bring down the dose to 30 milligram per kg body weight for the next 2 or 3 days. Patient would be fine and go home, and no problems thereafter. But maybe a decade later, when I was working in Kasturba Hospital, there the diagnostic facilities were more robust, and we used to get patients very initial part of the fever. And I saw many cases of culture-positive typhoid, culture-positive salmonella. Simultaneously, we realized that chloramphenicol is not as effective as it was in the past, and we started using amoxicillin and at times a combination of sulfamethoxazole and trimethoprim. Over the next 5-7 years, we realized that even this combination is not doing what it was doing earlier. And at that time, ciprofloxacin came into the market somewhere around 1990 or 1991. And we had wonderful results with ciprofloxacin for almost a decade. Now, for the past couple of decades, we have been relying on ceftriaxone as the drug of choice for treatment of typhoid. And azithromycin has been added in the last few years. But nowadays, we are also coming across cases which are not responding well even to ceftriaxone and azithromycin. And very recently, we have had an outbreak of typhoid in a town near Bhopal. Many cases of typhoid are coming. And one of my senior colleagues, he gave me a call a week ago and said, Dr. Bhatni, ये तो ceftriaxone से respond ही नहीं कर रहा है, क्या करें? तो मैंने कहा, सर, कार्बापेनेम यूज़ करना पड़ेगा, आजकल ceftriaxone से बात बन नहीं रही है. So this is what is the change that has happened in typhoid over the last 50 years. So these are the things that I am going to touch upon. So Salmonella gram-negative bacteria. Now, important thing is that the ingested dose is an important determinant of incubation period and severity of illness. The higher the dose of ingestion of the bacteria, the shorter will be the incubation period and more serious the illness. And conditions that decrease stomach acidity, decrease intestinal integrity, or alterations in the intestinal microbiome, they all increase the susceptibility to infection. So Salmonella, it can cause infection in humans as well as in animals. Enteric fever, Salmonella typhi, paratyphi A, B, and C, and simultaneously there can be non-typhoidal Salmonella, that is NTS, which can lead to gastroenteritis and cause extraintestinal invasive infections also. So these are the things which we are talking about today. It's identified by its H antigen, O antigen, and VI antigen. The H antigen determines the serover or serotype of a Salmonella isolate. The O antigen determines the serogroup of a Salmonella isolate, while the VI antigen, it confers resistance against anti-O antibodies, phagocytosis, and complement-mediated killing. That means it protects the bacteria against the defense mechanism of the body. So it's a systemic illness, and India has been experiencing an increase in typhoid cases, approximately 10 million cases in 2021. The clinical picture is very similar to the rickettsial typhus fever, but the difference was in the complications. Typhoid used to have intestinal hemorrhage and perforation, and that is why this disease was named as typhoid, typhus-like fever. And for one and later to quinolones as well. XDR, the variety when there is resistance to third generation cephalosporin and even to azithromycin, in which case we are left with carbapenems to treat. So practically every 8 or 10 years, a new generation of antibiotics which have been effective initially, the bacteria has become resistant to it. What is going to happen 10 years from now? We don't know. So a fever, a typhoid fever that responds to all is a non-resistant, which is resistant to most of the antibiotics, is multi-drug, and what is resistant to third generation cephalosporin and azithromycin also is a XDR typhoid fever. How about prevention of this disease? Well, we had some oral vaccines in the past. They had to be administered frequently. I mean, the initial dose used to be 3 or 4 doses of oral vaccine, and it was not suitable for children below 6 because it was a live vaccine and sometimes it used to cause the disease itself. Later on, we had a VI polysaccharide TAB vaccine which was used for many, many years, but it was not suitable for children below the age of 2 years. Now we have a conjugate vaccine. It has a greater efficacy because the conjugate gives a more, it gives a boost to the original vaccine. It has a more immunogenic response, which is longer lasting. Although even this vaccine also has to be repeated in a duration of 3 years. A typhoid vaccine that can prevent about 40 to 90% of cases during the first 2 years. The vaccine may have some effect up to 7 years. Diagnostics, blood culture is the gold standard. Bone marrow culture is positive in about 80% of cases, but it is invasive. Bile and stool cultures for chronic carriers. Vidal has many shortcomings. It can be falsely positive, yet it is easily available and is a useful tool, especially in poor countries. The newer tests, the Typhi, DOT, and Tubex, they are more reliable, quick, and simple. The PCR methods are precise, but need trained personnel and infrastructure. In the pre-antibiotic era, the mortality rate was 20% or even higher. Now it has been brought down to 1%. And in spite of these resistant strains, the mortality still remains about 1%. And it happens in those people where there is a delay in diagnosis, inappropriate antibiotic choice, or occurrence of complications in the form of hemorrhage or perforation. The issues to be addressed, water, sanitation, hygiene needs to be addressed, especially in poor countries. Long-term control of the disease is still far beyond because of the limitations and because vaccine needs to be given frequently every 3 years. So the take-home message is the high burden persists in South and Southeast Asia despite advances in sanitation and healthcare, rising incidence of Salmonella paratyphi because none of the vaccines gives protection to paratyphi. The conjugate vaccine is more safe, effective, and long-lasting. The emergence of multi-drug resistant and XDR strains limits treatment options and increases morbidity. The future control depends on vaccination, antimicrobial stewardship, and public health measures. Thank you.
Sir, I would like to add on a few my experience. One that initially, approximately 20 years back, I reported Salmonella typhi culture in 9 hours that patient belongs to Dr. Sanjay Kumar. In his presence, identification was done because he used to come at the Delta lab, and while he was there, so I said that it is about to finish, and sensitivity was, but the identification accuracy was 99.9%. At the time, technology was mini API. That was semi-automated identification technique. Good thing about the resistance of the Salmonella typhi is that mostly it is not accommodating to the plasmids. So recombinant modifications are very rare in this. And still a good number of patients are sensitive with the basic antibiotics. MDR, XDRs are reported, but they are less in number. Major issue in the treatment of Salmonella typhi is the right drug concentration. I have seen two, I will discuss only 2 patients. In one patient, it belong again from the doctor's family. They told me that मेरी बहू आ रही है और आप तुरंत उसका रेलवे स्टेशन से सैंपल ले लीजिए. तो मैंने फिर 1 महीने से लगातार बुखार आ जा रहा था और it was Salmonella typhi or resistant to most of the sensitive to most of the drugs.
Apur, please be brief.
हाँ बस खत्म कर रहा हूँ सब मैं. तो उस पे जो समझ में आया कि जो हो रहा होगा, तो मैंने कहा मैडम केवल इसमें एंटीबायोटिक का डोज इंक्रीज करना है। सेकंड, ऐसा ही मैंने बोन मेरो से आइसोलेट किया था, उस पेशेंट का भी लंबे समय से ट्रीटमेंट लगा था, फिर जो ट्रीटमेंट हुआ वो भी अगेन इंक्रीज डोज के साथ हुआ, देन दे आर फाइन।
Sir.
We have a very famous case in the history of typhoid, that of Typhoid Mary. Her name was, I think, Mellon Mary or Mary Mellon, whatever it was. How do you recognize carriers? There are many people who become carriers. How do you recognize them? How do you diagnose them? In good old days, when amoxicillin was there, we used to manage these carriers by giving at least 3 months course of amoxicillin and all these things. What are the recommendations for managing such carriers who are asymptomatic but keep shedding salmonella and are a very potential risk, especially in certain regions? What guideline, any latest recommendations for managing these kinds of carriers?
Well, even I was aware of prolonged oral antibiotics. If there is something new in this, probably Dr. Chawal himself would be able to throw more light on this.
I only know this thing that VI antigen testing is done to identify carriers, but what do we do these days? Because amoxicillin no longer is used in these patients. What do you do for these carriers then? Do you send them for cholecystectomy or not? I don't know. Because they are usually the involved carriers.
Carriers, basically, biliary carriers can be detected by stool culture.
Bile culture and stool culture.
Bile culture and stool culture. If you are not able to give us bile, we can very well do stool culture by using selenite F, which is an enrichment medium, liquid based. Only thing is to pass the stool to change the ratio between E. coli or normal flora and salmonella on the subsequent day. Subsequent day we can transfer the a loop full on a selective culture medium. So it is a 2-day procedure where the stool culture can be enriched in an enrichment medium so that we can isolate and then put the sensitivity. Another thing is urine culture. It is also shaded in urine. Here also we can use selenite F along with the bile broth and then report you whether it is a urinary carrier or not.
Hello.
So bile if you provide, it's okay. If you are not able to provide bile, you can very well write stool culture with due enrichment. Thank you.
Thank you, Dr. Bharti, sir. Next speaker, I invite Dr. Mayank Patel. He will speak on the upper GI infections.
Good afternoon, everyone. My topic assigned to me is upper gastrointestinal tract infection. I would be very brief. So my topic will be covered in following headings. To introduce prevalence of esophageal infection are increasing parallel to the prevalence of the organ transplant HIV and use of immunosuppressive drugs. So the clinical presentation is dictated by the infective pathogen. The specific immunodeficiency state, its pathophysiology and severity dictate the spectrum of clinical presentation, and the severity and chronicity of the infection for an immunosuppressant patient are dictated by the cause, duration and type of the immunodeficiency. And the endoscopic feature of any GI infections are variable and overlapping, so making definitive diagnosis by biopsy is essential. So esophageal infection, case 1, there was 54-year-old female with history of nocturia and polyuria, suggestive of diabetes mellitus, no history of comorbidity. Presented complaint were dysphagia for both solid and liquids for last 15 days, history of weight loss of 3 kg in last 1 month, no history of abdominal pain, fever, vomiting or nasal regurgitation. So endoscopic picture is suggestive of this white curdy plaques in entire esophagus. So the diagnosis is esophageal candidiasis. Symptoms of esophageal candidiasis are dysphagia, retroesternal pain and oral thrush. Oral thrush is associated in 30 to 50% of the cases. Risk factors are immunosuppression, medication, alcohol use, older age, diabetes, malnutrition and dysmotility. And in COPD patient and asthmatic patient, use of MDIs containing steroid. Diagnosis by endoscopy and brushing. Treatment antifungal in the form of fluconazole, itraconazole or voriconazole for 14 to 21 days. In pregnancy, amphotericin B is safer. Complication can be perforation, stricture, fistula formation or systemic candidemia. So now case 2, 32-year-old male presenting complaint odynophagia for last 5 days, history of fever for last 7 days, no history of pill intake or foreign body ingestion. Endoscopic image is suggestive of these type of ulcer with raised margin and pitting ulcer. Symptoms, it is herpes simplex virus esophagitis. Symptoms are odynophagia predominantly, then dysphagia and retrointestinal pain. Endoscopy suggestive of punched out or volcano-like ulcer, often small, discrete and well circumscribed and raised, with erythematous edges and yellow base. Diagnosis, the gold standard for diagnosis upper GI endoscopy with biopsy taken specifically from the margin of the ulcers. Immunohistochemical staining or PCR testing for HSV DNA are used for confirmation. Treatment, antiviral, acyclovir. Complication in the form of bleeding or perforation. Case 3, 55-year-old post-renal transplant patient presented with predominant complaint of dysphagia and odynophagia for last 1 month associated with low-grade fever. Endoscopic image suggestive of large single linear ulcer. This case of CMV esophagitis, symptom predominantly is dysphagia, odynophagia, chest pain, nausea, vomiting, fever, weight loss. In rare cases, bleeding from the ulcer. Risk factor, immunosuppression, reactivation of viral infection and immunoreconstitution, inflammatory syndrome in case of HIV. Diagnosis by endoscopy, biopsy, histopathology, immunostaining or in situ hybridization for CMV virus. Treatment in the form of induction therapy with gencyclovir, then converted to oral valganciclovir and supportive care. And complication, poor survival if not treated on time. Next case, adult male with history of fever for last 2 months and weight loss of more than 8 kg in last 2 months. Presenting complaint were dysphagia and odynophagia for last 1 month, no history of vomiting, hematemesis, and on evaluation he found to have HIV positive. Endoscopic image, large deep ulcer in the lower esophagus. It is idiopathic esophageal ulcer, most commonly associated with HIV infection, and clinical presentation in the form of severe odynophagia, dysphagia. These ulcers develop when CD4 count is less than 50. However, they have also been reported during acute retroviral syndrome, early HIV infection. Pathogenesis, they are believed to result from direct HIV-mediated immune dysfunction or cytokine dysregulation. Some studies have detected HIV RNA directly within the ulcer tissue. Because the symptom and appearance can mimic other conditions like CMV esophagitis and upper endoscopy and multiple biopsies are mandatory. Endoscopy appearance, they typically appear as large, often more than 2 cm deep, discrete punched out ulcer, often in the mid to distal esophagus. Treatment is ART, thalidomide and supportive care. Case 5, endoscopic image is suggestive of elevated lesion in mid esophagus with fibrinous base and ulcer. So this is a case of 32-year-old lady presented with fever, cough, weight loss and odynophagia for last 1 month. Weight loss is subjective. Histopathological examination suggestive of fair number of acid-fast bacillus and non-specific granulomas. CECT thorax suggestive of focal esophageal thickening with mediastinal lymph node, bit tree and bud appearance, bronchiectasis. So this is case of tubercular esophageal ulcer. Isolated esophageal tubercular ulcer are very rare, but often they are associated with mediastinal lymph nodes and pulmonary tuberculosis. Case 6, this is picture showing ulceroproliferative stricture in the mid esophagus. So, an apparently healthy patient without any predisposing factor. What could be the diagnosis? On histopathological examination, sulfur granules, often reveal pathognomic sulfur granules, yellowish clumps of bacteria and immune cells are there. And pathology stain, the bacteria are highlighted using gram stain or gomori methamine silverstein appearing as branching or filamentous structures. So this is that was a case of esophageal actinomycosis. It presented as esophageal growth. It is a mimicker of esophageal carcinoma. So if on repeated histopathological examination or biopsy, the histopathology report comes negative for adenocarcinoma, then suspect adenomyosis. This is endoscopic image and CT scan suggestive of diffuse ulcerative gastritis covered with yellowish and hemorrhagic slough. On CT scan, there is diffuse thickened edematous gastric wall and some air foci inside the gastric wall. So this is a case of acute phlegmonous gastritis, an extremely rare and life-threatening bacterial infection of the stomach, specifically affecting the submucosa, characterized by severe purulent inflammation that can be rapidly lead to tissue death or perforation of the stomach. Causative organism, Streptococcus and Staphylococcus in 70% of the cases. In some cases, pneumococcus and E. coli could be associated. Risk factor, while 50% of the cases occur in previously healthy individual, common risk factor include immunosuppression, chronic alcohol use, gastric condition such as stomach cancer, ulcer or recent endoscopic procedure, treatment, medical therapy, high dose antibiotics and in sometimes surgery, partial or complete gastrectomy. In infective gastritis case, 67-year-old diabetic male presented with hematemesis and melena, no history of NSAID abuse, alcoholism or antiplatelet use. So endoscopic image is suggestive of deep ulcer covered with yellowish black slough. This is a case of mucormycosis in post-COVID era. We are regularly seeing these cases, non-septated hyphae. Risk factor, uncontrolled diabetes, renal disease, immunosuppression. Diagnosis, gold standard is biopsy, treatment with antifungal medicine, amphotericin B as induction dose and posaconazole can be used later on. Case 8, it is a case presented as gastric outlet obstruction, recurrent vomiting. On upper GI endoscopy and antrum, we can see hypertrophic and ulcerated mucosa, and in duodenum, we can see hypertrophic patches. On histopathological examination, histoplasma capsulatum appears a small uniform round to oval yeast measuring 2 to 4 micron. There is characteristic hollow appearance on H and E staining. And treatment, initial phase, 2-week course of intravenous liposomal amphotericin B, maintenance dose with tetraconazole for 6 to 12 weeks. Case 9, it is yellowish discrete patches in the duodenum. This is a case of Mycobacterium avium intracellularly complex and foamy histiocytic infiltration in the duodenal mucosa, most characteristic finding in the presence of numerous macrophages with abundant pale granular foamy cytoplasm. So to conclude, whenever suspect any unusual lesion, please review the literature and do not forget to call your senior or colleague to get expert opinion. Thank you very much.
Thank you, Dr. Mahan. That was a wonderful talk. Because of shortage of time, I think so we have to skip to the next session. Thank you.
Thank you so much, sir. We quickly move on to the next session. The chairpersons for the next session are Dr. A.K. Dwivedi, sir, General Physician from Bhopal, Dr. Atul Kataria, Senior Pediatrician, Chirayu Hospital, Bhopal, Dr. Sanjay Gupta, Nephrologist from Bhopal, Dr. Sumit Kumar Singh, Pediatric Gastroenterologist from Indore. The first talk will be Changing Scenario of Hepatitis A and D. The speaker for which I invite Dr. Naveen TMV from GastroCare Hospital, Bhopal.
Good afternoon, everyone. Today I'm going to speak about the changing scenarios of the hepatitis A and E, both worldwide and also in the India. So first I would like to say regarding the changing scenarios worldwide, followed by in India, comparison of the hepatitis A and E. Again, in hepatitis A and E, what separate changes we are seeing. So this is one of the data from China. So here if we see like over a timeline period from 2019 to 2024, what we had seen is there is a shift of the hepatitis A is being increased, though the hepatitis A has maintained its baseline and hepatitis E is increasing. In comparison in India, so this is one of the study from Chandigarh, we can see from 2011 to 2018, the hepatitis A was always on the higher side. In between, because of some major outbreaks of the hepatitis E in this study, so we could get the hepatitis E. But again, in the 2018, if you see, the hepatitis A is more common compared to the hepatitis E. I would like to quote one more study here, where we have compared the different studies, where from 2002 to 2022, if we see, again, hepatitis A was always more compared to the hepatitis E. In between, in the 2019, it was little reverse. But what we can see at the end is when we compare the 2002 and 2022 is the hepatitis A incident from 24 to it has reduced to 9, whereas hepatitis E has reduced from 10 to 8. Both of them have reduced, but hepatitis A is still on the higher side. So this is again with respect to the urban and the rural and age group. So here we can see the, can I have pointer? Here if we see the, it is both of them are in more in the male group, and again they are more in urban areas compared to the rural, which was actually the reverse in the past era. Again, this is in relation to the age. So earlier we were seeing a more hepatitis A in the less than 5 years, whereas hepatitis E was considered a disease of the adults. Now we are shifting of the hepatitis A to the age group of up to the 30 to 40 years. So, and this is one of the study which shows the effect of the hepatitis A and E with its outcome, where if we can see the hepatitis A rarely goes for a fulminant hepatitis, whereas the hepatitis E can still go on a larger scale. So, what the changing scenarios we are getting in hepatitis A and E in India together is, globally the hepatitis E is increasing, whereas in India, though HEV is increasing, still the hepatitis A is predominating. This is, I'm now coming to the hepatitis A in India. Earlier, it is less than the 5 years of the age where more seroprevalent we were seeing because of the fecal-oral transmission and the other methods. Now what we are seeing is actually there is a shift of the age group from children to the adults. In the last slide, if we see in 2018, it is the adults who are more affected than the children, and of course the less number of the pregnant females are affected compared to the hepatitis C, which is I am coming later. So in hepatitis A, if we see like who is changing, whether it is virus, whether it is human being, or its immunity, or the environmental factors. To answer this, hepatitis A, we have 7 genotypes from 1 to 7. 1 and 3 are the most common which are causing. And the mutation in hepatitis A, unlike in influenza, they are relatively insignificant. So, occurrence of a new serotype is very rare. So, it means that it is not the virus which is leading to the change in the scenario. It has to be within the human and the certain environmental factors. So if we see the certain environmental factors, it is the sanitation. Yes, with the programs like Swachh Bharat Abhiyan and other things, our sanitation is getting increased. So the time of the exposure of the individual is actually shifting from the childhood to the adulthood, wherever there is a outbreaks in the form of monsoons and seasonal exposures. So earlier what happens in a less than 5 years is, it is only the B cells which get activated and the antibody will clear. As you go to the adult age group, it is the T cells which actually tries to act, either they will clear the infection or they will produce the more hepatocyte injury. That is why actually one will get a more complicated disease. So what changing scenarios we are getting in hepatitis A? There is a shift in the age group from children to the adult, and as this shift occurs, we can see a high severity of the cases, more and complications. So this was one of the wonderful article I got, hepatitis A wake-up call. This was in 2025 from Dr. Anil Anand sir. So they consider it as hepatitis is no longer a childhood illness that can be safely ignored, As the age increases, the severity increases. Though we have the hepatitis A, we discussed the adult vaccination just now. So though it is there, it is not yet incorporated in the adult immunization, or like we are not much oriented about educating the patients about it. So it has to be integrated, the hepatitis A vaccination, into the India's national immunization framework. So compared to the then hepatitis C is globally recognized as an enteric pathogen with a diverse transmissions route, zoonotic, parental and the vertical. With the age group, if we see, yes, still it is the disease of the adults. Most number of the pregnant females are affected here compared to the hepatitis A. Why this occurs? There is a change in developed nations and the developing nations. In the developed nation, it occurs as a sporadic disease. It is because of the genotype 3, and it is because of the consumption of more of the undercooked meat. Whereas in a developing nation, it is because of the outbreaks, seasonal outbreaks, because of the inadequate sanitation, fecal contaminated water, low socio-economic condition, and the natural disasters such as floods. Now, there were actually earlier the hepatitis E vaccine, which was more as a combination, more as a trial, more as a oral. Now we have very good HEV vaccine, which is a recombinant vaccine with a seroconversion of almost 100% after the third dose, and it has a duration of protection even after the 10 years up to 86%. So in hepatitis E, what the scenarios change is, in developed countries, it is still increasing because of the zoonotic and travelers. In the developing countries, it is increasing because of the sanitation. It has a higher tendency to cause the morbidity and the mortality, as that was always. The availability of the vaccine can be a game changer. So now with this, I would like to give some of our data from the GastroCare. We had around in between 22 to 25, around 200 patients. What we have studied over the timeline is, we can see the hepatitis A was always on the higher side compared to the hepatitis E. And if we see the age group in the hepatitis A, if we see the above chart, we can see it is the less than 5 years of the age are rarely affected. And what we are seeing is the shift in the adult in between 5 to 30 age group. The same in hepatitis E, what we are seeing is again from 5 to 30. Yes, the people of 40 and above 40 are also getting affected more. And we had studied the outcome where we got hepatitis E as a bad outcome. Up to 4% of the patients are affected compared to the hepatitis A. So with this, I'll conclude saying, my summary: hepatitis is no longer a childhood illness in India. A strict incorporation of the hepatitis E vaccination is needed. Hepatitis E is increasing both in the developing and developing nations with the different causes. And HEV vaccination can be a game changer, as this is predominantly fecal-orally transmitted. Sanitation plays a very important role in both these cases. Thank you.
Thank you, sir. For the last session, I invite Dr. Priya Gogia, Associate Professor in Bhopal, for the topic protracted diarrhea in a child. Is it infective?
A very good afternoon to one and all present here. Today I will be discussing about the persistent diarrhea with the focus on very important question, that is it infective? So, persistent diarrhea can be defined as a diarrhea which starts acutely but lasts for more than 14 days. It is presumed to have an infectious etiology. It leads to deterioration in the nutritional status and also poses a substantial risk of death. And it excludes the chronic and recurrent diarrheal disorders. If we see the burden of persistent diarrhea, it's a major public health problem. We see 60% of the pediatric persistent diarrhea occurs before the age of 6 months, 90% occur before the age of 1 year. It usually accounts for 10% of total diarrheal episodes, but if we see the contribution to the death, 35% of diarrheal deaths are due to the persistent diarrhea in children below 5 years of age, which says the impact is disproportionately high. If we see the natural course of diarrhea, the 70% cases of acute diarrhea resolves in 1 week. If not then resolved, 90 to 95% of cases resolves in next 2 weeks. Only 5 to 10% becomes persistent, and majority of the cases subsides in 4 to 6 weeks. If they are not subsiding in 4 to 6 weeks of time frame, that means we need to investigate for the other causes. The other causes of prolonged diarrhea can be cow milk protein allergy, immunodeficiency, celiac disease, lymphangiectasia, cystic fibrosis, and other anatomical causes. We talk of the causes of persistent diarrhea. The trigger behind the persistent diarrhea is infection. To begin with, the persistent diarrhea begins with the infection, but its persistence occurs because of multiple factors playing a role in its persistence. So if we see the common viruses implicated in the cause of persistent diarrhea, Rota and Noro are the most common viruses which are implicated as a cause of persistent diarrhea. Adeno and Astro are less. Cytomegalovirus is more common in the people who are immunocompromised. If we talk of bacteria, enteropathogenic E. coli is the main culprit which leads to the persistent diarrhea. Enteropathogenic E. coli is known to cause the attaching and effacing lesions leading to microvillus damage and reducing the absorptive area, creating a vicious cycle of malabsorption. The other causes includes the Shigella, Salmonella, Mycobacterium avium, Campylobacter, and Clostridium difficile is more common in the patients who are on prolonged antibiotic course. Amongst the parasites, Cryptosporidium and Giardia are more common in the child who are malnourished or who are having immunodeficiency. Other parasites can be Entamoeba histolytica, Isospora, and Cyclospora. So infection is the initial trigger, but it is not the sole reason behind creating the persistent diarrhea. The risk factors for persistent diarrhea is age, less than 1 year. Malnutrition is the most important factor leading to persistent diarrhea. Impaired immunity, early introduction of the animal milk, lack of breastfeeding, occurrence of the recent diarrheal disorder, or systemic infections. If we see the pathogenesis of the persistent diarrhea, the initial injury is due to the enteric infection, which may be in the form of virus, bacteria, or parasite. After the mucosal injury, there is villus atrophy and crypt hyperplasia. That leads to the cycle of a malnutrition in which there is a poor nutrition absorption, increased susceptibility to infection, and also there is dysbiosis. All this leads to, because of the loss of brush border enzymes, there is secondary lactose intolerance. Because of villus atrophy, there is protein and fat malabsorption, and also there is bacterial overgrowth which fights for the nutrition consumption in the intestine, and this further leads to food allergy and infections. So the cycle continues, and there is a cycle of infection and malnutrition, and this leads to a prolonged diarrhea. So the management of persistent diarrhea should include the control of diarrhea and its consequences, which is mainly dehydration. It should include the treatment of the infection, and third is nutritional rehabilitation. So if we talk of the fluid resuscitation, in cases of some or no dehydration, we are going to deal with the oral ORS solution. Low osmolarity ORS is effective. In cases of severe dehydration, we go for IV fluids. We need to do the correction of the electrolyte imbalances. Hypoglycemia need to be corrected. In cases of children who are suffering from severe malnutrition, we should not go for IV fluid unless they are in shock. We should manage these kids with the Resomal. That is the rehydration solution for malnourished children. We also need to identify infections, because one of the cause of persistence of diarrhea is systemic infection. There may be hidden infections in the lungs or in ear, like otitis media may be there, pneumonia may be there, severe sepsis may be there, which is leading to persistent diarrhea. So we need to do the thorough clinical examination to look for the hidden signs of sepsis in such kids. Also, we need to examine the perineum and oral cavity to look for the fungal infection. CBC, CRP, total protein, albumin, blood sugars, electrolytes, cultures, and chest X-ray should be done routinely. 3 consecutive stool samples should be sent to identify the parasite if it is parasitic infection. Stool for fungal hyphae and Clostridium difficile toxin should be done in isolated cases where you are suspecting these organisms as opportunistic organism. We need to identify the infection, treat them with the antimicrobial as well as antifungal if required. Antibiotics are always indicated if you get a child less than 3 months suffering from the diarrhea, and also if the child is having severe acute malnutrition. Dietary management. We need to look for the features of secondary lactose intolerance due to loss of the brush border enzymes. So we need to see whether there are perianal rashes, explosive stools present. If those two are present, they are suggestive of secondary lactose intolerance. So we will decide the dietary therapy according to that. We also need to look for the micronutrient deficiency. If any, we need to correct that. we should continue breastfeeding in less than 6 months. In more than 6 months, we should continue the food during diarrhea. Home-based culturally acceptable food should be given to the child at a dose of 100 calories per kg per day. Diet therapy, not all the cases of persistent diarrhea need reduced lactose or lactose-free diet. Only the cases which are known to have secondary lactose intolerance should be started on a low lactose diet, that is diet A. We will see the response if down the line around 7 to 10 days there is no response to low lactose diet, we are going to switch to lactose-free diet. Still there is no response after 7 to 10 days, we shift to monosaccharide diet. If not so, then we shift to semi-elemental or TPN. This is very important because a nutritional rehabilitation breaks the vicious cycle of malnutrition and persistent diarrhea. To break the cycle, we need to do the nutritional rehabilitation in the kids having persistent diarrhea. So should give the multivitamins twice the RDA for 2 to 4 weeks. Folic acid, vitamin A, potassium and magnesium sulfate should be supplemented. Elemental zinc, vitamin D, vitamin K and iron should be given. Iron should be given after the cessation of diarrhea, not during the phase of diarrhea. We see the probiotics from the InfeCON 2023 guidelines. They are known to reduce the duration and intensity of diarrhea. Lactobacillus rhamnosus and Saccharomyces boulardii are the recommended strain which give the clinical benefit. The duration of the probiotic should be for 5 to 7 days and they should be started as early as possible while starting the antibiotic therapy. There is an update on zinc from the recent 2024 guideline from WHO that the reduced zinc dose can be used in children up to 14 days. 5 mg per day can be used. The dose was reduced in a view that there are episodes of vomiting during the zinc therapy. So it was found that 5 mg per day is also equally efficacious as 10 to 20 mg. But there is a conditional recommendation, not strong recommendation regarding this guideline. Green banana diet, this is a study published in BMJ. They have considered green banana diet. Green banana diet is known to cross the small intestine, undigested, reaches the colon. After reaching the colon, it gets converted into short chain fatty acid. This short chain fatty acids enhance the sodium and water absorption and also promote the mucosal healing and provide the energy to colonocytes. In future, we may get more studies recommending this green banana diet. Infant in having age less than 6 months are very tough to deal. It is very challenging to control persistent diarrhea in them. If they are found to have secondary lactose intolerance, they need extensively hydrolyzed formulas and elemental amino acid formulas. So we need a good center to manage such as mortality is very high in them. For prevention of diarrhea, this is a picture taken from Ministry of Health and Family Welfare. Hand hygiene, food hygiene, and hygienic surroundings and more usage of toilets, exclusive breastfeeding, complementary feeding on time, vaccination for rota and measles, and vitamins A supplementation can reduce the chances of persistent diarrhea. Take home message, persistent diarrhea is often initiated by infection, but its persistence is due to multiple interacting factors including malnutrition and mucosal damage. Therefore, management requires a comprehensive approach rather than just the treatment of infection. Thank you so much.
Time for questions.
Thank you, Dr. Priya, for a very concise and specific diarrheal management. Do you recommend any other, you have already mentioned about the probiotics of choice, but there are a large number of probiotics being used in combination as well. So do you recommend some specific guidelines for that, number one?
Yes, sir. In InfeCON, they have mentioned like Bacillus clozi. They are saying if it is associated with abdominal pain, then we can go for Bacillus clozi. Like we are using suspension Enterogermina and other. For using Saccharomyces boulardii and all, we have Darolac. So there are different indications. Infantile colic, they recommend different probiotics. So different recommendations there.
Thank you. And number two, the use of zinc, how long can it be used? Because sometimes the duration of diarrhea is a quite long time. And we have already started with zinc and it is almost 2 weeks there. So do you recommend to continue it or there is a specific time period for that?
No, sir. For gut repair, they are saying should supplement only for 14 days, not more than that. And reduced dose is showing similar efficacy. So we can use 5 mg per day in children who are having vomitings.
Thank you. Thank you very much.
Thank you, sir. Thank you so much.
Thank you so much. If there are no more questions, we would like to move on to prize distribution for poster competition held. Thank you. The second prize goes to Dr. Badal Gondane from SAMES Indore on the topic, a study of correlation of EPRI score and FIB4 index with the severity of esophageal varices in liver cirrhosis patients. I would call Dr. Sanjay Kumar sir to hand over the prize. Thank you. And the first prize goes to Dr. Afreed Gori from Gandhi Medical College, Bhopal on the topic evaluation of minimal hepatic encephalopathy using FES and its relation with child-pug class. I invite Dr. Chobal sir to hand over the prize to Dr. Afreed Gori. Anybody from the audience who knows Dr. Afreed or any batchmate can come and collect the prize. Anyone? Okay. By the time I call Dr. Sandeep. Next, I call upon Dr. Sandesh Sharma sir for the vote of thanks.
Very good afternoon. It is customary to propose vote of thank, and I have been given this task to propose vote of thanks to all of you who have made this conference our big update InfeCON 2025 and 2026 a very grand success. First of all, I would like to thank all the participants, our delegates, our speakers, who came all the way and delivered a very scientific content during the course of these 2 days of conferences. As we say that all great achievements cannot be made without the great appreciation, I would like to appreciate and convey my best wishes to the team GastroCare who stood and made this conference a very success. It's been since last 11 years we've been holding these conferences on a regular annually basis. And every time the standard of a conference is been going up and up and up. So I must congratulate our director, Dr. Sanjay Kumar, our mentor, Dr. C.C. Chaubal, Dr. Neetu Kumar. I would like to special thanks Dr. Kshitiz, Dr. Akansha, who came all the way from Odisha, and despite having a very, very limited time, they've given every hour, every minute to make this conference successful. It would be not nice not to mention few names, but I would like to especially mention our team of GastroCare, right from the administration to the finance department to the housekeeping department. Everybody has contributed making this conference a very grand success. Last but not the least, our pharmaceutical partners, the industries who has immensely supported this conference and made this event a very, very successful. Thank you very much, and God bless GastroCare and his team.
I would invite everyone for a photograph here.
Sorry to interrupt. Our first prize winner, Dr. Afreed Gori, is here to collect his prize.
Okay.
So I would call upon Dr. Chobal sir to please hand over the prize.
I would also like to thank Dr. Atul Kataria for nicely conducting the inaugural ceremony yesterday.
Yes, certainly.
And all the master of ceremony, including Akshay, and Naveen was here all the time. Mayank, who took pains to look after the poster session. And of course, Mr. Divedi and entire team of admin, which Sandesh has mentioned. Thank you. I would request everyone from the organizing team to come here for a photograph. And then, of course, one photo with all of those who are still present. Please come. Thanks to audio-visual team, Gaurav and company. Though we had some hiccups yesterday, it was pretty smooth today. And our photographers, Faruqi and brothers. Dr. Chuk can join us on stage. Please come. I would now request Dr. Kataria, Dr. Iqbal, Alok, whoever I can see in this slide, please come. So all the doctors who are still around, please join us for a photograph. Kamlesh, Rakesh. We'll have another photograph with pharma people, but maybe others can join. All the pharma people can come. Would also like to thank Mr. Vinod and entire staff of the Jahanama for all the help. All the pictures are available on all the WhatsApp groups. You can just click and you will get all the photographs, courtesy Farooqi ji.